शुभम करोति कल्याणम आरोग्यम धन संपदा शत्रुबुद्धि विनाशाय दीप ज्योतिर्नमोस्तुते. Salutation to the light of lamp which brings auspiciousness, health and prosperity. I request all the dignitaries to come forward for lamp lighting. I request our chief guest, Chandravati ma'am, the guest of honor, Dr. Haresh, and our secretary, Sir Swami Muktinathananda ji, to come on the dais for the felicitation ceremony. Now I request our secretary, sir, to felicitate our chief guest, Madam Chandravati. We are so grateful to ma'am who could come and grace us for inauguration ceremony despite her so hectic schedule. Now I would request Head of the Department of Vivekanand Polyclinic, Gynae and Obs Department, Dr. Vishali Jain, to felicitate our guest of honor, Dr. Haresh sir. We are so glad, sir, that you have come from Mumbai to here to give us a new enlightenment about the hysteroscopy and its various aspects. I request Dr. H.P. Gupta ma'am to felicitate our secretary, Swami Muktinathananda ji. I feel very delighted to invite Swami Muktinathananda sir for his welcome address. Words fall short for describing his commitment towards devotional services for the humanity. He is always so inspiring, so supporting and encouraging us for anything new we want to do or start. Welcome, Swamiji.
जननीं शारदां देवीं रामकृष्णं जगद्गुरुं पादपद्मे तयोश्चित्वा प्रणमामि मुहुर्मुहुः। नमः श्री जतिराजाय विवेकानंदसूरये सच्चित् सुख स्वरूपाय स्वामिने तापहारिणे। I am extremely happy and honored to be present amidst a highly excellent people in their respective fields of achievements and participate in this live workshop on the operative hysteroscopic procedure for enlightenment of our professional gynecologists of this region. I am encouraged to note, though our expected number of participants were around 75, but we have already more than 130 registrations. So that shows the deep interest of the gynecologists for learning this procedure, which is not very common in this region. We are extremely honored to have the august presence of a person like Dr. Chandravati, who is a legend even while she is alive. She has been in close touch with us, and we have received his cooperation and guidance from a very long time. And I pray to the Almighty that she is endowed with a long life full of vigor and glory, so that she may continue to shed her lustre among the young professionals in this field. We are extremely fortunate to be able to have Dr. Harish Vagashia from Apollo Hospital, Mumbai. This hysteroscopic procedure is no doubt a difficult procedure, but I never thought that it needed such a depth of expertise, for which Dr. Vageshia had to go all the way to Italy and take 1 full year training in this field. So we are extremely fortunate to have such a highly advanced hysteroscopic surgeon amidst us for guiding this live operative workshop. I am also extremely thankful and heartily I welcome them, our learned faculty, Dr. Sunita Chandra, Dr. Uma Singh, Pushpa Jaiswal, Ritu Saxena, Renu Mekar, Fatima Shiva, H.P. Gupta, and Sumita Arora, Nisha Singh, and our faculty of our institution. But my hearty welcome goes foremost to the participating gynecologists, those who have come at the feet of Swamiji to have this wonderful session of very short but rewarding training. We'll try to make this short workshop as professional as possible, as enjoyable as possible, and we seek your cooperation. Our success will be if you can go back to your individual institutions and try to replicate in this procedure, which is a safe procedure, very short duration. The patients may come and go back on the same day, reducing the cost of surgery, time of surgery, risk of surgery. We must advance in such modern technologies, and Swami Vivekananda was the foremost in pronouncing the excellence of education. He said that education is the panacea of all evils. If you can educate someone, then all the problems get resolved automatically. His spiritual mentor Sri Ramakrishna said in Bengali, Javod machi tabod shikhi. As long as I live, so long do I learn. There is no end of the learning curve. But the reverse of this proverb is also equally true. That is important for the professionals. Javod shikhi tabod machi. As long as I learn, so long do I live. That is, if you want to stay abreast in your profession, you must keep your learning curve ablaze, or else you are outdated, you are rejected, and you are forgotten. The excellence must go hand in hand with learning, and our institute provides a wonderful platform for exchange of education, exchange of learning, just for the sake of the enhancement of the subject. I heartily welcome you all from the bottom of my heart and pray to the Almighty to shower His choicest blessings on us all. We have come for a very fruitful interaction and make their mission a fruitful and successful and a remembering event in their life. Thank you.
Thank you, Swamiji. And I must tell here that Swamiji has always encouraged us to remain abreast with the most modern and latest technologies, and we are very glad to say that we are doing all kinds of advanced endoscopy, high-risk cases in ops and everything, whatever is possible. So thank you, Swamiji, for providing us with this platform. Now, no program, at least in Gynae fraternity, is complete without the Ashirvad from the teacher of the teachers, the legend, as Swamiji said herself, Professor Chandravati ma'am. Ma'am has so many achievements to her credit that we will fall short of time. So we are very fortunate and grateful to ma'am that ma'am has come over here to bless us. Ma'am, please.
At the outset, I must thank Swamiji for having me here. My connection with this institute is a very, very old one. I had been here as a DNB teacher for a long time, and I used to come and do DNB teaching. I've attended many seminars, many workshops in the same hall, and I thoroughly enjoyed all those seminars and workshops. So thank you again for having me here today, and I thank Vaishali and Sonu again for really pressing me to be here present today, because I had to go early in the morning, but I said I will come and visit you all and then go. I'm very pleased that the faculty has thought of holding this hysteroscopy workshop. You all are aware is in gynae practice. I think I remember our days when we did not have any ultrasound, we did not have any endoscopies, and how many things we used to miss, and when we used to operate, and then we used to think we could have done much better if we had facilities to diagnose it in a different way. Today we have all the modern methods of diagnosing things, reaching to a concluding diagnosis for a patient, and unnecessary surgeries on the patients are avoided. Hysteroscopy is one thing which may look very simple, but is a very, very important diagnostic and therapeutic tool, which is useful not only in infertility workup, but it is useful also in most of the gynae practices, many gynae conditions, where you need to do it as a diagnostic procedure, and sometimes your therapeutic procedure as a hysteroscopy could even treat the patient for her long-standing problems. So I wish this seminar a great success. I'm sure they have chosen wonderful cases, and I'm sorry that I would miss the workshop, but I will have the proceedings from Vaishali or someone. They will naturally do the video proceedings of all the cases, and I will go through it also when I come back. And again, wish you all the luck for all your cases. I know it looks very simple procedure, but one has to be very careful while doing hysteroscopy, doing hysteroscopic procedure, because sometimes rare complications can occur if the surgeon and the team is not very careful. So I wish you all successful, all healthy workshop today. All your patients must do well, and when I come back, I'll hear about it. Thank you very much. Thank you.
Thank you, ma'am, for such golden words. As we know that one state level conference is also going on, so ma'am has to leave. Now I take this opportunity to introduce our guest of honor, Dr. Haresh Vaghashia sir. Sir is not only a great surgeon, but he is a great teacher. I am glad and fortunate to listen to sir on some occasions, and then it crossed my mind that someday I will be able to bring him to my hospital. I am very honored and glad to have you with us. And sir, we are looking forward for a great learning experience all throughout the day.
Good morning all. The words are going to definitely fall short, and after Swamiji himself speaking, a Das cannot speak anything. So, and of course, after teacher speaking, a student has to just absorb. So I think I will speak much better hysteroscopy, and will do much better teaching there rather than wasting our time here. So I would just not speak anything, but just thank you so much for having me, and we'll make this time fantastic in learning hysteroscopy. Thank you very much. Thank you, Swamiji. Thank you, madam. Thank you, Sonu ma'am. Thank you, Jain ma'am. Thank you very much.
Yes, sir. Sir likes to speak with hysteroscope in his hand. So now here we come to an end of our inauguration ceremony, and I'll see you in OT along with sir, and the rest of the session will be taken by Dr. Varsha. I request our chief guest and our guest of honor, all senior ma'ams, Dr. Vinita Das, HP Gupta ma'am, Anju ma'am is also with us, Renu ma'am, Dr. Sunita Chandra ma'am, please come and have refreshments.
Hello. Check. Hello.
Good morning. Good morning and regards to each and everyone present here. Honorable Swamiji, Secretary VPIMS, and all other dignitaries present here. Myself, Dr. Varsha, feeling immense pleasure on the behalf of Vivekanand's organizing team of this live operative hysteroscopic workshop, welcomes you all delegates and dignitaries present over here. Not wasting much of our time, let's head towards the first session of this workshop. First of all, we all must congratulate ourselves present over here, since we all are ambassadors of health, especially women's health. And wherein we are here to ease a woman's life by brushing and refreshing our knowledge and technical aspects of hysteroscopy, which is required during day-to-day gynecological practice. So first of all, feeling presence of Almighty Godfather, I invite senior most ma'am, who is renowned, eminent, Professor Vinita Das ma'am, and I myself is feeling honored to have you ma'am. Respected ma'am is consultant and advisor, Birla Fertility and IVF Center, Lucknow. Ma'am is ex-dean and head of Department Obstetrics and Gynecology Department of KGMU, Lucknow. She is also governing council member, NHSRC, Ministry of Health, Government of India, 2022-24. She is also vice president, ISOPAP, 2022-23. She is founder president of Lucknow chapter ISOPAP. Ma'am has received various international fellowships, FIGO and FOXY awards. She has also received DIPSI National Award for her GDM guidelines and has written more than 14 book chapters and have more than 150 publications in her name. And the list is so big, but in summary, ma'am is always a cheerful person with clear concepts and always encouraging. And in 1 to 2 lines, ma'am used to clarify his core concept of any seminar, any lecture, and which I have so much experience about that. Under her, I have done my jarship. Ma'am, please take your seat as chairperson. You are most welcome. Next, I take this opportunity to invite great academician, respected Professor Anju Agarwal ma'am. Ma'am is Professor, Department of Obstetrics and Gynae of KGMU Lucknow, and she is also Vice Dean Academics of KGMU Lucknow. And in her name, she has more than 100 national and international publications. Ma'am has presented number of papers in national as well as international conferences, and she has been winner of various awards. Ma'am was past chairperson in North Zone ISOPAP 2018 to 2020. She was past president Lucknow chapter ISOPAP 2017 to 2019. She is executive member ISOPAP 2022 to 24. Ma'am is vice president elect North Zone ISOPAP. Ma'am has participated as expert in making guidelines as for calcium supplementation, deworming, GDM and hypothyroidism in pregnancy. And the list of curriculum is long and is still continuing further. Other than this, respected ma'am has great knowledge of the subject and has the ability to take clear and beneficial judgments in critical and confusing clinical situations. And in person, she is so kind to always help you. Ma'am has already taken the seat. You are most welcome, ma'am. Now I request Professor Vinita Das ma'am to kindly introduce our first speaker.
So good morning everyone. It's my honor and pleasure to invite Dr. Vaishali Jain. I know her from the days when she was a resident in King George's Medical University in Department of Obstetrics and Gynecology, and she has done thesis under me. Now at the moment she is working as head and faculty for DNB, Department of Obstetrics and Gynecology, here in Vivekanand Polyclinic and Institute of Medical Sciences. She has got so many other responsibilities like working as treasurer LOCS, joint secretary LOCS, joint secretary AICOG 2020, and so many conferences to her credit where she has worked in different capacity. Today she will be speaking on setting up of a modern hysteroscopy unit. As we have heard in the morning that hysteroscopy has become one of the very important tool for diagnosis of gynecological condition and very important for infertility. We cannot work without having hysteroscopy. So it is very important to set up an hysteroscopy unit, and what instruments, what OT, what procedures, what type of lab technician, what are the things which can go wrong while doing hysteroscopy, and how it can be helped. So Vaishali, the floor is yours, and we are eager to hear you.
Good morning, everyone, and I welcome you all in this today's workshop. The topic is the live. Basically, we'll be seeing the live hysteroscopy cases, and as it is being discussed since morning, that hysteroscopy is part and parcel of gynec practice now. And with the patients choosing the endoscopic surgery, and they have become more aware of the endoscopic surgery, so it's the duty of a gynecologist to provide them with this service. And when we are practicing the hysteroscopy, when we are doing the hysteroscopy, we must be well aware about our instruments. So I am talking about setting up a modern hysteroscopy unit. What we'll be going to discuss, we'll be discussing about some intracavitary vision. For that we need video camera, light sources, light cable, endoscope, and video monitor and data archiving. Then to distend the cavity, we need distension media, which can be a non-electrolyte solutions or electrolyte solutions. And we need some supply methods which can supply this distension media to the uterine cavity. Then comes the part of the hysteroscopes, and now in the modern era, we are moving to office hysteroscopy. So basically, most of the procedure we can do in our outpatient department, and some cases which need to be sent to OT and to be done in the OT, and that is where we use the resectoscopes. So what is hysteroscopy? It allows direct visualization of the uterine cavity with the opportunity for targeted biopsy, safe removal of endometrial polyps, submucous fibroids, treatment of intrauterine septum and adhesions. So whatever the disease which is localized to uterus, you can deal with it. Even we are doing in scar pregnancy, we are doing hysteroscopy. For retained products of conception, we are now doing hysteroscopy. So hysteroscopy has role in each and every disease which is related to the uterine cavity. So as per the RCOG, there are 3 levels of categories of hysteroscopic surgeries: level 1, level 2 and level 3. Basically level 1 and level 2 you can manage at your outpatient department with the new instruments which are available. Level 1 is diagnostic hysteroscopy with target biopsy, removal of simple polyps and removal of intrauterine contraceptive device. Level 2 is proximal fallopian tube cannulation, minor Asherman syndrome, and removal of pedunculated fibroid, which is like type 0 or a large polyp. So basically level 1 and level 2 you can manage in outpatient, but for level 3, which is the division and resection of uterine septum, major Asherman syndrome, endometrial resection of submucous fibroid, which is type 1 or type 2, and repeat endometrial ablation or resection, that surgery you need to do in OT under anesthesia. So what are the instruments? We have to be prepared with all these instruments, and I must say that the quality of instrument is very important. Although your skill and experience does matter, but the quality has to be important, because many complications are happening when the quality of instruments are not good. Image management system, we need camera, light source and monitors. It has to be a medical grade monitor, not the normal monitor. Then hysteroscope will include the telescope. Hysteroscope is basically a telescope and inner and outer sheath. Inner and outer sheath is basically to flow the that is the distension media. So inner sheath is basically where the water flows, and then we can visualize the uterine cavity. Then resectoscopes are also there for the operative, for the high-end level 3 surgeries. Electrodes, bipolar and unipolar. Then we need some ancillary instruments like grasper, scissor, Fluid delivery system is very important, and then the generator. The generator is basically the cautery. If you are doing the resectoscopic surgeries, level 3 surgeries, then you will need a cautery or a generator to provide the current. So we have a variety of cameras, but I must say that 3D camera or the HD camera, mainly the HD camera will be suffice, and if you are planning for high end, then you can go for 3D camera. So video camera should have a good resolution, high sensitivity, high quality of video output, good signal to noise ratio, and easy sterilization. And single chip is sufficient, because if you are adding a 3-chip camera, it is adding to your budget, but not of much benefit. So if the single chip is good enough for starting, and once you have the basics things, then you can add luxury to your place, your instruments also. So light source is xenon light source and the power LED. Power LED is the latest one, although it is very costly, but it has a very high working life. Around 40,000 working hours it has a life of 40,000. While the xenon light source, which is being routinely used, it has a 500 working hours. Then light cable, we have many options, but the fiber optic cables are the best, and they are reasonably good. So we should have a medical grade LCD, mainly the 2D and the 3D monitors also. And the monitors should, in the era of medical litigation and in the era where the patients, they want their reports and they want to visit with that report to consult some other doctor. So it's better if you have a video monitor which can make our images and videos, and so that you are safe with for medical litigation also, and then you have a data archiving facility also in those monitors, in which you can collect all your data and then use it. So now come the main part, that is the telescope. Telescope is basically which allows the transmission of light to the anatomical site that should be investigated with the back of the camera. So this is the telescope, and here we will be putting the camera, and this is the light source. So this is the telescope, and when we add inner sheath and outer sheath over it, then it becomes a hysteroscope. Okay. So this is the camera. With this end, we add camera, and with this end we add the light source. So what is office hysteroscopy is basically the size of the camera, the diameter of the camera, telescope, whatever you are using. Initially, we have both the rigid and flexible telescope, but I must say rigid telescope is better. And there are several endoscopes with different angles, like from 0 to 70 degree, there are different telescopes. But for hysteroscopy, if you are like money constrained, then it's better to go for a 30 degree telescope, which will help you in diagnostic as well as operative procedures. And for resectoscope, if you can manage, then 12 degree is the best for level 3 surgeries and the resectoscopic procedures. So we have a rigid hysteroscope. The standard rigid is 4 millimeter, but that was way behind. Now we are having 2.9 and 1.9 millimeter. These are the mini rigid camera, and this is the backbone of office hysteroscopy. See, in office hysteroscopy, we are not using any anesthesia, we are not dilating the cervix, we are doing the vaginoscopic approach. So if the diameter is thin, then we are able to manage without dilating the cervix. For 4 millimeter rigid telescope, we need to dilate the cervix. Now the sheaths. So basically hysteroscope include telescope and the sheath that encompasses it. Inner sheath is basically for the inflow, and with only the inner sheath we can do the diagnostic procedures. But if we want to add some operative thing, or we want to do a little bit of more time we are taking in diagnosis, then we need to add the outer sheath. So this is basically your telescope with the light source and the camera end, And this is your inner sheath, which is having a this for inflow of the distension media. And this is the outer sheath. It can be without the operating channel. This is the operating channel, which is the 5 French, and through which we insert the operating instruments like scissors and forceps and punch biopsy forceps. And this is for the outflow. Basically, sometimes you need, beside inflow, you need to, that the media should come out also. So this is the outflow, and this is the operating sheath. It can be combined, like this is a 1 unit you can order, and you can do your basic level 1 and level 2 surgeries with these 3 instruments. And these are the ancillary instruments like a scissor or a grasper. So, diagnostic and operative office procedures. They are designed with an operative channel and a system of continuous flow irrigation. And it is possible to, and because of this office hysteroscopy, it can be done in ambulatory setting also. Like you can take your things and you can do in some other place also. We have 2 versions of this hysteroscope. One is 2 millimeter and other one is 2.9 millimeter. And it is all 30 degree. And the most important thing is it is of oval shape. Before these telescope, we were having the telescope which were basically having a round shape. So the visibility was not proper. With the oval shape, it has overcome all those difficulties. And both of them have a double sheath, one for the irrigation and one for the suction, and a 5 French operating channel. So basically it is a complete set with the inner sheath and outer sheath with an operating channel. You can, with the operating sheath, you can use different electrode also, the unipolar and the bipolar. Bipolar electrodes can be used in normal saline, that is 0.9% solution, while the unipolar electrodes has to be used in some non-electrolyte solution like glycine and sorbitol. And these are the list of some instrument which we can negotiate through the operative sheath, which is of the size of 5 French, and alligator forceps, the biopsy forceps, of the spoon forceps, of the pointed scissors. So it is the type of patient you are getting, you can order it, because you might not need all the ancillary instruments. If you are doing the procedure like scissor or a forceps or grinding forceps will be good enough. So what is hysteroscopy? It allows minor pathologies to be treated in outpatient setting, and which is see and treat. Once you are seeing it, and at the same time you are treating the pathology. It is a vaginoscopic approach, no cervical dilatation, no pre-medication or anesthesia. And it is, we can do both the level 2 and level 1 and level 2 surgery, that is both the diagnostic and operative. So just to summarize, for office hysteroscopy, you need a monitor, light source, light cable, camera, telescope of 2.9 or 1.9 millimeter with 30 degree angle, and a continuous flow operative sheath. That is the final diameter of this whole system will be 5 millimeter. Then that way you won't need to dilate the cervix. And the 5 French mechanical instruments you can use, you can scissors, alligator forceps, then you bipolar and unipolar electrodes you can insert on this operative sheath. The approximate cost, if you are going for a good company, so it comes out to be around 5 lakh. So your initial investment is good enough, and then I would say you should go for a good company telescopes and operative sheets. But you can somehow little bit be stingy on the operative instruments like the scissor and the grasper, because they tend to, even if with the good company, they tend to get damaged. So now comes the when we have to do the level 3 surgeries, which are the major surgeries in hysteroscopy. That has to be done by the resectoscopes, and it has to be done in an operation theatre. The anesthesia of choice will depend upon the anesthetist, but you can do in spinal anesthesia as well as general anesthesia. And the most commonly used are 22 French, which is the 7.3 millimeter, and 26 French. And we can use both the unipolar and the bipolar energy with these resectoscopes. So the typical resectoscope is the one. This is the typical resectoscope. You have an for camera, for light source. This is the basically the working element is there, and then a outer sheath and inner sheath. This is for inflow, outflow, and this is for the working channel. And these are all the leads you will need while doing the resectoscopy. Like the Collins knife is there, then the ball electrodes is there. So, and recently mini resectoscope is there, which is 15 French. Although in Lucknow it is not available, but in India it is available from different companies, which is 15 French. So for resectoscopy also, see, if you are using a 20 French or a 26 French, that is like around 8 millimeters. So you need to dilate the patient. The cervical dilation has to be done. But if you are using the 15 French, then you need not to dilate. But I would suggest, even with the 15 French, it has to be done in OT. So what is the most important thing is intracavitary distension media. There are two, initially it is basically to allow a complete overview of the inner surface of the uterine walls and tubal ostia, and they are mainly gaseous and liquid, and mainly liquid is nowadays used, available in 3-liter bottle. Non-electrolyte solutions are glycine 1.5%, and the electrolyte solution is normal saline, that is 0.9%. With glycine, it is the distension media which you have to use in unipolar. But for bipolar, you have to use the normal saline. See, the difference is with the glycine there are increased chances of cerebral edema, hyponatremia. So it is best to avoid these kind of media. There comes a role of bipolar electrodes. So what are the devices to supply the liquid distension media? We have a gravity method. In the see, this is the normal one which we are using in our hospital. It is a gravity method, and with a pump attached to it, so that with gravity there is some pressure, and with this pump the pressure increases. So with this system we have a 70 to 80 mmHg of pressure, which is good enough for all the procedures. And then you have this pressure cuff, which is like a sphygmomanometer. You put a bottle in it. Definitely the 3-liter bottle will not come in this, so you need a 1 liter of normal saline or 500 ml of normal saline. Then you can keep it inside, and then you can inflate for the pressure. Then comes the Hysteromat, which is the dedicated microprocessor, electronic control, irrigation and suction. In this system, both the irrigation and the suction is happening. And this is good in the case of resectoscope, because during resectoscopy we need to monitor the inflow and the outflow diligently. This is the pressure. Basically the outside pressure is 100 mmHg. So in uterine cavity we need to have a pressure which is less than 100 millimeter of mercury, so that there is no extravasation of fluid. If the extravasation of fluid is happening, then it can lead to cerebral edema, pulmonary edema, and all those things. So what are the options, whether we should go for a unipolar or bipolar instruments? Definitely bipolar instruments are safe, because we can use in normal saline, and the current pass between the two between the two jaws is very less. But for in the unipolar we are using the non-electrolyte like glycine, and also the current flow is very high in this unipolar system. So generator is the important thing. If you are planning to do a level 3 surgery, then you have a cautery. The cautery should have a unipolar, bipolar electrodes for underwater cutting, because all the cutting which we are doing is in underwater because there is a flow. Then trolley, beside this, even if you are doing the office hysteroscopy, you should have all these things on in your trolley: Sims, speculum, sponge holder, ovum, forceps. All these things should be there, because you might need it during office hysteroscopy also. How to clean and sterilize, and because the maintenance of instruments is very important. They are very delicate, they are very flexible, especially the operating instruments, like the 5 French instruments are very delicate. So after each operation, you should clean it and then disinfect it with bacillite solution. And the endoscope must be dried with cotton pledgets soaked in 90% alcohol. We can put them in, if our instruments are autoclavable, we can autoclave them, or we can do the gas sterilization. But in your practice, or what we are doing in our practice, we are soaking those instruments in the Sidex solution for 20 minutes. Then we are cleaning it, and then we are putting it in formalin chamber for overnight, or whenever till the time we are using it. So in between the cases, we are putting the hysteroscope and all those things in Sidex, and after washing in the normal saline, you can use the instrument, and when you have to store it, keep it in a formalin chamber. So these are some modern. We'll be showing you the 19 French IBS system. That is the intrauterine Bugatti shaver. As you all know, the morcellator is being not allowed even for the fibroids, laparoscopic surgery. So initially we had a morcellator, we were having a morcellator, but this is an intrauterine Bugatti shaver. Is a mechanical shaver. Basically it is using the mechanical energy. And these are all the new things which have come up. We have a new integrated work system. You don't need to, which is ambulatory, you can use in your OPDs. And this is the Telepex LED, which is basically a monitor, the cable, all these things are integrated, and you can use it if you are visiting to some place and doing the surgery. You can very well use it. And we can use the laser also through hysteroscope. So basically the high-tech hysteroscopy unit should be able to carry out diagnostic and up to level 3. Basic height for high-tech, it has to be level 3. And the level 3 surgeries include this. So thus, to conclude, in order to achieve a best possible outcome of the operation, the surgeon must be thoroughly familiar with the instrument and know the equipment's layout preferably, because it will prevent and control a series of snags and malfunctions occurring during hysteroscopy. So the way to success is the way of continuous pursuit of knowledge, and we all have gathered here to pursue the knowledge in hysteroscopy. Thank you so much.
So thank you so much, Dr. Vaishali. It was an excellent talk and really brought out all the nitty-gritty of setting up a hysteroscopy unit, because these are the things which everyone who's planning should know: which instrument to purchase, where they can cut costs, which one they have to spend on. So thank you very much.
Thank you. Any questions? I think we'll be showing you in the OT also, so be prepared with your questions, okay?
So now it is my pleasure to introduce my dear friend Dr. Sunita for the next talk. She is Director, Rajendra Nagar Hospital and IVF Center. नहीं, पर थोड़ा सा बता दें. And she is past President APGL, Founder Joint Secretary IFS, Secretary IFS UP Chapter 2020 to 2022. Received many awards. Honored with the Gomti Gaurav Award, Sanyokta Mahajan Memorial Award, Chikitsa Ratna Award, and very many more. So welcome, Sunita, and we really look forward to hearing from you the role of hysteroscopy in infertility.
A very good morning to all of you. Congratulations, Dr. Vaishali, Dr. Sonu, and the whole organizing team of Vivekananda Polyclinic, Vivekananda Institution, for organizing such an important workshop, which is actually needed nowadays for our youngsters. So as Dr. Chandravati said, that we are the generation, I mean she was that generation, and we also did our MD without ultrasound. I mean, don't think about endoscopes, laparoscopy or hysteroscopy. It was only and only clinical sense. We never had ultrasound in our hospital. Even in the city, there was only 2 ultrasonologists available at that time when we did our MD. But I am really thankful to all my teachers who had inculcated so much of clinical sense with us that even today we are not only depending on the diagnostic things. We actually look for clinical things also, whether this is correlating clinically and diagnostic evaluation. Is it there or is it not there? So, thank you, chairpersons, Madam Dr. Vanita Das. She is, whatever I am here, I am today is because of our great teachers like Dr. Vanita Das. Thank you, ma'am. Thank you for being here for this session. And my dear friend, पेन ड्राइव चाहिए क्यों? आ तो रहा है, उस पे भी तो आ रहा है. देखो एक मिनट रुको तो. अच्छा ठीक है, तो पेन अच्छा. Okay. Sorry for inconvenience. Actually, I had given my laptop in the beginning only so that he could have done it. But anyway, now we are here. So, I will be talking about role of hysteroscopy in infertility. my talk actually has been done a little better because of Dr. Vaishali's talk, because she has already explained the instrumentation, the OT setup and everything about basic hysteroscopy and operative hysteroscopy also. So friends, I must say one thing, that whenever you are planning for hysteroscopy, it is okay that you go for office hysteroscopy, but I think it is always better to plan diagnostic and therapeutic, that is diagnostic and operative in one sitting. Maybe the patient is in the theater under GA, but that becomes easy, because once you diagnose the thing and then you tell the patient that, see, you have a septum, you have a polyp, and now you come on Thursday for your operative hysteroscopy. In our setup, at least in private setups, we always plan to do it diagnostic and operative in the same sitting, because we have already diagnosed the pathologies and then we go ahead with diagnostic and operative in the same sitting. So this is hysteroscope, which she has already showed in the previous talk. I will start my talk with a paper. What is the role of hysteroscopic surgery in the management of female infertility? Query. See, there is a query about it. So I started my talk because of this, because there is still lots of controversies. A review of the literature. The position of hysteroscopy in the management of infertile female remains under debate. It is still under debate. Although we know that the procedure is well tolerated and effective in the treatment of intrauterine pathologies, but there is no consensus on the effectiveness of hysteroscopic surgery in improving the prognosis of subfertile women. More randomized control studies with adequate controls are required to actually say that it is effective, that we get more live birth rates. I mean, you get more pregnancies, but to say that you get more live birth rate is still very, very controversial. Structural abnormalities of the uterine endometrial cavity may adversely affect the uterine reproductive outcome. All of us know that, by interfering with implantation or causing spontaneous abortion. Therefore, evaluation of the cervix, endocervical canal, uterine cavity and fallopian tubes becomes an important step in the infertility workup. So, all of us know what is infertility and the causes. 1 in 7 couples suffer from infertility. Causes may be in the male, in the female, and if we talk about, and maybe in the both, or maybe some unexplained factor. If we talk about female factor, the uterine factors make actually a big chunk of causes, that is 10%. So, we have to look for these causes. Hysteroscope, what is it? She has already told what is hysteroscope. Is just a telescope which is visualizing the uterine cavity. Why it is called hysteroscope? Because it is in the uterine cavity. And this is the history of hysteroscope, and the evolving, this was evolving right from 1807, and in 1996 we got Bitoshi developed first office operative hysteroscope. So the ASRM guidelines, what is it for hysteroscopy in infertility? Hysteroscopy is the definitive method for diagnosis and treatment of intrauterine pathology, but because it is costly and invasive, the method for uterine cavity evaluation, it should be reserved for further evaluation and treatment of abnormalities defined by less invasive methods such as HSG and sonohysterography and transvaginal sonography, MRI and all. So basically what ASRM guidelines are here is that you should not put each and every patient for hysteroscopy. There has to be a patient who should go for hysteroscopy. Not all the patients of infertility should go for hysteroscopy. This is again very good green top guidelines, RCOG, that basically these guidelines are that the choice of anesthesia even for office hysteroscopy should be discussed with the patient. It is not that every patient can be done under local anesthesia or cervical blocks. You should always discuss the pros and cons of the anesthesia before going for hysteroscopy. This is important. What are the indications? Whenever we are going to do any surgery, we should be very clear what are we going for. Actually, what are the indications? Why is our patient in the OT? What is the pathology which we are going to look for? So, abnormal HSG, that is filling defects like polyp, fibroid, adhesions. Uterine anomaly is the most important cause. proximal or distal block of the tube, loculated peritoneal spill, hydrosalpinx. If we talk about uterine synechia, they may be mild, moderate or severe. Suspected intrauterine pathologies like polyp, fibroid, adenomyosis. Congenital uterine anomalies are very, very important. Separate uterus, bicornuate, unicornuate and diadelphus. Recurrent pregnancy loss, even if we are not able to find out anything in transvaginal sonography, I think it is better to go to look in the uterine cavity before allowing her for further pregnancy. Others like misplaced foreign body, you have the retained bony fragments and impacted or transmigrated intrauterine contraceptive device. Office hysteroscopy, as Vaishali said, it can be done in your outdoor setup. It is just that the hysteroscope is only 2.5 mm and it doesn't give much pain. You don't need to dilate the cervix and it is ambulatory, so it can be done in your outdoor procedure. Operative hysteroscopy, usually we are doing for polyps, submucous fibroids, uterine septum, synechia, misplaced or embedded IUD or any foreign body, and tubal cannulation. So for infertility, this was a very good study where higher pregnancy rates were seen after the hysteroscopic removal of endometrial polyps, submucous fibroid, uterine septum or intrauterine adhesions, which are detectable in 10% to 15% women. This was published in American Journal of Obs and Gynae, and the conclusion was that if it was performed concomitantly with laparoscopy, hysteroscopy becomes the most effective technique for evaluation of the uterine and tubal conditions that may play a role in female infertility. So, once we have decided that yes, this patient needs hysteroscopic evaluation, hysteroscopic surgery, then what are the actual things which we are doing on our day-to-day practice? So one is septum, which is very, very common. Second is submucous fibroids, intrauterine polyps, and we have adhesions nowadays. More and more patients are coming with synechias, and these bony fragments which have been there because of previous second trimester abortion. So these are the commonest indications where we are doing hysteroscopies in our infertility patients, and recurrent implantation failure is another very important indication, and recurrent pregnancy loss, early recurrent pregnancy loss or even second trimester pregnancy losses. This is important to look into the uterine cavity why this patient is not continuing her pregnancy. So if we talk about uterine septum, this is the most common uterine Mullerian anomaly, and uterine septum can interfere with reproduction in about 25% of patients. Reproductive outcome decreases, spontaneous abortion rates are very high, premature labor is also high, fetal survival is less. Spontaneous abortion after resection is 5 to 9%, that means it decreases a lot. So this is actually important to go for septoplasty hysteroscopically to have a good uterine cavity. So actually what happens is that we ask the patient to go in the theater, we take the patient to the theater and we do this diagnostic hysteroscopy first, and then we see where is the septum, whether it is only fundal, whether it is complete septum right from the internal os, and then accordingly we plan our surgery. So this was a complete septum right from the internal os, and this is just last week, complete septum from the internal os. It was just dissected by the scissors, and this is the last slide, last picture, where it is showing that the cavity, now that there is, the septum is not there and the cavity is 1 and the cavity size is increased. Actually what happens is when we do septoplasty, septum resection, and you see in the beginning the cavity size is small because of the septum, division of the uterine cavity. Once you do septoplasty, once you do septum resection, and you can immediately see the size of the cavity increasing after the resection of septum. Let's see the clinical evidence in favor of hysteroscopic metroplasty. So this was clinical evidence, hysteroscopic metroplasty, reproductive outcome in relation to septum size, retrospective and comparative cohort study, where 112 non-parous patients were treated for partial uterine septum by hysteroscopy, and it was seen that hysteroscopy metroplasty in cases of partial uterine septum and infertility significantly improves the reproductive performance, irrespective of septum size and independent of previous obstetric history. And this was American Fertility Society, which says that in some group of patients, it is important to resect the septum to have a better outcome in her future obstetric career. So now if we talk about submucous leiomyoma, all of us know that these interfere with the implantation only. These patients may present to you with intramenstrual bleeding, with heavy bleeding, with recurrent implantation failure or with recurrent abortions. And these patients are actually being diagnosed only by transvaginal sonography. Sometimes you need MRI to map. If you have multiple submucous fibroids, then mapping of fibroids is very, very important. And as he said, nowadays even bigger fibroids can be done with hysteroscopy in one sitting, not with the morcellator. The other unit was, what you said, the other unit? Okay. So that can be dealt with. I have not done that, I have not used that, but hysteroscopic morcellator I have seen, but not this new unit. So hysteroscopic myomectomy becomes important in these cases where you have diagnosed submucous polyps. So these polyps which are directly into the cavity is easy. More than 50% in the cavity, then again it becomes very easy to take it out. This is pedunculated submucous fibroid, which we just cut the pedicle, and this fibroid comes out on its own. There is no need to take it out by the grasper or anything. No need to cut it. You just put a mesoprost 400 milligram, and this fibroid comes out on its own within 2 to 3 days. Second thing, one is for pedunculated fibroid. Second is for 2.5 millimeter to 3 millimeter. That means less than 3 centimeter submucous fibroids. We are just doing cruciate incision, which are actually projecting in the cavity. We just make a cruciate incision. We do the extra excavation of the fibroid, and we put a mesoprost 400 milligram vaginally for 2 days, and this fibroid comes on its own. Call the patient after 7 days or 8 days, and you can see the cavity clear of the fibroid. So that's again important because you are not doing resectoscopy in these patients. Why? Because the more you are doing surgery in hysteroscopy, the more you are putting your patient under risk for fluid overload. And that's very, very important, friends. Dr. Chandravati said that I wish that your conference should be successful and your patient should be safe. Yes, friends, patient safety is very, very important because you feel that it's a very small procedure. I mean, you just take the patient and you tell the patient to come in the morning and go back in the afternoon, just after 4 or 5 hours. But then there are risks for each and every procedure when the patient is going into the OT. With hysteroscopy, this is the most important thing, embolism and fluid overload. So if you can go away with a lesser time, it is important. Challenges are large submucous myoma, thorough pre-evaluation with mapping of fibroid, complete excision of fibroid may be done in 2 steps, yes. Even for the bigger septums, like I did last week, the septum which was running from internal os up to the fundus, I told this patient that I will be seeing you after 1 month or so to see whether this septum resection is complete or not, because instead of taking too long, it is better to go for 2 sittings, and this is also true in cases of submucous fibroid which are larger. So where 2 or 3 sittings may be required to go for the complete excision. So what is the clinical evidence? Again, in favor of submucous leiomyoma, hysteroscopic myomectomy might increase the odds of clinical pregnancy in women with unexplained subfertility and submucous fibroid, but the evidence at present is not conclusive. This is about polyps. All of us know that these polyps interfere with nidation of or appropriate growth and development of an established pregnancy. That is why we want to remove. And all of us know that there are so many polyps which are lying down in the lower part of the cavity. They go unnoticed. We don't even diagnose them, and patients do conceive, and go to term. But the fibroids, the polyps which are hanging down right in the fundus on the lateral walls in the upper uterine cavity, it is better to remove them because they actually interfere with the implantation process. So if the patient is having recurrent implantation failure and you don't know what is there, then it is better to see in the cavity and there may be some polyp or septum lying down. So this is a pedunculated polyp, easy to remove, very easy. You just cut the base and take out with the grasper. But this is sessile, completely sessile polyp on the posterior wall. It is little difficult. The sessile polyps are little difficult to resect and take it out because there is no base, there is no pedicle. So it is little difficult, but once you start dissecting it, it becomes easy. Again, the clinical evidence is in favor, but it says that the polyps, if it has been diagnosed before doing the surgery, it is much better. The clinical pregnancy rate definitely are better. Intrauterine adhesions. These patients usually present with primary amenorrhea, hypomenorrhea, primary infertility, secondary infertility. And because there are adhesions, whether it is mild, moderate or severe, they interfere with the implantation only. These patients do not have implantation, and that is why this treatment is very, very important to cut all these kinds of synechia, whether this is filmy or thick synechia, it is important. This is a very important, very nice picture where you can see multiple granular granulations. This all is caseating granulations. So this patient had adhesions also, and this patient, the cavity was studded, I mean anterior, posterior, all lateral surfaces with these kind of granulations. The laparoscope was also put in this patient, and there also there are multiple caseating nodules and multiple tubercles, and plastered peritoneum was seen in this patient, and the histopathology confirmed that it is tubercular, and patient was started on ATT. These patients are actually very good patients because if they are diagnosed in time, you can improve their fertility potential. For tubal occlusion, I have not done a single tubal occlusion in my practice, but it is said that cornual occlusions really do well when you are taking it with the hysteroscopy. So it is very easy to pass the cannulator and do this cannulation hysteroscopically. It is better to put a laparoscope on the same sitting, because once you are doing laparoscopy, hysteroscopy, you are more satisfied, and it is better to go with the laparoscopy and hysteroscopy, and you know that you are doing things in a better way. So if the HSG shows that there is cornual occlusion, this may be because of spasm only. So it is better to go for hysteroscopic cannulation, and it has been seen that in many patients, one tube becomes patent after hysteroscopic cannulation. Foreign bodies. I have seen lots of patients with multiple bony fragments presenting as calcified spots in transvaginal sonography. They will come with multiple ultrasounds, calcified spots in uterine cavity, and when you put a scope, you see that there are multiple bony fragments which are there because of the second trimester abortion in previous days. And blind removal is very, very difficult, so hysteroscopy is used for this complete removal. So this is bony fragments, you can see. This is bony fragments, this is bony fragments, and this was a lost IUCD. Basically only the one arm was seen in the uterine cavity, and other arm was totally embedded into the myometrium. So these patients actually have problem in conceiving, where you have foreign bodies, because implantation will not be possible. Even if implantation is there, the pregnancy will not continue. Same likewise the IUCD. Because if IUCD is there and you cannot see the thread, you cannot take it out. You have to take it out if the patient wishes to get pregnant. Even if she doesn't want to get pregnant, it has to be taken out, because it is now perforating the myometrium, but it can perforate further also, and it can go into the abdominal organs. So that is why it is important to remove the lost IUCD. Now comes the important thing, that is hysteroscopy prior to ART. So The guidelines are there for this. Some guidelines are in favor, some are not in favor, that you should not do a routine hysteroscopy in all ART patients. This is everywhere. Every study says that yes, it is important to go for hysteroscopy in patients where you have diagnosed something by transvaginal sonography or HSG or MRI, or the patient is of recurrent implantation failure, or the patient is of recurrent abortions. So currently the gold standard technique for uterine factor evaluation is hysteroscopy, since it enables direct visualization of the uterine cavity and its relevant pathological disorders, as well as the treatment of the detected pathology at the same time. According to NICE guidelines, women should not be offered hysteroscopy on its own as a part of initial investigation unless clinically indicated, because the effectiveness of surgical treatment of uterine abnormalities on improving pregnancy rate has not yet been established. This was a very nice meta-analysis and systemic review in 2019. It was a robust, systemic review, meta-analysis, where 3 RCTs, 3 non-randomized prospective studies and 2 retrospective cohort studies were included. It was seen that hysteroscopy improved the implantation rate, clinical pregnancy rate, but failed to improve live birth rate and did not affect the miscarriage rate in women with recurrent implantation failure undergoing IVF. Since hysteroscopy plays a significant role in pregnancy and birth outcomes of women with recurrent implantation failure, further studies are warranted. This is again a very nice study where this systemic review and meta-analysis was done. 7 studies were included, and again there is moderate quality evidence that hysteroscopy increases pregnancy rate if performed before IVF regardless of intrauterine anomalies. Low quality evidence that hysteroscopy may increase pregnancy rate when removing submucosal fibroid or endometrial polyps. Robust and high quality RCTs are still needed to say that hysteroscopy can be regarded as a first line procedure in all infertile women. This was a very nice paper that I have taken it. Sensitivity of diagnostic hysteroscopy is significantly higher than TVS and HSG in the diagnosis of intrauterine lesions. Diagnostic hysteroscopy should be performed before ART in all the patients, including women. So this is in favor, because they say that there are multiple things which are not diagnosed either by TVS or by the routine examination. So according to this paper, all infertile patients should undergo hysteroscopy. This is a very recent trial. Routine hysteroscopy does not improve live birth rates in infertile women with a normal transvaginal ultrasound of the uterine cavity. So women with a normal transvaginal ultrasound should not be offered routine hysteroscopy. Outpatient hysteroscopy before IVF in women with a normal ultrasound of the uterine cavity and a history of unsuccessful IVF treatment cycles does not improve the live birth rate. Further researches are required to say that yes, it improves clinical pregnancy rate. As for any procedures, there has to be some contraindications. So viable intrauterine pregnancy, any cancer,
Sunita,
infections.
we have started the OT.
Okay. So I'm done with it. I just wanted to say the risk, as I said, infections, hemorrhage, but the most important is fluid overload and embolism. So thank you, friends. Hysteroscopy is considered the gold standard. Although it has not been proving, hysteroscopy might be beneficial for some infertility cases, and we need more randomized control trials to say that patients should undergo hysteroscopy before any infertility procedures. Thank you so much.
Sunita, it was a very wonderful presentation, and you have covered all the aspects of hysteroscopy for an infertile patient. But you should not do the hysteroscopy only in all the patients of infertility.
As a primary procedure, yes.
If you are finding any symptoms or any suggestion by ultrasound that there is something in the uterus, then hysteroscopy is a must.
Yes.
And hysteroscopic removal of this polyp, uterine synecdoche, and especially retained product of conception. I have found many patients, after removing these bones from the uterus, they become
Conceive-
pregnant.
yes, they conceive on their own.
conceive
Yeah.
immediately
Yes,
in the
yes,
next
yes.
cycle or the after that. So hysteroscopy is a very good tool
Yes.
for infertility, but should be done cautiously because it has got its
Yes,
own
every
problems.
procedure has its own risk.
Yes.
So that is the message I wanted to give, that it is not that every infertile woman has to undergo hysteroscopy, but yes, it is important.
And fluid monitoring is a
Yes,
must.
fluid overload and
because
embolism too
fluid
are very
overload is the most common
Yes.
cause of death in
Yes.
hysteroscopy.
Yes, so actually these
Thank
two
you.
messages are very important. Thank you, ma'am.
So thank you everyone. We have come to the end of this first session. Both the talks were excellent. Thank you
Now-
so much.
Now I request our chairpersons to please felicitate our speakers. Professor Vinita Das ma'am, please Dr. Indu Tandon ma'am, please felicitate our speakers, Sumita Chandra ma'am and Vaishali ma'am. Please come ma'am. Professor Vinita Das ma'am, Anju Agarwal ma'am, please come for the felicitation. Now I request Professor H.P. Gupta ma'am to felicitate our chairpersons too. And I also request Professor Anju Agarwal ma'am, Head of the Department of Hind Institute of Medical Sciences, to felicitate our chairperson. Please come ma'am.
Hello, hall. Hello, hall.
Hello. Yes.
Thank you all chairpersons and speakers. Thank you so much for being the part of the first session.
मैं बोल रहा हूँ. Check. Check.
Thank you so much.
ठीक है मेरी आवाज
Now moving towards our session 2,
ठीक है
which is our operative session,
हेलो
where we will
ठीक है,
have live relay
Change
of
कर दिया
surgery from OT. Soon we'll be connected from the OT. And I would like to invite our chairperson for the next session. I invite Professor S.P. Gupta ma'am, former Professor King George Medical University, Lucknow, for the chairperson. Ma'am, you are welcome and please be seated as a chairperson. Professor H.P. Gupta ma'am. And I also invite Dr. Renu Makkad ma'am, Director Makkad IVF Center, Lucknow. We are pleased to have you with us, ma'am. Ma'am, please take the chair. I also invite Dr. Fatima Shiba ma'am, Senior Consultant and Director, Aman Nursing Home, Lucknow. We are very glad to have you, ma'am. Please be seated as chairperson. Thank you all, ma'am. I welcome all the chairpersons for this session.
इनका बेटा यही है
डॉक्टर हरीश का
मेरा चल रहा है शुरू करें बेटा हेलो हाँ Good morning, and it's my pleasure to introduce Dr. Haresh Vagashia, who is the operating faculty of this CME. And till now we have seen all the procedures and the instruments of this hysteroscopy. Now we'll have the visual effect of those instruments which will be depicted by Dr. Vagashia. Dr. Vagashia is alumni of Grand Medical College, Sir J.J. Hospital, Mumbai, India. He is multiple clinical fellowship in gynecological endoscopy, including with Dr. Sanjay Patel, Dr. Mayflower Hospital, Ahmedabad, advanced pelvic endoscopy by endometriosis with Professor Kekshin, LKH, Austria, office and operative hysteroscopy with Professor Pitocci at Policino, Italy.
hello
And Dr. Advanced endoscopy for gynae-oncology with Dr. Putambare, Pune, India. He is also presently practicing at freelance gynecological endoscopy surgeon and visiting multiple prime institute Mumbai with 15 years of the experience in the field of endoscopy. Now this Vivekanand Polyclinic will be one of them. He will be visiting for that. He has got the core interest for infertility endoscopy, endometriosis and office endoscopy. Conducted multiple gynae endoscopy training courses and workshops in India and abroad. He is invited operating faculty in various national and international workshops for this hysteroscopy and endoscopy procedures. Now we are watching Dr. Haresh operating in the theatre, and all of you just see, and if there are any questions, you can directly ask from the Dr. Haresh and he'll be there to answer. Dr. Haresh, please. शुरू हो गया ना?
hello Sonu, hello, anyone in the OT?
Sonu is there.
Are you able to hear us?
Yeah, we can hear you.
Hello.
Hello.
Yeah, are you able to hear
Yeah,
us?
yeah. Can you hear me?
Yes, we can.
Yes. So we have actually that much time was taken and actually should be taken before any surgery. All the equipment should be properly checked. So we were doing that, sir personally took all the efforts in checking everything, right from the camera, the light source, and the histromat, and all the settings he has done himself. So, sir, your mic is.
Yeah, is my mic on? Am I audible? No. Am I audible? इसकी बैटरी चेक की है क्या आपने? माइक ऑडियो विजुअल कौन है यहाँ पे? यहाँ पे देखिए ना, आवाज आ रही है? नहीं जा रही है. हेलो ऑडियंस.
Hello, sir, we cannot hear you.
That's what. So basically, I think, let's see 1 minute, just a minute. They are checking the. Yeah, now is it okay?
Yeah,
okay.
better.
So good morning. Now, without further ado, we are already delayed. So let's not waste our time. I will discuss the trolley once everything is set up there. Okay. So how we have sterilized the tubes. Okay. The people who have organized have done fantastic job. Carl Stores people are also have provided everything. The thing is that they do not know how to sterilize tube in very short span of time. The patient is not very well counseled. This is not an ideal setup. However, still we are going to show a conscious sedation hysteroscopy. So patient is aware, awake, but completely covered. We have to maintain the dignity of the patient. She is a teacher. I have spoken to her. Kavita ji, Seema. ठीक हो ना आप? डरना नहीं बिल्कुल, प्लीज. ओके, सिर्फ पानी जाएगा अंदर. सो वी आर नॉट सपोज टू प्रिपेयर. ओके, सिस्टर वाज आस्किंग मी 3-4 टाइम्स, सर बिटाडीन, सर बिटाडीन. So there is no need, because most of your ART procedures are done without preparation, mind you. So if ART can be done without preparations, this procedure also can be done without preparation. There is a meta-analysis on this particular aspect. Without further ado, I will start now. Vaginoscopic without touching the patient. You can see me. Can you see me? Hello?
Yes, sir, we can see you.
Okay. So you are not supposed to touch the patient and hold the vulva because she is aware, awake. You are not supposed to touch her, just the water jet, and the scope will go inside. And you always constantly remind patient that you are doing that. Okay. So we'll start the fluid. इसको suction में लगाना पड़ेगा.
Sir, before you start the procedure, can we know the brief history of the patient?
इसको suction में लगाना पड़ेगा.
Can we have the brief history of the patient,
should provide
sir?
from the, please. Yourself, Dr.
Good
Aparna,
morning.
right?
Yes.
Dr.
Good morning,
Aparna,
everyone. Myself, Dr. Parna. I am giving you the brief history of the patient. The patient is Seema Mishra. She is a 40-year female. She is para 2, live 3 with previous 2 cesarean sections. Her LMP was of 20th August 2022. The patient is para 2, live 2 with abnormal uterine bleeding with endometrial hyperplasia with query adenomyosis with previous to LSCS with hypothyroidism. The ultrasound report of the patient showed enlarged uterus with heterogeneous myometrium. Her endometrial thickness was 15.9 mm. The bilateral ovaries were normal. There was no free fluid in the pouch of Douglas. This is the history of the patient. Thank you.
Okay. So I'm starting now. Seema ji, Darnani, please relax. नहीं डरना नहीं बिल्कुल, बस हो गया. That's it. Okay. So we are now going to go in the, not putting any instruments inside, only the telescope, and that's the cervix. You can see that. Okay. Can you see the cervix? That's the Nebothensis sister Caesar. Caesar, इधर मुझे Caesar दे. हाँ, यहाँ पे आइए. Okay. Gauze piece, please. Gauze piece. Sister, okay. Gauze piece. Yes. We'll do that. Don't worry. Yeah, okay. Gauze piece यहाँ रखिए आप. We need a plastic brick actually. Okay. Yeah. All right. Hello. Can you see the picture there? Audio visual, please give them inside picture. Inside picture. Is there only one picture or there are going to be 2?
We are getting picture from the OT only.
Okay. Ma'am, soon you will have, don't worry. Can we reduce some lights in the OT? सीमा जी, आप देख रहे हैं? तो ये, this is the Nebothian cyst. Once you have internal picture, please let me know.
Yes, now we can see the internal.
Okay, how big is the internal picture? Good, nice picture is there. you can see the pink. Can the stool come inside little bit? Yeah, thank you so much. Okay, so now this is the cervix. Can you see that?
Yes, sir.
And that's the Nabothian cyst. This one
Yes,
is
we can appreciate it.
this
sir.
is the Nabothian cyst. So I'm going to deroof the Nabothian cyst. Okay, this will not cause any pain to the patient because cervix generally has only the baroreceptors. Okay, there are no only thing patient will feel is slight understanding that there is something happening to her. Okay, something like cutting the nails. All right, so scissor is not very sharp. Can we have better scissor? इसके लिए मैंने बोला स्टोर्स पर 2 सीजर रखो अंदर. दूसरा सीजर रखा है, एक दूसरा सीजर रखा है सिस्टर, देख लो आप प्लीज. So can you see the Nabothian cyst now? And you will see the secretion coming out. Okay, so the Nabothian cyst is deroofed. You can see, can you all see, appreciate it?
Yes, sir.
Oh, thank you so much. Okay, so this is how alright, so this is complete deroofing. Now I am going to go inside the internal os, and if you can see here, the internal os is here, which is completely stenotic, only accommodating 5 French instrument. Okay, can you see that? This is the os which is accommodating only 5 French instrument and not allowing the, you see now the instrument is gone inside. So I will extend, this is called, okay, how to get into the cavity by Batocchi's technique of enhancing or doing the adhesiolysis. By both the sides you will do incision, okay, on the lateral aspect, 3 o'clock and 9 o'clock. Can I get better scissor please? Better scissor, sister. 1 minute. So we'll stop the fluid flow 1 minute, don't worry. Yeah. So change of instrument, change of everything should be so easily done with after stopping the fluid flow, so that there is nothing coming onto you. Okay, so leave it. Okay, so that's the deroofed, don't forget. Okay, this is the deroofed part. No, this is also not great. Is okay? Yeah, so basically the internal os is, external os is stenosed, and generally when you have stenosis it is going to be very difficult. Okay, so there are 2 methods of getting ahead of stenosis. One is cutting the, yeah, can you hear? Yeah, so I am going to do negotiation now. Okay, so we are in the canal and I have started the suction. Okay, so that will take away the mucus and the debris. क्या हो गया? You are completely covered. सीमा जी आप भरोसा रखिए please. आप completely covered हो. So the most important problem is that the dignity of a woman has to be completely maintained, because most of the time the setup that we are demonstrating like this is not very ideal. Okay, in my setup generally I have 1 female assistant and another staff nurse, so only 2 people. So that is another Nabothian cyst that I have deroofed. Okay, so you can see now that this is a fantastic crypts. Okay, you can see beautiful crypts. The cervix is absolutely normal. And now we'll further go inside the internal os. This is the only part which is the most important part in the office hysteroscopy, is to negotiate the internal os. So first you can do probing if you are thinking that there is any deviation. This is acutely anteverted and it is again stenosed. Okay, so this is typically a type type 3 stenosis, in which you have stenosis of internal os and stenosis of external os. Alright, so there are 4 types of stenosis defined by Batocchi and Spazio-Sardo. You can read that paper in Fertility Sterility and watch the video also. The first type of stenosis is only stenosis of internal os, which is very common. Second one is this one, internal and external. Third one is internal os stenosis with upper 1/3 of cervical canal stenosis. Okay, and the last one is only external os stenosis, which is most common in postmenopausal women. So if you see here, she has internal os stenosis and external os. That is not type 3, sorry, type 2 stenosis. Okay. And you saw me giving the incision on the external os. Same thing I am doing to the internal os, and you can see the patient is quite comfortable. Of course, this patient has been given little sedation because of the setup. Okay. Otherwise, in my setting, generally we don't give anything to the patient because patient has met us. We have given most important part of the. Can you vent that bottle, please? Can you vent it? So now we are going to go from 3 o'clock to 9 o'clock, 9 o'clock to 3 o'clock. Can you see the arrow moving? Can we have interaction?
Yes, we can appreciate
Sorry. थोड़ा दर्द होगा आपको, स्लाइटली आपको समझ में आएगा अभी. 1 मिनट के लिए सीमा, प्लीज.
Sir, we want to see your hand movements also while negotiating the internal os.
Yeah, so if external camera can come close here and show that movement, it's very easy otherwise for them. Can you show only the hand movements here? Do you have picture in picture, ma'am?
Yes, sir, we have.
Okay, so now you can see there is lot of fibrosis there at the internal os level. Okay. So having the instrument, sorry. Seema ji, theek hai aap? So you keep talking to the patient, okay, and see to it that the patient is comfortable. So now you can see that it's quite stenotic os, okay.
Sir, now we can see your hands.
Yeah, okay.
So you can, yeah.
So basically what you do is you hold the camera like this, okay. So right now my cable is being moved by my index finger. It is at 3 o'clock. Okay, it's at 3 o'clock. So then I move to 9 o'clock. Then again I move to 3 o'clock. Can the table go up, please? Can the table go up slightly? Okay, then I again do probing. Can you see that? I am doing probing. So sometimes stenosis can be really painful to negotiate. So these patients are not very ideal in complete office, and you may require either some sort of local or block or something. But if the patient is counseled well, generally they do very well because the pain is only for some time. Okay, it's not constantly going to be there. So when you negotiate slightly, at that time there is little bit of. Okay, just a minute, Seema. So this patient has adenomyosis, and most of the time I have seen in adenomyosis that the fibrosis in the canal is there, and that is one of the contributory factor in adenomyosis, because the flow is not coming out well. Slowly patients have. Is she all right? She is okay? Huh.
Sir, what anesthesia has been given to the patient?
So generally right now we have only given fentanyl, okay? Means sedation, not anesthesia. Patient is awake and aware about the procedure and she is talking to us. Generally, I don't do that also, but here what happens is the patient is not seen by me. She is surprised to see that I am there. She doesn't know me, she doesn't know my abilities. So generally patients have slight sort of mistrust that, oh, okay, suddenly how come the surgeon is somebody whom I don't even know. Okay, so in that case scenario, generally the chances of office being failing is quite high, okay. So, and again you can see the stenosis is quite intense. So now I'm going to use negotiation method. Sorry. Okay. So she has a lot of pain because the stenosis is quite a lot. Okay. Yeah, sure. So we are now giving her anesthesia because patient is not very comfortable. The stenosis is quite intense, okay. So this particular procedure is not like that, okay, we have taken for office, so we will do office. Seema ji, don't worry, okay, आपको anesthesia दे रहे हैं अभी. Okay, so can you see the probing now? Hello?
Yes, sir, we can.
Can you see the scissor moving completely inside and outside easily?
Yes, sir, we
so
can.
So this is the internal os which is completely hidden and acutely anteverted. When this is all fibrosis here. Okay, so generally if this is an infertility patient, then you can have really very difficult transfer of gametes in IUI and transfer of embryo if it is IVF. Okay, so these patients are generally then done resection of the cervical canal area. All these fibrosis needs to be resected with resectoscope in those patients. Here she doesn't require that because she is not for fertility, but she has higher endometrial thickness. We are trying to do, say, biopsy, or if there is a polyp, we'll do polypectomy. If there is a cystic adenomyosis, then we'll do resection. Yeah, I agree. So we will try to see if there is isthmocele or something like that. Okay.
Sir, what are the pressure settings right now?
Right now the pressure, see, basically I am using Hysteromet Select, which has a set pressure of 100. Okay. Generally what happens is, ma'am, I will talk about pressure when I talk about my lecture in resectoscopic tips. What happens to the pressure is that generally we think that the pressure is very important factor. Basically the uterus is a dynamic cavity. It's not like abdominal cavity. Second thing, fluid is a medium which can be compressed much less as compared to air. Okay. So the pressure that you see on the Hysteromet is not the actual pressure in the cavity. Alright, ma'am. I hope I'm understood what I'm saying. So yes, if you see pressure set at 100, generally there may not be 100 pressure inside the cavity. Okay? Because that is why you will see some bleeding happening. Otherwise you will never see bleeding. So what I would say is that if you are doing a hysteroscopy and if you see the pressures, mean blood pressure, and see there is some amount of bleeding occurring. Now can you see the internal os?
Yes, we can appreciate.
Okay, so and you see my hand now. It's completely gone up. So this patient has acutely anteverted. In some cases you can give suprapubic pressure like that or maybe the bladder you can make it full for easy negotiation. But generally that does not help much. Best is to do negotiation method like this, okay? You keep on moving inside, okay? And that's in. Yeah. So I'm in the cavity and there is a polyp maybe or a polypoidal endometrium. Okay, can you see the cavity now?
Yes, sir.
So this was a difficult entry case, definitely. Okay, now you can see the fibrosis. I will show you. Can you see the fibrosis here which we have broken? And can you see where the internal os is? It's at the angle which is completely up. If I keep it at 6 o'clock, the internal os is at 12 o'clock position here. Okay?
Yes.
So this is because of the caesarean scar area, but she doesn't have ischemocele. Definitely she has some portion of ischemocele here if you can see. This polyp what you see here at 12 o'clock is the part of a ischemocele niche. Okay? And the cavity will be down retroverted. You will see now. At 12 o'clock you will see the cavity very well. That is because the cavity is retroverted. Okay. So now we'll go and evaluate the cavity very well. Okay. You can see now that's the cavity and this is ischemocele. Are you appreciating?
Yes, sir, we are very well.
This is the ischemocele area. Okay. Now you can see very well. Okay. And what are her symptoms? AUB. Yes. Suction is on. Yeah. On, no? So this is the ostium, tubal ostium on the right side, and this is, can you see my hand movements? I am not using any other hand for mobilizing the only index finger. So you hold the camera and only the index finger you can move like this on the right to left. And a very interesting thing I will show you here. You can see red blood vessels, all of you. Yes. Go very close and you will see something brown there, okay? Can you see?
Yes, yes.
Yeah,
yes,
something brown or a black. Can you see now? 1 minute.
Yes.
I'll go close and show you. Can you see now?
Yes, sir.
Much better?
Yeah.
So this is the gland filled up with the hemosiderin because she has adenomyosis. Okay, and you can see hyperemia is too much. Okay, so I will just try and explore this area first. Why it is like this? Okay, you will see now the glands and hemosiderin very easily once I open it up. You can see now gland filled up with hemosiderin.
Yes, we can very well appreciate.
See the glands. Okay, these are the glands. What you see, the vertical lines are glands filled up with hemosiderin. Okay, so there is a very nice method of something called as a furrow technique. So you generally must have seen dots shown by many hysteroscopic surgeons, that you see dots, they are endometrial glands. Can you see dots here?
Yes, sir.
These are endometrial glands. Now, but if you see, if you just give a furrow, just go inside with any instrument and make a furrow like this, okay? Just cut it off and go inside the furrow, okay? Just go inside the furrow. Now what you see vertical is nothing but the glands, okay? We call it vertical vision of the view of the gland, okay? This is quite flabby endometrium, quite a lot of endometrium is there. Okay, I will just make a furrow properly. Yes, you can see the vertical glands now. Whatever vertical lines can you see here in the center are the glands. Okay, see these lines. So these glands are filled up with hemosiderin over here in this area. You can see that. So this is pathognomic sign of adenomyosis. Okay, so basically she doesn't have any polyp or anything. or any other abnormal areas. So we can take a biopsy. Now taking biopsy has two methods of way of taking biopsy. One is with the grasper and one is with the Caesar. Okay. So I will show you the grasper technique, which is very easy. Sister, grasper please. अभी वहाँ नहीं रखना कुछ. Okay, ठीक है. Yeah. Yeah, we'll take the biopsy. We are taking the biopsy, ma'am. Definitely we are taking the biopsy. We are taking the biopsy actually from this area so that the hemosiderin also comes in. So now generally when you go with the grasper, you open the grasper and you see the entire vision is gone. Okay. So what you should do is you open the grasper and draw it outside. So you can see something now, right? Whatever you see, you are supposed to take a biopsy. Suppose you want to take a biopsy from here. Then you bring that area in between the grasper. Okay. And then you just push it. Don't pull it. Just push it, push it, push it. And then break the endometrium one, and then you do not hold again. Now you see it's like a polyp. Alright? So we are making a endometrium into a polyp, and then we are holding the base of a polyp. How we do polypectomy? Just like that we'll do biopsy. Okay? So this is how we do biopsy. It's broken now and it's in my hand. Can you see the biopsy? Okay? I hope everybody is appreciating it. So now I will stop the fluid and see the biopsy. No, bowl le lo, sister, bowl. Just take the bowl. Yes. So I have taken the biopsy. You can show in the bowl. Yeah. So this is how you can get targeted biopsies if the case is like of suspected malignancy or any other case wherein your biopsy is very important. Okay. In this case, I would not worry about it because generally I think it is she is having some sort of menorrhagia because of AUB, like because of could be anovulatory. Okay, so that's why there is hyperemia, and adenomyosis also could be a contributory factor. We can also take biopsy from the isthmocele area. Most of the time inflammatory tissue here can keep on causing issues. Okay, so you can go back. It's very difficult generally to stay in the isthmocele. This is the isthmocele. Okay, so I will go there. You can see the similar way. You just go with the grasper, disturb the endometrium, make it as a polyp, and then do not try to hold. Just break it. Okay, just break. You see. So you hello.
Is everything audible there?
Yes, we can
Yeah.
see.
And okay.
And we can see this polypoidal endometrium also, and from where he is taking the biopsy.
Yes, thank you. Yeah. So every time you come out, the going back again becomes much and much easier because the os is open now, the fibrosis is gone, and if it is infertility patient, generally it becomes really very well. This fibrosis is probably because of her previous cesarean scar. Okay, and generally most of this patient comes with that. So any patient who has previous cesarean and undergoing infertility treatment generally comes with type 2 or type 3 stenosis. Okay, so now last the biopsy from the hemosiderin area. Okay, so you just break it like that. Alternative method is go with the scissor, make a carpet. Okay, like how we are making a polyp here. In scissor you keep on cutting circular and make a carpet, and then at the end you can go with the grasper, hold the carpet and then remove it like that. Can you see that? That's the polyp sort of. Okay, you can see the hemosiderin laden glands have come in my grasper, and that's the end of the case.
I think that
Yeah.
cervical fibrosis or stenosis must have been, she must have had some
Yeah.
vaginal manipulation for the treatment.
Maybe, ma'am.
Yes, that's why it caused that cervical stenosis or such a severe
Stop.
disease. So it was a
Yeah.
wonderful operation.
Thank you, ma'am.
The way you dissected the fibrosis and fibrous tissue from the cervix.
Yes.
And took the biopsy from this endometrial cavity. From
Thank
the
you, ma'am.
liver.
Thank you so much.
So,
Main camera,
it was
please.
a wonderful
Light
surgery.
off, light.
Dr. Renu.
Stand. नहीं, हाँ, ठीक है, चलेगा.
Clarity of
या इसको रखिए, इसको क्लीन.
So, it's a big round of applause for this wonderful surgery.
So, ma'am, if you can see here now.
Yes.
Now, for the second case, what I'm doing is, I have just wound these cables like that.
Yes.
The internal part is sterile.
Okay.
Okay. So, internal saline is not being used or not being. So, I have stopped the cock here, and all this will go in the side X. So, for the next patient, it will be sterile tubings that we'll be using.
So, you will be putting in the Sidex for at least 20 minutes.
Yes, yes, ma'am.
Okay.
Any questions from the audience? Any questions?
Yes, sir.
Your information, actually it's streaming on YouTube also. If you want to share with any of your outside
Okay,
listeners,
okay.
Like we understood, there was
There is a link.
Yeah,
What
You
was
can
done for
forward the link to
endometrial
me.
hyperplasia as
that link I'll
it was
forward.
shown in
Yeah.
I
ultrasound?
don't have your WhatsApp map for that.
What was done for endometrial hyperplasia as shown
Yeah,
in
sure,
ultrasound?
sure. Yes, yes, yes. I don't know. Is my mic on?
Yeah, what is the question, madam? Excuse me.
Dr. Harish, there is one question for you.
Yes.
Yeah, actually, it is an endometrial hyper. What is to be done for What is being done for endometrial hyperplasia?
Okay. So now this particular patient, I would not label it hyperplasia because hyperplasia is a histopathological diagnosis,
Yeah.
right? This patient, I would label her as hypertrophy, right?
Hypertrophied or thickened endometrium?
Yes, right. So same thing. Thickened is hypertrophy. So hypertrophic endometrium, I would go and see if there is any disordered endometrium. What is disordered endometrium is one gland is normal size and one gland is big or a cystic size. So if you see multiple of such glands, then this is disordered endometrium. It will also have micropolyps. Alright, so this is showing the sign of chronic endometritis. Now when you have a chronic endometritis, the glands are of disordered size. It's like, I will say you, suppose you have a military battalion, all the soldiers are given enough training so they remain in synchrony. So when they are marching, it will look as similar. But suppose one or two soldiers are not very well trained, and if they join that battalion, they will not be exactly looking like similar. So if you see multiple glands are looking some size, that is normal size for that particular endometrium, and some glands will be seen bigger. We will definitely see one of the case today. I will show you very closely. So in such cases, generally I give doxycycline for 10 to 15 days and give probiotic for 1 month. So this treats the endometritis. Another thing is you can suppress the endometrium by giving either OC pills or using cyclical progesterone for 3 to 6 cycles, and they do very well.
So thank you, doctor.
But this patient, ma'am, she has adenomyosis also.
Hello?
So depending upon her pain factor, her other symptoms, you have to weigh what you are going to offer to the patient.
What is the rate and the pressure at which the fluid is, saline is going in through the...
Yes, so basically saline flow rate also depends upon how much you are suctioning out the fluid to keep the cavity clear. So it is the concept of something called as continuous flow. Okay, because when you work in the cavity, there is some debris, some bleeding, some mucus. All the time it is coming in, and that's what you need to continuously clean out. So there is a suction and irrigation both happening, and that's why the flow generally is about 80 to 100 ml per minute.
And is there some pressure also by which...
Yes, ma'am. Generally we keep the pressure at 80 millimeter of mercury in office and about 100 millimeter of mercury under anesthesia. Sometimes when the cavity is under contraction, I would recommend all of you to wait and take deep breaths and do not increase the pressure. what happens is uterus is under contraction, and that time how much pressure you give, the cavity is not going to open up and give you the view. So if you relax for a minute or so, the contraction is not like labor pain. It will not last for a long time. In a minute the contraction will go away and you will get a good cavity again at the same pressure. So do not increase the pressure.
While doing your procedure, do you need to stop the outflow and keep the cavity distended for some time?
Ma'am, depends upon how much suction you are using. If your suction is 0.1 bar, which is there on the Hamau endomet, or if you are keeping the the suction pressure at the lowest, that is 10 to 15 millimeter of mercury, then generally your distension will not get disturbed, because inflow is kept at 100 and output is at 20. So you will get somewhere around 60 to 80 pressure. Okay, so if your distension is lost, it is mostly because there is contraction. So if you wait, your distension will come back. If it does not come back, then you can increase the pressure and reduce the suction. That can be definitely done.
Thank you.
Yes, ma'am.
Hello?
Yes.
Sir, okay. Sir, actually while negotiating the os,
Yes.
sir, as it was an antiverted uterus, so you kept the, sir, the glide cable was down.
Yes.
And while if it is a retroverted, then you'll keep it at 12. While
Yes.
negotiating, while like in
Yeah,
this
so
case,
once you see that the cavity is retroverted and you want to have a complete look at the cavity, then the cavity is at then you keep the cable at 12 for that particular time.
yes, sir.
But if you are
while
doing any
negotiating.
operative procedure, it comes back at 6 o'clock.
Yes, sir.
Why is it so?
So because when we enter inside,
Yeah.
so then we have to look like because the cable is like the opposite now.
No, just for the view is for orientation. Okay. So for cavity is retroverted.
Yeah.
So to have an orientation, you take the cable at 12.
Okay, okay.
But when you keep a cable at 12, the instrument will go down.
Yeah.
Now with retroverted and like this, your hand will not allow you to do the movements. So to operate, you have to again bring the cable at 6 and operate with the instrument up.
And so this was 2.9 mm scope, no?
Yes, yes. This is 5 mm. We do not call about scope.
Okay.
You should talk about a hysteroscopic sheath.
Okay.
So this is Batocki 5. Okay. 5 means 5 millimeter sheath and 4 means 4 millimeter sheath.
Yes.
I will tell you a very simple clue. If the scope does not show the notch on the screen,
Okay.
did you see there was a notch on the side which I was telling you,
Yes,
3
yes.
o'clock, 6 o'clock?
Yes, yes.
If you do not see, if you just see complete circle, that means it is 4 millimeter Batocki. 4 millimeter does not have a space for the notch.
Okay, sir.
Are you getting me?
Yes, yes.
Yeah. Because it's a smaller scope, there cannot be notch.
Okay, sir.
So 5 millimeter only will have notch. So somebody who is showing 5 millimeter, generally with 5 millimeter with tight stenosis, your hysteroscopic office procedure is going to fail.
Yes, sir.
So if I had 4 millimeter, I would have succeeded in this case. Again, 4 millimeter is slightly flexible as compared to 5 millimeter. So to go into a crooked endo-uterocervical axis, it is much easier than going in such cases with 5 millimeter, which is rigid, is difficult.
Okay, sir. Thank
Yeah?
you so much.
Okay. We are ready in the other case? Other? Okay. Huh? No, it's okay. We'll go, no? Later on. Mike can be. No, announce the second case in history, no? नहीं ये ऐसे ही रखिए, ये निकालिए मत. केस डायरेक्टली शुरू करेंगे ना. हाँ, we will not give time, otherwise the audience will lose them. We have to continuously have. We'll take that next case. ये वहाँ ले लेंगे. बट कैसे लेंगे फिर? थोड़ा डिफिकल्ट हो जाएगा, है ना? I'll give you one idea, sister. मैं बता रहा हूँ आइडिया. इसको सक्शन में से निकाल दीजिए आप. ओके, अभी ये है ना, ये बाद में लेके आइए, ये पहले लेके जाइए. एक में आराम से ये रहने दीजिए. किसी को ऐसे बस आराम से सिस्टर, ये है ना, ये भी किसी और को ये लाने बोलिए बाद में. पहले ये लेके चलो, ट्रॉली वहाँ ले जाएंगे. अभी मैं देखता हूँ केस क्या है. हेलो, व्हाट इज दिस केस मैम?
Hello.
Yeah, hello. Hello. Wait, wait. ये नीचे वाला, ये नीचे. Hello. Perfect. Hello. Am I audible? यहाँ पे और पता नहीं चलेगा. Monitor ठीक है. It's perfect. It's okay. Hello. Yeah. ये वहाँ सुनाई देगा ना, वो वहाँ पे है. इसको ये लगाओ. मार्कर है. व्हाइट बोर्ड परमानेंट भी चलेगा. परमानेंट है क्या? परमानेंट देना मुझे. परमानेंट देना है.
हेलो हेलो
ये बकेट खाली कर. है परमानेंट है.
हेलो ओटी. हेलो चेक. हेलो ओटी प्लीज. हेलो.
दूसरे केस के लिए कितना यूज़ कर रहे हैं पता चलना चाहिए. तो फर्स्ट केस में इतना यूज़.
हेलो हेलो डॉक्टर सोनू, you are not audible. The audience wants to see the trolley, the instruments and the layout for the camera and all those things.
Yes, we are just about to
the time when you are shifting the patient and making the preparations.
Okay. Oh, okay. बहुत ज़्यादा है. Hello.
Hello.
Yeah. Am I audible, ma'am?
Just now we saw that there was
Hello?
so much
Can you hear me?
difficulty in dilating the cervix. For most of our outdoor procedures,
खाली bucket ले, खाली bucket.
even before
खाली,
MTP,
ये
before
bag नहीं डालना.
hysteroscopies,
Plastic bag
we
नहीं
feel
चाहिए.
the difficulty in
Empty
dilating the
bucket
cervix. Sometimes even before IUI, before embryo transfers. So we've been using misoprost to soften the
okay.
cervix, and that helps a lot in softening the cervix, and it becomes easily dilatable. For your information, there is one more device which is available nowadays, which dilate. There are many devices rather, but I have experienced a good device which is called Dilapin. And if you put it inside the cervix, even the most tortuous cervical canals, they become easily negotiable. So we saw there was so much difficulty. He had to use the scissors to negotiate the cervix, and he, being an experienced person, can do that. But we know that we can't use the penetrating instruments like that. So it is better to dilate the cervix if you are planning, because all of us know beforehand that what is going to be the diagnosis.
No, am I audible there in the audience? The dilatation is completely not a good idea, madam, because it's a blind procedure. So I will explain to you if I have an external camera here.
No, doctor, I am talking about Dilapin. It's not the
Yeah, I agree to what you're saying. Yeah, that's true. That I agree, whatever is there. But the best method is what I have shown, ma'am. Believe me, if you try doing it in a simpler cases, once you get into the using the hang of it, it is much easier and safer, because everything what you do here is under vision. Rest everywhere if you use dilator, or yes, what you're saying is right, the Dilapin is good if you are using that, but not everybody may have the access to it. If it is there, then it is one of the option that you have. But I don't think that all the cases are needed to be done that way. What I would suggest is, where is the marker gone? So basically what happens in cesarean cases is, the uterus falls down like that, okay? You have cesarean scar here, so there is isthmocele area, this much, and then this is making the cavity negotiation difficult, this bend. Now when you put in the fluid by probing, what you do is, when you probe, the fluid goes in. Once the fluid fills in, the uterus slightly becomes straighter. Are you getting my point, ma'am?
Yes, yes.
So when you understand probing little bit, by doing little probing here again and again, every time you go, the uterus starts coming slightly in line with the scope, and you can do it. Some cases are very difficult to do. Then those cases you can do how it is shown here. You can now see the trolley. Somebody was interested in knowing the instruments and trolley, right? Hello?
Yes, sir.
Yeah, so basically you can see here, this is the hysteromat, okay, which is having the suction and the irrigation component. This is hysteromat select by Karl Stoss. If you are going to do any of the cases with shaver in future, then you must buy this particular set, because with your morcellator, which is now company has completely stopped using for myomectomy, but now this is being used, the same morcellator unit drive, you can use it for morcellation. Okay, only the program has to be changed. That is a hysteroscopic tissue retrieval system. So this one is used for both hysteroscopy as well as IBS, that is integrated Bugatti shaver. Okay, I will show in one of the cases where it is possible to use. And this is camera. What you should remember is that the hysteromat should always be placed at the patient level. Okay.
Okay.
If it is placed down on the floor or very high, then the pressure inside the cavity will change. Okay? And that is why the light and the camera is placed down. Generally this we place it here. In my setting, the hysteromat comes here. So you can see the pressure, you can see the suction, everything here.
But
And
it's
then the
not
camera
at
and the
the
light
level
is
of
here.
the patient. If it is higher up, then it's not at the level of the patient,
What happened?
as you said.
Sorry, ma'am.
हिस्टोमैट की तो बात कर रहे हैं.
Hello.
Hello.
हाँ.
Hello.
वॉश कर लीजिए उसको. ऐसे ही ले लीजिए, पूरा ले लीजिए, पूरा सब कुछ. हाँ. सलाइन दे दो.
Ma'am, please. Hello.
Are we ready with the second
हाँ,
case?
आप सही है?
Are we ready?
Okay, okay.
Are we ready with the second case, sir?
Yes, yes, we are.
So can we have the history of the patient, please?
यहाँ पे
Dr.
connect.
Sonu. Dr. Sonu. Hello.
हाँ, कैमरा, कैमरा. किसी को देने को बोलिए. कैमरा.
Please
Are
share
you?
the history of the patient.
Yes, we can hear you.
Hello. Hello.
अच्छा, वैशाली में.
Yeah, please speak.
नहीं, कवर कर दो ना, कवर. इसका कवर था ना. ठीक है ना, वहीं पे रख दो. इसको वो ओटी में लेके जाओ अभी.
Hello.
No, I think the audio is not connected. हाँ. वो है ना स्पीड.
Hello, are we audible? Hello.
संजय, तुम्हारी आवाज नहीं आ रही हॉल में.
हाँ, बस बस बस. लाइट ऑन नहीं है, लाइट ऑन नहीं है. या 5% को बढ़ाना पड़ेगा. उसको बढ़ा. अच्छा, डिस्कनेक्ट किया था ना.
Hello, hello.
ऑन इनफ.
Hello.
एटलीस्ट वीडियो है क्या? वीडियो इज देयर. स्टार्ट दिस नो. Hello.
Yes, sir, we can hear you.
हाँ ठीक है भैया. हेलो. हेलो. हॉल.
Yes, we can hear you.
यस, मेरा हैंड बैंक.
Hello.
Now we can hear you. Please share.
Hello.
Yes.
Now am I audible?
You are audible. Please share the history of the patient.
भैया, हैंड माइक की आवाज कम करो जो तुमने हेलो बोल रहे थे.
सेक्शन में.
Yes.
इसको ओपन कर दो.
Yes.
ऐसे. हाँ, और सेक्शन
आप क्या बताएं, अभी पहले लोग बोले तो.
कहीं पर भी अपने सेक्शन में लगाओ.
Dr. Sonu, can you
Hello,
please
so,
share the brief history of the patient?
Okay, okay.
Okay. So this is our second patient. She is 34 years old and she is a case of primary infertility with the TVS finding of endometrial polyp. So it's a small polyp on ultrasound and she is having infertility also. Sir has already started with the case.
Okay, so this is how you generally hold the scope, ma'am. Okay.
Hello, Sonu?
Hello,
Doctor
hello. Can we have the inside picture also?
Monitor is not visible for us.
Hello.
Hello?
Kindly show the scope view.
It's easy, right? So there will be not much force of your hand on the patient. So this is
Sir, you are not audible.
Yeah. You will be. You will hear me. Don't worry. Don't worry. We'll see to it that you don't lose anything. Am I audible now? Okay. So you hold it like very, very gently, very softly, so that there is no force on the patient's vagina, and you're gliding only in the fluid. Okay. You're gliding only in the fluid. You see, there is no friction between the scope
Hello?
and the vagina at all.
Can we have the inside picture, please?
Yeah, inside picture now. And then you can just see. This is the negotiation. No, ma'am. That's what I'm saying. You are in the fluid. You are swimming. How in the swimming pool you swim underwater? Just like that. Because you are not touching the floor of the swimming pool. You are not touching on the out. It's like within that. You see, right now I'm inside the fluid. You see? Okay? And that's when you see this. When you see this, what I generally do is, you see, I rotate the scope so that it goes there, and then you just rotate it slightly. Okay, like that. So you get inside the cervical canal. So without disturbing the, you see, there is no disturbance at all. The configuration is still same. Okay, exactly like how it is. Right? So you can just go, you can alternatively go like this also. Take the cable at 3 o'clock and go inside. Okay?
Sir, you are not very much audible.
Okay, okay, ma'am. We are trying to correct it. Just a minute, ma'am. Caesar. पानी कहाँ से आ रहा है यार? हाँ पहले गया हुआ है. Can you give that towel here? Yeah, thank you. Oh, so sorry. अभी हो गया. चलो. अभी हो गया. So sorry. Hello, am I audible now? Gospel is there. Yeah. है यहाँ पे. Don't worry. एक ही हो गया बस. Hello. So now what I'm saying is, you can see, you can keep a Gospis or a Gamgee here, so the fluid doesn't come on to you. Okay. Right. So this is just to keep the. Now I'm too loud, right? It's okay, little louder is fine, then no noise, voice at all. So this is a cryptal polyp, you can see here. Sorry, there is some debris in the Caesar. In the end, I will show you how to clean the Caesar also, if there is some time. Okay, so suction on please. Is the suction connected? Is it on? अरे ये खोल दो ना, ये खोला नहीं तो ये एक मिनट वो नहीं this one, keep it open. हाँ please don't do anything, otherwise suction will not happen. Suction is on. Have you connected surely?
नहीं but ये connected है उससे.
Just remove this, no? हाँ ये just remove कर दो इसको निकाल के. हाँ हाँ इसलिए because there is too much of suction there. Yeah, yes happened. हाँ king था कहाँ पे. Okay, that was a problem. Anyways, no problem. So these are all hiccups in the workshop because, wait, let it be now. संभल के रखना उसको. There is some debris, some hemosiderin collection here. You can see now. Most of the infertility patient, this is a detrimental thing. You can see hemosiderin. I don't know whether they can appreciate this. See that? Can you see that?
Yes, sir, we can appreciate it.
Yeah, there is a black color marking there, and you can see now I have gone inside and I have opened that area. So the hemosiderin will drain and it will not have any detrimental issue in the.
We need inside picture.
Oh. See that? So much of hemocentrin, right? So these cervical issues only you can see if you're going vaginoscopic. The moment you use dilator, you will lose all these findings. An infertility patient, because your embryo travel, look at this. Can you see? Yeah? So all this will be lost. And this is a cryptal polyp. This also will be missed if you do directly dilatation, okay? So cryptal polyp has a lot of thick secretion and chances of cervicitis. So I'm going to go on the pedicle here. Can you see the pedicle now? So you go on the pedicle there and just cut the pedicle and see it's gone. It's gone out. Okay, it's gone.
So it's because of suction it is coming out. So
Yeah. Otherwise it, yeah. So it comes out. Now see, right now I'm at the cervix, okay? Now most of you feel that now it is difficult negotiation. So what you just do is you stick there. For example, if the door is closed, what you first do is you go yourself and push yourself against the door. And then you push more to open the door, something like that. So I'm at the door now, see? The door is closed. So I'm going at 3 o'clock, 9 o'clock, 3 o'clock, 9 o'clock, 3 o'clock. Can you see there now? See there. Okay? So it's up. So you will lower your scope. 3 o'clock, 9 o'clock. I am inside the cavity now. Can you see that? This is a negotiation method. And now that's the polypoidal endometrium. Okay? So this patient has basically polypoidal endometrium. That's the, okay, this is polyp, okay, this is the polyp, cavity is here. Okay, very interesting finding I have, only one ostia. Where is the other ostia? Here it is, okay, this is another ostia. So basically if you see there is the arcuate uterus also, I'll show you, that's the arcuate uterus, okay. So this is how you diagnose the arcuate uterus, because the cavity is deep. Can you see that? If they can hear us, then it will be better. Are we audible there? Can you keep a mobile on?
Yes, sir, you are audible.
Oh, perfect. So now, ma'am, see. If you see here, the cornu is very deep. Okay. If you can see here, the cornu is very deep. Okay. The cornu is not at all visible from the internal os. This cornu is superficial. So, no, even that is deep. Okay. So generally, can we just increase it plus one time, one more, plus proper. नहीं हो रहा है, हाँ अभी हो गया, that's it, yeah. So because there is polypoidal endometrium, we don't have a good panoramic view, but if you see now, we'll first clear the polypoidal endometrium and then we'll go and check for the cavity. So this is typically a Y-shaped cavity. Okay, I want to show you the dysmorphism in the patients, and generally these patients have lot of issues in conceiving. Okay.
So your scissor is also acting like grasper.
Yeah, it's at times it becomes like grasper once it becomes old. Otherwise, generally scissor will cut only. Once it becomes slightly old, it becomes.
The thing is coming out along with scissors.
Yes. That's because of suction. Okay, when you come out, things are coming out. That's because of the suction. If it is completely detached, tissue is detached, then it will definitely come out. So this is the polypoidal area. You can see. Then you can just cut it.
So you do all hysteroscopies in standing position?
No, generally I sit. But this. No, it's okay, ma'am. Don't worry. Office I do standing because patient can see me. When the patient can see you, it becomes very easy because patient sees the confidence in you. In between we can keep on talking to the patient because patient gets worried sometimes. What is this coming out? He's quiet. Can you see the polyp now? The best way to do polyp is by using the grasper, not by using the scissor, because that's why I'm pushing in between, okay, and not cutting it. When you just cut it, you leave the pedicle with which, from where the polyp has arise. This is the area, okay? You can see that is the area where has a polyp from. So you can see that's a fibrotic part. The polyp is now almost free. You can just take the polyp out, and there is another polypoidal here. Once we remove all this, you will have a fantastic panoramic view. Grasper, please, brother. Dinesh bhai. Thank you. अभी बोल ले लेना. What? कटोरी. हाँ. So basically these instruments have a micro channel, okay, and see the polyp coming out. Can you see? Yeah,
Sir.
Are you able to appreciate?
Yes, sir, we can appreciate.
So the polyp is out, and you can see the polyp here. Cut, पानी open करना पड़ेगा. That's it. Okay. So one polyp is out. I'll remove the other one now. Okay. After removing polyps, we'll show you the arcuate uterus.
Reverse PIP.
Generally, most of these patients, if they are for infertility, they are put on suppression, ma'am, with OC pills. Without, so just like how you do preparation of endoscopy by giving, either Dulcolax or bowel preparation, okay, or at least keep the patient on liquid diet. You do not, do nothing and take the patient. So that patient will have issues. So this endometrium is not very nicely prepared for hysteroscopy, because the fluid is over. Huh? Just check. Yeah, no? Yeah, fluid is over. So can we change the fluid? उसको बंद कर दिया दूसरा वाला. So we'll check the air coming out first. Yeah. So right now the advantage of vaginoscopy is that whenever there is air, you can come out in the vagina. When you are in the vaginal area, you will have no chances of embolism. If you remain in the area which is open or which has dilatation or some place, polypectomy done, the channels are open there. And if you are going to do some, air, if it comes there, then you're going to have problems. So see the air column coming here now. So one has to be continuously, watching this. So I'm keeping the suction on so the air column can be, because it got
Reverse
over.
PIP.
Yeah, outer thing is visible, ma'am. In PIP, that is visible. Okay. So now you can see that hemosiderin area. See, very, very well seen this one. The area with hemosiderin collection in the cervix here. Okay, preferably we should, that's the air column coming in. Some air is still left. No, that is okay. This much air is okay. A small bubble will just hamper your vision. That's why it should be out, not for any other hemodynamic issues. Okay, itna chota bubble will not cause issues. Only problem is that it will make your vision very, because the refractory index of water and air is different. So you will have distortion in the vision. So you don't want that. These small factors are generally missed at the hysteroscopy. In this tool. Yeah.
Dr. Harish?
Yes, ma'am.
Can you guide us how do you prepare the endometrium before the operation?
Yes, ma'am. Before any operative hysteroscopy, what you should do is put the patient on OC pills. If she comes to you in any cycle, then you start it from day 2, like how we generally start OC pills. Do not operate the patient in that cycle. Generally, that is why this patient is run away. So most of the time when you talk about endometrial preparation, most of the people are not happy because the patient will not agree for that long time. So what you do is allow, if the patient has come to you in say mid cycle, and then so that is how you then first cycle you don't operate, you operate in the second cycle. So you put on OC pills, allow her to menstruate, again start the OC pills and post her any day.
Okay.
Yeah.
You don't use GnRH channel?
Ma'am, in myomectomy, if the fibroid is of a complex lasmar, then I prefer using GnRH. It will help in 2 ways. It will prepare endometrium also, and it will make the lasmar score little less. So that I will show you in my tips and tricks of resectoscopy lecture, how to reduce lasmar. So see, this is the polyp which is coming out, and the polyp is completely out now.
Sir also has very amazing set of lectures. So we will definitely have.
Yeah, we'll have at least one of them.
Once we'll get time in the end.
Yeah, sure.
We'll request sir to take those lectures.
So generally in my setup, I don't use Histomat Select. I use Hamao Histomat, which is integrated Histomat, which has both irrigation and suction together. Okay. Now if you see the Histomat here, you can see the polyps are out, but still the endometrium is too much. Okay. So it's not very ideal situation to do metroplasty, but I will definitely demonstrate to you. If you keep your eyes very closely open and be with me, then you will see now. This is the internal os level, and you can only see the cavity. You can't see cornua at this level at all. So you have to go at the fundus level and then take the cable at 3 o'clock to see the right ostium. Yeah. Okay, and still you can't see the ostium, and you have to go in the cornu. Okay, in the cornu, and inside it is seen. So it is quite deep ostia. That shows that this lateral wall, you can see the fibrosis here.
Yes, sir.
I will show you. See, the endometrium grown here is so much nice and polypoidal, right? But here there is no endometrium. You see that? There is no endometrium here. You see only fibrosis. Can you see now?
Yeah.
So this is the impact of the dysmorphism. Generally at the fundus also, you saw in the beginning, the endometrium is quite thin. So that is because this area has non-absorbed fibrotic area which was supposed to have got canalized during embryonic life of this patient, right? But it is not canalized like how triangular cavity we generally see in conjuta class 1. Okay. So I am removing all polypoidal to have a good appreciation by all of you to for the metroplasty. And all metroplasty in infertility should be done with Caesar. Those who are doing resectoscopic metroplasty should consider using only Caesar. I am not saying that they are doing wrong, but they are doing it slightly differently. The result may be varied because most of the fertility societies now recommend using only Caesar for metroplasty and not using energy at all. Okay.
And sir, I want to ask you, many times we find arcuate kind of uterus.
Yes, ma'am.
So should we do correction in those also in infertility cases?
So basically none of the metroplasty should be done only on the view of hysteroscopy, ma'am. Okay, unless it is gross like this patient. So subtle findings what you see is could be because of pressure, but the best way to diagnose dysmorphism is not hysteroscopy but 3D sonography. Yeah, if I know the thickness outside, then only I can shave the wall, right? So basically what you do in this dysmorphism by metroplasty is, we are not getting good distension because of this histomat. It is not, cannot be increased. This is the problem of this histomat. This histomat is very limiting in view of that. So for Batocki 5, this is not a very ideal histomat. Homov is ideal. For IBS, this is very, very good histomat. IBS is shaver. Okay. because it has a good channel for inflow. So this is how this fluidodynamic lecture will solve all these questions of your how to get distension, how distension is. आप यहाँ पे है ना, वो जो बाहर लगा है ना, उससे प्रेशर दीजिए ना, ये बंद कर दीजिए. Yeah. No, you are allowed to shift in this bottle.
We are using that only.
Yeah, I will show you how to increase with that. नहीं इसमें लगाओ भाई, वो बॉटल तो बंद हो गई ना. इसी में लगा है, हाँ तो बड़ा हो, ये बंद कर दो, स्विच ऑफ. हाँ ऑफ करो और ये खोल, हाँ और ये खोल दो. ओपन दिस. यस, नाउ स्टार्ट. गिव. उसको निकाल दो. रिमूव दैट.
Is the view fine over there? Everything?
Yes.
The inside picture and the outside picture?
Right now we cannot see the inside picture.
Oh.
Yes, it's fine.
बढ़ाओ, इंक्रीज.
रिवर्स PIP.
हो रहा है क्या वो? ठीक है. बल्ब ठीक है. दूसरा ले लो ना फिर बल्ब.
Fatima ma'am, now is it fine, the inside picture?
Yeah, now we can see it.
Yes,
Okay ma'am,
yes.
okay ma'am.
बढ़ाओ, वैसे नहीं बढ़ेगा.
Actually we are little struggling with the pressure inside.
That's fine now. See, you can see that beautifully. So
Yeah, now it is better.
yeah. So we'll just remove the polypodal endometrium and then see if we can see the cavity contour.
Initially it was so nicely visible and
Yes, because once you try and do polypectomy and do some shedding, what happens with the shedding is uterus naturally starts contracting. You get my point? Whenever you have lot of endometrium shedding, the uterus starts contracting. So whenever you do this type of preparation, intraoperative, you will not get good distension because of the contraction. You got my point? See how much endometrium I have removed. So this shedding will cause natural contraction in the uterus. So being a lady, you will understand well but why it happens. It happens because uterus does not want to bleed naturally, right? Once the endometrium is shed, the uterus wants to contract. So you will have more contractions once you prepare endometrium surgically. That's why surgical preparation is not good. Like somebody you will do DNC or MVA syringe and then try to use, it will not be very good idea. No, लगाओ ना, pressure बराबर नहीं मिल रहा है. Pressure is not proper. What is it? किससे? Why, you know? There is lot of contraction basically. So we'll do Caesar दे दो. Yes, very good. Thank you so much. Very nice. Yeah, please give. Okay. So now you can see very well the fibrosis. Can you see? Yeah. So now how to do metroplasty? You see, this is how the position is. The notch is at 3 o'clock. The instrument will come from 9 o'clock. This will make a right-sided metroplasty easy. Now if you see, the Caesar has two parts, one is immobile and one is mobile. So what you need to do is you have to make this Caesar, no don't worry, Caesar from like this grip, you have to just allow it to rotate. So the mobile part goes, see the mobile part is right now outside, okay?
Yeah.
Now you cannot keep a mobile part in the wall. So mobile part will increase here because there is a space in the cavity.
Yes.
You get it? There is no space in the wall, right? Wall is composed of solid tissue. Here there is fluid, so opening is easy here. If you use like this, there is a chance that you can break. Second thing, you don't know how much it is opening. Can you see? You cannot see that. Here you can see opening. Now what you do is you just allow the immobile part to go inside the wall. Okay? And then don't remove it out. Just keep on closing half, little bit, not too much. Okay? So just go inside and do not remove it. Just keep on just going ahead without taking out. Are you getting my point?
Yeah.
See, like how you cut cloth. How you cut cloth? You see? You cut cloth like this. You see that metroplasty happening? Can you see that?
Yes, sir.
So this is how you do. Okay? You see that?
Very nice.
See
sir.
that?
Really.
Now you can see the cornu?
Yes, yes.
And see, ma'am, you will see wonderful. Okay? Now this is not an ideal preparation, but still the appreciation of cavity getting enlarged. Bus. Perfect. Thank you so much.
Yes, beautiful.
Okay, now you will see what is the area, till what level you will go. Bus, don't give it. Okay, till what level will you go? Because the scissor gives you a fantastic tactile feel, ma'am. Okay, now can you see the cornol ring completely?
Yes, yes.
So you are not supposed to go beyond cornol ring, because cornol ring is the area where one layer of myometrium is deficient. Okay, that is the only oblique layer is there, not circular. Like you have if you have studied anatomy of myometrium. Now see this, can you see, appreciate it very well?
Yes, yes.
Beautiful, see that dysmorphism
yes,
gone?
very beautiful.
Then you can do the lower part also similarly, okay? However, lower part, even if you don't do too much, because it is close to the area of isthmus, it's alright. This is fantastic metroplasty there, okay? Now you can see the fundus part also. You can go there and then just make it. Now the reverse scissor I'm using is a reverse grip, okay? And the notch is at 6 o'clock. Okay, so then that will make it straight. Again, what you have to see is the fundal notch. This is the fundal notch here. The entire ring, you can see sorry, not the fundal notch, the cornual ring. That is the end point that you have to remember always. Okay, and you will see in a while a fantastic cavity happening here. You can see the cornual ring coming. Can you see the cornual ring coming?
Yes, sir.
And I can see the feel of the scissor. I mean, I can't explain to you but I feel so well when I go and finish this fibrous part. See the myometrium coming in pink? Yeah? So this is the fibrotic area, and all the fundus is now being, it's so these two metroplasties has been done both. Now I'm coming to the left. Okay, so the cable, I'm changing the hands now. Okay, so far I was using left hand for the scissor. Now the cable is holding with my index finger, 9 o'clock, and then again I'm coming. So with the scissor down, the mobile part is going in the wall. I don't want it like that. So left wall, always the instrument will go reverse. Okay, so you go inside and then just do not come out, just like cloth. Okay, just keep on opening and closing, okay? But be very careful not to apply force, otherwise you will perforate the fundus. Okay, so you go like this. As soon as it is approaching, go very slowly also, see? So I am stopping there. And this is how you continue doing it, and that's the, okay? You see that? And this is the polyp base. Now I'm going to cut it off. Okay, ma'am? So this was not approachable. Can you see that polyp?
Yes, sir.
Yeah, it was not approachable because of this dysmorphism. Now it is going to get approached. Okay. See that? So now how do you estimate how much metroplasty have you done roughly? Okay, I will show you how to do the estimation of the metroplasty area that you have done. Okay. Generally when you open the scissor, it is 4 millimeter at the tip, open scissor, okay, like this. If you open scissor, it is 4 millimeter. So you open the scissor and you see, it's more than 4 millimeter. Can you see that?
Yeah. Yes, we can see.
So I have got almost 5 millimeter here, and you go here, the open grasper is almost 11 millimeter, okay, because it is bidirectional. This is unidirectional, okay, or so this is, you can see it's almost 4, and then much more than that.
Yeah,
you see
much
this
more.
side was much more, okay.
Yes.
So this was more or less, you can say, a dysmorphism with slight not symmetrical dysmorphism, okay. So now I'm going to do the polypectomy. Very good, thank you. Enough. Okay, so the polyp is coming out. That's the polyp. You can see that very well. Can you see? Once you remove that, the posterior polyp will be easily seen. The polyp in the back side. You see there is another polyp there, which is nothing but a continuous polyp here. So you basically push it like that and you will avulse because polyp is made up of mucosal lining, which is very easily, you can avulse. So you can either continue cutting or just do like this manipulation. You can see the polyp mobilized now. So actual polyp which was seen on sonography was this. Not the one which we removed. One which we removed was just the folds. Yeah. So this is coronal polyp, slightly difficult for beginners, of course, because it is not very easy area for you to approach. Sorry. Okay, you can see now the polyp. It's okay. Enough. So basically, see the polyp? See that polyp now, ma'am?
Yes.
And see the cavity entirely. I will take out the polyp with the grasper. Grasper, please.
Yes, very wonderfully done, sir.
So if you keep a little bit of patience, and don't keep a target of 10 minutes, that I'll finish hysteroscopy in 10 minutes and it's a minor procedure. Believe me, look at that polyp. This is the first one. And this is the second one which is still not detached, okay? So I will remove it. More than that, I am interested in the base, okay? More than this polyp, what I am interested in removing the base of it, because it should be done with the grasper. That's why I like the Batoki's technique of avulsing the base, because base is like a root of a plant. It will not grow again, okay? So when you pull it out, that's the base, okay ma'am?
Yes. Sir.
So generally that has fibrosis area, and chances of regrowing of anatomy, the polyp will come back. So that's the polyp. Okay.
Yes. So the better idea is first just separate half of the
Polyp, yes.
then grasp at the base and
then remove. Yes ma'am,
avulse
perfect, yes. So see now the base here. Can you see? Beautiful base. And you can see if there is any bleeding. See that? I've stopped the fluid.
Yeah.
And there is no bleeding.
Yes,
Okay,
yes.
this much will get controlled with the...
This much is normal.
Yeah, this will be controlled by the normal uterine contractions. You don't need to
Healthy
give...
bleeding, we call
Yes,
it
it's perfect.
healthy.
Yeah. She's infertile, so that's the polyp coming out. Can you see that? Fully coming out. And you will see
Too
that.
good,
That's
sir,
the polyp,
too
okay?
good.
So all the polyps are out. Now we'll just have a look at the final view.
Sir, any post-operative advice for this patient? Will you be putting her on estrogen progesterone?
Ma'am, no, there is no need of estrogen progesterone, because you see there is a polypodal endometrium this patient has. Okay, so it's better not to put such patient on estrogen progesterone. You will harm the patient than benefit. The rest of the area which you have done the metroplasty is not adhesion, ma'am. Okay, so without that also the endometrium was quite thick and nice, right? Without my metroplasty, like you went in with, at that time polypodal endometrium was there. That means endometrium is growing well. So only in the Asherman cases or uterine adhesion cases you will give estrogen. In metroplasties or a septum also I don't give estrogen, ma'am. Giving estrogen in this case has no use, but I will put a balloon for her. We need a pediatric Foley's number 10. Okay?
So for how many days, sir?
Generally 10 to 12 days.
10 to 12 days.
Yes ma'am, not 5 days, not 6 days, not 2 days.
3 ml saline. And
Yes, for this particular cavity, ma'am, you must always estimate the cavity and then put the light off, and then only put the fluid in the balloon. If the cavity is small, like in the infantile uterus, then only 2 ml or 2.5 ml is sufficient enough.
Otherwise the patient will deliver the balloon on day 3, day 4. So you don't want to deliver the the balloon. You want to keep it there till the healing has occurred.
So that means if you are putting the Foley's catheter,
light बंद करो ना.
that will also take care of the bleeding. If
ऐसे भी बंद होगा ना, change करेंगे. Yes, true, ma'am.
Yes. So, thank you, Dr. Harish. It
Yes.
was a wonderful and fascinating surgery.
Thank you, ma'am. This you must see.
Especially the metroplasty.
Switch on this, ma'am. You will see now what I do. Yes, ma'am. Metroplasty is very, very interesting subject.
Yes, it was
Syringe,
really
syringe,
very interesting
syringe.
and fascinating
5
to
cc.
watch. Congratulations. and
Ma'am, I am
thank you
going to
so
show you
much.
something here. If you can see, external camera can be made complete full. And saline nahi, distilled water le lo. Never instill the Foley's catheter with saline, because salt can get sometime crystallized. Okay, so what you do is first inflate with the air, ma'am. You can see here. Are you all seeing the catheter? Now because I have done the fundal metroplasty, I don't want this hard tip to go inside and cause a small hole there. Okay, so what I will do is scissor. Sterile scissor, please. No worries. So you cut the tip.
Okay.
Okay, but you have to first inflate the balloon. Otherwise, if you cut just like that, sometimes the balloon is cut. So inflate with air. Aram se. Yes, thank you. So you cut the tip. Okay. So I have cut the tip. Okay. Now I will deflate it, and I also put a catheter in the office procedure. And the patients are really very comfortable. Actually, it's much ideal to do it that way, because the patient will definitely tell you that
in the office procedures also you put for 14 days.
For 12 days, ma'am. Yeah.
12 days.
Ma'am, a patient will come out of anesthesia any which ways. So for 12 days, whether it is office or non-office, patient is going to experience same post-operatively. Light de do, please. So only thing is, ma'am, in office it is very objective. The patient will wince with the pain when you inflate the catheter. Yeah, दोनों पकड़ना पड़ेगा आपको. डिस्टिल वाटर है ना ये? हाँ, लाइट करे लाइट. हाँ. So ideally you need a long artery. Ask the assistant to hold the cervix and the speculum both, and then you just put in. If you have any doubt, you can either do hysteroscopy to check it is in the uterus or no, or you can do sonography. Okay, on sonography also you can make out. Now see, always all this is air in the catheter. Okay, so you have to remove the air from the catheter first. So you see how much air has come out. Okay, you see now it is flat. This was the air here. So you remove the air part, and now I will put only this. Keep it pressed here, because you don't want saline to be here. You want saline to be in the balloon. So slowly put in then. Otherwise it will get inflated here.
It happens.
Yeah, I know. Because of uterine contraction.
All these things were happening, sir, but we were not knowing the reasons.
Okay.
So these small tips are also
Now
very
see,
important.
then you just give a small tug. You see now it is in the uterus. It's not coming out. Now I'll show you another trick of making the knots. Now we hold it in the left hand, and the right hand make a gynac, okay, gynac pose, and then cross your hand, and then you grab it like this, okay. It makes a good knot. Now your hand, this hand will hold above the knot and remain on the patient's buttocks, and this one will pull. Okay, so you see there is no pull on the internal part. Okay, so only then this becomes tight. When it becomes tight, the angle in the catheter has to be there. If there is no angulation, means it is loose. Okay, so otherwise it will leak out and patient will deliver in the ward, and you will see that the catheter is lying in the bed. Okay, so you can put 2 knots and then cut below the knot. When she comes for removal, you have to just cut above. Not have to put speculum valsellum. Just remove it out and then cut above the knot. It will deliver on its own. Okay? And if patient delivers at home, there is no problem, nothing to worry. Tell this patient that you might see something, okay, coming out when you go to the washroom or something. There is nothing to get worried about. You can easily push it inside with a clean hand. Okay, so that's it. That's the end of the procedure. Thank you so much. Any questions?
No, sir. It was a very good tip. And
Now, if you
we'll
see
be
here, the
waiting for
fluid-
more tips and tricks from you. Any questions from the
10 to 12
audience?
days. 10 to 12 days.
So how do you feel about metroplasty? We have many IVF surgeons over here. I would ask them what they feel about metroplasty and
Yes, ma'am.
your
So, yeah.
idea about metroplasty.
So, I already said that it is
So
not...
the lateral metroplasty basically.
Yes. Most of the people do lateral metroplasty when the endometrium is not growing. Now, generally, I would not say that you should do metroplasty in all the cases of where the endometrium is thin or it is fibrotic or if there is a dysplastic endometrium. It will not improve. It's only meant, metroplasty is only meant for the people who have dysmorphism diagnosed on 3D sonography. Are you getting my point, ma'am?
Yes, sir.
But
And
not
we-
on HSG or not on hysteroscopy.
We have IVF specialist,
Yes.
Dr. Renu ma'am.
Yes, ma'am.
Ma'am, what is your take on lateral metroplasty? Because the IVF specialists, they stress upon getting it done.
Yes, true.
Somehow I'm very afraid of the uterine cavity. I
Yes,
just
ma'am, absolutely. You should not do in left, right, center. Metroplasty is not
just
meant for...
don't feel like damaging the endometrium. That is why I like the hysteroscopic morcellator, the mechanical one, so that you don't destroy the endometrium. You don't put energy into the endometrium. No chemicals inside.
Yes,
no
ma'am,
foreign
true.
bodies inside.
Yes.
So that
But
is my
Caesar
take on that.
is another way of doing metroplasty because Caesar there is no energy used, only the fibrosis cut. While Caesar also gives you tactile feel
Yeah.
when you are doing it. It's much better than using resectoscope. Resectoscope should not be used in infertility cases, ma'am.
And many a times when the endometrium is very thin or not growing,
Yeah.
you can put them on a few months on estradiol so that they develop the endometrium. Many a times initially they don't respond, but
True.
putting them on 2-3 months with caution, of course, the endometrium grows.
Right, ma'am. Yes, true.
And sometimes if they don't grow, we can try stimulating them with gonadotropins, and that also gives them a good endometrium.
I'm fine. Actually, doing metroplasty will not grow endometrium. That is the message. Many people have this notion that doing the metroplasty will grow endometrium. Right, ma'am?
It only increases the space inside.
Yeah, that's what. If there is true dysmorphism, that too, true dysmorphism, then if it is, because of the uterine pressure during hysteroscopy, it is not very nice way of doing it.
It's a kind of stimulation also to the
Yes,
body, and
true.
sometimes it helps.
Third case?
Can we have the history of the third patient?
So just now we had demonstration of such beautiful case, and now our next case is ready. She is 33 years old, and she is also a case of primary infertility with cervical stenosis, and her TVS also shows poor receptivity score. So we will also be doing PRP installation
Ready?
in this case, and PRP is ready already.
Do we have the needle? Are we just instilling in the cavity? There are two ways we can do it.
Actually, yeah. Okay.
There are two ways we can do PRP installation in the cavity. One is just inside the cavity and keep a, yeah. And another is subendometrally. Subendometrally is with the syringe, with the needle, sorry. There are subendometral, no? So then we need a needle, embryo, yeah. The ovum pickup or did you all get the history of this patient, ma'am?
Hello.
उसमें से लेना ले लो सर. Is the audio on?
Hello.
Yeah.
There is one more important finding in this patient, and that actually she is for IVF, and during her mock embryo transfer, it was a failed attempt because of the cervical stenosis.
Oh wow! So that is a good. ये
So
light
that
कहाँ है?
is
Light
another indication of hysteroscopy here.
कहाँ है? कहाँ है? कहाँ है? लाओ लाओ लाओ. मिला कि नहीं? अरे हाँ करना है वॉश बेटा करना है.
Hello, Dr. Harish.
Yes,
This is,
ma'am.
I am Dr. Sumita Arora from the
Hi, ma'am.
audience.
Hello.
I just wanted to clear a doubt. Like you had done one first case in which you had negotiated into a difficult internal loss,
Yes,
and
ma'am.
again we are going to deal with the same patient. We just want to know the tricks so that we do not create any false passage. We are
True.
not under any lab vision at that time. So how, if it is acutely anteverted or it is acutely retroverted, and if we haven't done ultrasound or an MRI beforehand, so how would we prevent making of any false passage and perforating the uterus at the internal os?
Yes, ma'am. Very
so
good.
while
very
doing
good
this
question,
case,
yeah.
please.
Yeah, I will demonstrate
explain.
that. The few things you have to notice in this case while doing hysteroscopy is that it is under vision. Everything is under vision. When you don't see anything in hysteroscopy, you have to come back. It's like suppose you're walking in a room which is dark and you're throwing a light. The light will not be falling into the area which is deep. For example, suppose if there is a turn in the room, okay, on the left side and you're showing the light straight, the left will appear dark. Are you getting my point, ma'am?
Okay.
Because the light is not falling there. Once you approach there and turn your light towards left side, then you will see their light there. So basically same principle applies in hysteroscopy. When you are doing hysteroscopy, whatever dark is, that is where the space is. Because void absorbs light. The space absorbs light. Okay, same way you see sky is dark in the night because it absorbs light. So wherever there is no light, you have to go there, not where there is light. So when you don't see anything, if the picture appears completely red or pink, you are supposed to come back. When you come back, you will definitely see something there. One is that. Second is check for the debris and the mucus. The secretory epithelium of the canal, uterocervical canal, is secretory and you will see the secretions. So that will take you there. In a very, very difficult cases, suppose there is a very difficult case of negotiation and people have tried multiple times, and you can do another idea is that you can take a methylene blue and very diluted methylene blue and instill that before going inside. So that will take a path of, so you will see the blue color path. In a very rare cases, ma'am, any extremely rare. But
Okay.
generally with mucus and debris and looking at the secretory epithelium, you can easily negotiate. I will show you. I will show you in this case.
Thank you so much.
Are we ready? Chalo. So the cable has to be always 6 o'clock. Okay. This is how you hold. Yeah. Yes, no problem. Yes. ऊपर लगेगा बेटा. आपने उल्टा पकड़ा ना इसके लिए बेटा. हम ऐसे पकड़ते. So another thing that I want to show you is the assembly and disassembly. So I can show you the disassembly as soon as we are over with this case. So you will be able to keep the. ये सब अंदर है एकदम नहीं ये बाहर जाएगा पानी. No, so this has to be completely inside, otherwise. Yeah, okay. क्या हुआ? All right, okay. Yeah, I'll show you. Okay, balance kiya. Okay, so basically when you hold the camera like this, the cable is at 6 o'clock, and the output, there are 2 openings down and 2 openings on the top. Okay, so 2 openings are outside, is the light and the outlet. Okay, and both of the things which goes in are on the top. The things that goes in is fluid and the instrument. Okay, so whatever goes in comes up. Okay, of course the light also goes in, but light just falls here. It does not go in like fluid or instrument. Okay, so if you see, this is down and this is 2 up. So this is how you hold. Then you start the fluid. Don't touch the patient. Okay, just go like this by lateral movement, and then as soon as the column is filled, you swim like underwater and reach the posterior fornix. First you touch the posterior fornix. Now you see what, madam, I was telling you. When you don't see anything, means you see. Are you seeing anything
Reverse
now?
VIP, please.
Inside picture, please.
Inside picture is there? Okay. Is it there, inside picture now?
No, we can't see. We are only seeing you.
Oh, okay.
Inside picture, please.
Inside picture, please. We've seen enough each other. We want to see the uterus. Yeah.
Which I learned that the rain falls from above and the sun rises from below.
Yes.
So the
Light is always above.
Here, reverse VIP.
Okay, now there is the picture internal. Do you have internal picture?
No.
No?
Now we have.
शुरू हो गया? Okay.
Yes.
Now see, this is posterior fornix. Okay, is it audible? Am I audible? Hello?
Yes, sir. Yes, sir.
Yeah, am I audible?
Audible, yes.
Okay, so now see, I was telling that when you don't see anything means of course you will see some circle there, some pink color there, but you don't see what you want to see. When you don't see anything, come back. Means right now you see only pink halo there, right? That means I am too much inside somewhere where I have stuck. I don't see the canal there. So that means I have to come back. This is the principle of hysteroscopy. So I come back and now I can see posterior fornix. Can you see? There's the posterior fornix and this is the cervix. So you come back and that's the cervix. Can you see now? Hello?
Yeah, we can see.
Yeah, okay. So now can you see the secretion?
Yeah.
So that means, am I right? I am in the proper place, right? Where the secretion occurs is the cervix. So now I will follow the secretion, okay? So I will follow the secretion. And what I wanted to see is this, okay? Alright. So now all of you will see something very interesting, okay? Is the canal is going down, okay? You can see that? The canal is here. Now you can see all the crypts are converging to one place. Very nice picture. Can you see? These crypts are going at one place. You see this crypt is going there, this crypt is going there. All the crypts are converging at one place. That is called internal os. That's the internal os. Now you see that? Once you go there, you drop the camera down. You see physically here, my hands are seen? Hello? नहीं बड़ा हुआ है but no, I don't know whether they are hearing me.
Yes, sir.
Okay, perfect. Then
Yes,
it's
yes.
fine. I don't need to hear them. If somebody tells me that they are hearing, it's fine enough. So when you see the internal os at 12 o'clock, you have to bring it at 6 o'clock. How can you bring 12 o'clock os at 6 o'clock? By making the camera fall down. Okay, not completely down on the floor, please. Don't take my words exactly how it is. Huh? Fall down means just allow it to go down. So that 12 o'clock thing migrated down. Okay. So I go there now. Now I can't see anything, right? So principle is come out. But I know it is here. You see, I can see it's here, right? So principle is to come out, but I will see some part, and then start negotiation. So keep eyes there. Can you see the small hole? Hello?
Yes, sir. Yes.
Can you see the black thing there? Yeah. So keep it at 6 o'clock and then just go negotiation, 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 and you are inside the cavity, ma'am. You will see now. Okay? See the entire os now. This is disturbed endometrium here. Okay? And with negotiation, I am gone inside the cavity, and that's the cavity. Did you understand?
Yes, sir, very well.
It's clear now. So what I did is I just followed the debris, ma'am. See this mucus. I follow. Then I automatically saw the crypts. When I saw the crypts, I saw where they are converging. They were converging here into a small stenotic os. Now see how it is. Is it nice? So this patient will have no problem in mock ET now. Okay, once you correct that. But this patient definitely has. Okay, can we have the suction on? ये खोल देंगे. कोई आएगा यहाँ पे? Romil. So, can you see what is this here?
Shiny keys.
No, that's what. ये खोल दो. और ये suction connect करना है इसको. ये जो tubing है ना, सुन ना वो छोड़ दो.
Tubercles.
Yes, that's fine, no problem. So these are not synechiae, okay? Believe me, this is not synechiae. Because synechiae cannot have endometrium coming on it. Very rarely, if you have a thick band of adhesion, only then you will have. So this is not synechiae. Some people also say that this is adenomyosis. It's not compulsory that you will see this. This is basically nothing but a myometrium. So I will reduce the flow completely and you will see it disappear.
That means thin.
Okay, you will see now.
Yes, thinned out endometrium.
Yes, you are right. And the endometrium is always thin in the area of fundus and lateral wall. Now see, it is gone. Can you see?
Yes, yes.
So I have reduced the flow and see the vascularity. It's beautiful. So there is nothing, only the thin endometrium making the myometrium very, very, nicely coming. But of course, this patient has slight dysmorphism. If at all, if there is any evidence of that on sonography somewhere, I can correct it. Otherwise, I can just leave this patient alone and we can do PRP, because this patient, generally the patient who has stenosis, do not develop good endometrium. The moment you correct stenosis, they start having natural growth of endometrium, because outlet obstruction is one of the sign or one of the leading cause of poor endometrium. Whenever the outlet is blocked, the internal os is blocked, generally the endometrium will undergo atrophy because of something called as atretic amenorrhea process. Okay, so this is all that I am removing out. Okay, it came out. Again you go inside and I will show you the internal os, beautifully oval. All internal os is oval in shape, it's not circular, believe me. Okay, so we'll remove the endometrium. We'll study the endometrium very well for infertility, how it should be studied. Most of the time it is not given in any book in a standard manner, that how to study endometrium at hysteroscopy in an infertile patient. Okay, so I will show you what you should do is, first and foremost, you see that the endometrium is uniform. Means, are there any areas in which you have no endometrium at all? Okay, then you see the order of endometrium. Means, are the endometrium glands enough? Okay, so I will show you one by one all the factors. Let the cavity get clear. Can we have suction on? Suction is on.
Picture, please.
Yeah, is not there inside picture?
Reverse the PIP.
Yeah, we will have to wait for a clarity to occur. Just a minute. Can you see the glands?
Yeah.
So, can we have the suction? Is the suction on? Yeah, okay, perfect, fine.
Sir, what are the pressure settings right now?
The pressure is set at 100, okay, and there is a suction of almost 60 for a while, okay. Now see what I am seeing, endometrium is not very regular. I will come to it. So first you see, do you see endometrium everywhere? Yes, I see endometrium everywhere except in the area of fundus, right? So you can write this down. Now check the lateral wall also. You can see that there is a fibrotic ring here also. Can you see the circular endometrium here?
Yes.
So concentric endometrium is not a good sign, okay. This is very nice. You see this wall, compared to this wall has concentric endometrium. Don't worry. You see that? Can you see? So that is not very nice, okay. So we first notice that how much endometrium is there. Only in the fundus and the lateral wall the endometrium is absent. Posterior wall, anterior wall, cornu, everywhere the endometrium is there, okay. Second will come is uniformity. Now we see bump here is not good. Second thing will come to the size of endometrial glands. Now if you see here, all these glands appear same grossly. Hello, I want answer from you guys. Does this endometrium gland appear same? Yes, right? They are appearing similar size.
Yes.
The dots. Now if you see here, are they appearing same? No. You will see, I will point out the endometrium glands which are bigger, okay? So this is not an ordered endometrium, this is disordered endometrium, okay? They are not in order, that's what the idea is. They are not same standard. Some standard 7 student is there in standard 3 class. So see, all these glands are big. This one, over here, this one. Sorry, 1 second, I'll just clean the... Okay, this oh, is not clean. I'll clean the grasper and come back. Okay, fine, ho gaya. Okay, see this gland here is bigger as compared to other glands. So similarly you see here, this endometrium and this endometrium is not same. Are you getting me, ma'am?
Yes, sir.
See, this endometrium is folded, while this endometrium is polypoidal, polyp sort of thing. And plus hyperemia. Can you see this patch here?
Yes.
Is not good. So this is disordered endometrium, okay. One of our international colleagues has done a beautiful study on this, and it's called the IISP, okay. So this is inflammatory disordered. You can see the micropolyp here.
Yes, we can appreciate.
I will show you that. 3 micropolyps I can see here all together, okay. If you can see, one at the tip of my instrument, 1, 2 and 3 here. Can you see?
Yes.
So these are the micropolyps. You will also see micropolyps other than this. Over here, can you see micropolyps? This one.
Yes, sir.
So that means that this patient has more or less a disordered endometrium. Now here also, can you see this micropolyp, right? So basically by removing this endometrium, she will develop very good endometrium. But we can also do PRP if they have seen that. Now I'll do the groove test. You can see the thickness of the endometrium now. Can you see? And can you see the lines?
Yes, sir.
Yes.
And see the blood vessel reaching right up to the top of the line.
Yeah.
This is vertical endometrium. Okay. What first we were seeing dot was a end-on view of the endometrial glands. Now this is the vertical line what you can see here. You walk through and you will see all of them standing like soldiers in one line. Can you see?
Yes, we can appreciate.
Both the sides you can appreciate. See that? And the blood vessel is reaching right at the top. All these blood vessel parallel to glands. Can you see? Yes. You see here it's beautifully appreciated. So if you see now, so this is called the furrow method of testing the endometrium or checking the endometrium. Okay, this is physical. You can see the glands here also. and the blood vessel reaching right up to the gland end. So this in my view is fantastic endometrium. You see the thickness is quite good. Okay, you can see it's almost 3 millimeter here, not fully 4 millimeter. No, this is 11 millimeter when it's open. Okay, so you can see half of it at least. So it's 5 millimeter on one side. So you will definitely also have thickness here also nicely. So we'll see there also thickness, and see that. Can you see the glands?
Yes, sir, yes.
See the glands here. So this endometrium is not thin according to me, but if
So
we are
this glandular picture is normal. Matlab, these glands are
these
normal.
glands are normal,
Okay.
but what is not normal, I'm going to take a biopsy of, is this bump sort of thing, okay, which was there in the beginning, this area. So this is how you take the biopsy. You break and then you come back again. So break and you open. Don't try to avert it. Just push, not pull, okay? So push and leave it. And you see now it's like a polyp hanging there. Okay, so now you can just take it, and you can also appreciate the glands in the broken endometrium there. Just a minute, I'll show you, okay? This grasper is not leaving. See the glands?
Yes, sir, yes, yes.
Yeah. So this in my view is a good endometrium for fertility, but in case if the patient has recurrent implantation failure and you want to do the PRP, I can just do that. So I have removed this.
So the consultant in charge
Yeah.
now doesn't want
No,
PRP
no?
in this case, sir.
Yeah, this is a very good, I think she will do very well without that. Now you see the endometrium, okay, the canal, whoever is taking care of her, ma'am, you, right? So you see it's a straight canal, you go like this, it's a straight axis, okay, here. Only after this there is acute antiversion. Okay, see that?
Inside picture.
Is there, no? You got it, ma'am? There is no fibrosis, nothing now. All is out.
For the sake of the delegates, can you show the PRP in the fundal area where the endometrium was thin down?
Ma'am, Sheba, Fatima ma'am, we have another case of PRP.
Okay.
One more case in which we will show.
So basically, my take on PRP is not very great because we still don't have much of data on this. But yes, we can do it if the patient is really keen on, and there is a recurrent observation by a gynecologist that patient has thin endometrium not growing beyond 5 millimeter. Thank you very much. Biopsy Liliana. Thank you so much.
Any questions from the audience?
So did you see how beautifully the endometrium evaluation is on hysteroscopy? If you see the furrow method of showing it, you see vascularity, you see regularity of the gland, you see micropolyps, you've seen the axis of the uterus, all this will go on your notes so that the consultant who is taking care of IVF part will know what exactly is this patient's information. So you will notify the outer cervix how it is, internal canal, the axis, the fibrosis at the canal in the beginning, and all that is removed with the grasper, and then the axis is made straight, endometrium evaluated, and the biopsy taken. Yeah, thanks.
Thank you, Dr. Harish.
Thank you so much, ma'am.
Wonderful demonstration of the surgeries.
This
and
is okay.
metroplasty,
can go on
polypectomy,
and on.
and various types of the endometrium you have shown. So, any other questions? I think the audience must have enjoyed a lot. And with this, we come to the end of this session. And thank you so much. Thank you so much, Dr. Harish and the audience. Thank you so much.
Thank you so much, ma'am, for your kind suggestion. And now I request Dr. Sumita Arora, ma'am, to kindly felicitate our chairpersons. I request chairpersons to please come over the dais. Please, ma'am. Thank you so much, ma'am. Now, since we are running short of time, we'll move ahead towards third session. And now I would like to invite Professor Dr. Uma Singh ma'am, former Head of Department Obstetrics and Gynecology and Dean of Medicine, King George Medical University, Lucknow. And I am really feeling honor in inviting ma'am. And I think we all are well known about her, about her perfection and all. And second, I would like to invite Professor Anjana Agarwal ma'am, Head of Department of Hind Institute of Medical Sciences, Barabanki, as a chairperson. Ma'am, kindly honor us and please take your seat as chairperson. And I also invite Dr. Ritu Saxena ma'am, who is a renowned senior private practitioner at Lucknow. Ma'am, I request you to please be chaired in. Thank you, ma'am. Now I would like to request chairpersons to kindly introduce our speaker, Professor Nisa ma'am. Sorry, a small change is there. First speaker is our Sumita Arora ma'am.
Hello. Hello, I now introduce Professor Nisha Singh. She is unit head and in charge of genital cancer control unit at KGMC. She is vice president of our very own LOGS, secretary UP chapter of AGOI, secretary annual conference of AGOI, ACO ICON UP 2022 Lucknow, and she has a vast experience and many. So now I request Dr. Hello.
It's okay.
So, Dr. Nisha Singh will speak on AUB and hysteroscopy.
हेलो लगा दो नहीं इधर से लगाना पड़ेगा साइड में चलेगा ऐसे हेलो गुड आफ्टरनून
Yeah, hello sir.
Hello.
Good afternoon.
am I audible
Yeah, sir.
okay so this patient you saw already the history right what did assist pass me down saline le lo
So we are expecting a polyp or a submucous fibroid.
yes ma'am so first we will put a 5 millimeter Bataki to understand where is the what is what okay whether it is type 1 fibroid grade 0 fibroid or a polyp so what are the ways we can find out whether it is fibroid or polyp anybody can we make it interactive thanks so generally you check for the blood supply okay the fibroid will appear whitish in color one and will have a peripheral blood supply while polyp will have a central blood supply because polyp grows like a tree it has a root and not a peripheral supply myoma has a peripheral pseudocapsule and it is supplied ठीक है it's okay hey can we check it because it's a resection I want to see the fluid so can we have an empty bottle remove this ये निकाल दो प्लास्टिक निकाल दो यहाँ से बस बाकी कुछ मत करो येलो प्लास्टिक है ना दैट यू रिमूव इट जस्ट कीप इट एम्प्टी बॉटल any hysteroscopy when you do don't keep this bag because that makes the most difficult measurement of the fluid okay so we now because we are expecting some resection right from beginning you have to see that you are using fluid which is can you vent it properly and see exact amount of fluid नहीं वो नीडल है ना वो निकाल के 2-3 बार ऊपर से वो नहीं सुनो ना मेरी बात नीडल हाँ गुड बॉय yes make it proper round and see if it is 3000 proper this one has definitely lost some fluid that is complete 3 liter right so we have on the IV stand almost 5.8 liter of fluid okay so to start with we have 5800 and in the end we should have 5800 so let's see how to maintain that fluid so can we have the gauze please light on please laparoscopy light on please 5% है बढ़ा दो okay so I'll start now fluid on ये खोल दो सक्शन को लगा दिया वो भी खाली है कि चाहिए सक्शन भी खाली कर दो यस गुड ये खोल दो ये ओपन कर दो हाँ बस दैट्स इट ओके so there are some tablets there okay it's all
Can
right.
we have the inside picture?
Yes they are giving you inside picture
Yeah.
do you have inside picture now yeah
Yes sir.
so this is the external os can you see the mucus just follow the mucus and that's the internal os okay and which is having a polypoidal hypertrophic okay endometrium there which shows that there is cervicitis you can see okay this is hypertrophic endometrium in the internal os and you can see now the polyp saying hello to you all
Yes.
all right
Nice round one.
so you go undisturbed and then you will have proper picture now how you can see that this does not have a peripheral blood vessels okay big vessels like have you seen a subserosal myoma in laparoscopy do you see blood vessels like that no so this is mucosal polyp second thing it's a gray in color because the fluid in the polyp is absorbing light okay
Yes.
So it is grey in color. Plus you have supporting other polyps also. You can see that? Okay? Yeah?
Quite a few.
Alright, and then there are bands of adhesions or a fibrin bands which is there, which is adhesion to each other, and this is basically, so this is a polyp,
Yes.
and this could be fibroid. Okay, let's see.
White
Yeah.
in color.
Right?
Yes.
So this could be a large one, could be a fibroid. I don't know because it has endometrium grown all over. So we can't make out, but it could be fibroid, could be polyp. Anyways, this particular polyp is too big for it to be removed intact, okay? So what I will do is now we'll go with the resectoscope, and you can see that the os is open. Resectoscope le lo sister. So I will just arrange the resectoscope. I will show you the arrangement of resectoscope also. So that is our diagnosis you saw.
Yes, sir.
So I have stopped the fluid. We are going to now.
So
Now
you
you
can
see here,
switch
ma'am.
the
I am
P-
changing from.
So you
it
can
is
switch
possible,
the
ma'am.
PIP.
Now I am not changing my.
PIP.
I have just removed the fluid, not removing the camera and the light. I will just change the sheath, right? I don't have to change the scope. So I
Yes, sir.
change the scope. Sister, all of them. Take all of them. हाँ यहाँ रख दीजिए. Okay. Now, so first and foremost, I'll just put a handle of it. I'm going to use 6mm resectoscope, okay? A smaller one for this because this is not a very big. Then goes the loop. That's it. वो रहने दीजिए. कुछ नहीं यूज करेंगे वो. सिस्टर हो गया. Give me that cable. Clean करके. This cable. Not that way. आप रख दो 2 मिनट. वो टायर रखना आपके पास. So now in this is inlet, this is outlet. Okay. Okay. So that's the outlet. नहीं कुछ sparking. What sparking? Sparking हो गया वहाँ पे. Careful हाँ clean करो. Okay. Alright. So I am not using dilatation, I am not using speculum, I am not using valsalum. I am just going to do the resection without using anything of that sort. Now I want the sample not to lose it, okay? So I'll put in a gauze piece there. So all the sample will come in this. Okay? हाँ फुट स्विच यहाँ रखना है. So now you will see a fantastic flow, okay, and you can see now beautiful crypt, okay. Now
Can we have the inside picture?
Sometimes you can see this anterior crypt is so hypertrophic.
Inside
Do you have a
picture is not
picture?
visible.
Inside picture, please.
Inside आ गया picture?
Not yet.
Not yet.
Sir,
I'm okay. You can.
sir, you are not dilating the cervix?
No, ma'am, no. I'm not dilating. I saw in the beginning whether the os is good or no.
Okay.
The initial operative hysteroscopy was for that purpose. Not only to see the polyp, but to see the os also. If the os would have been not diagnosed, I would have given a lateral cut. But generally I don't dilate and go. Once you dilate and go, you disturb the endometrium, chances of fluid absorption is higher.
Okay.
Okay? So if you see Professor Osama, the great resectoscopic surgeon, also do not dilate. Okay? He goes without dilatation in resectoscope.
Still we don't have the inside picture. Excuse me.
Yeah, we are working on it. They are seeing it.
Don't worry, I will not proceed till you see.
Okay.
You will not lose anything. Okay? Don't worry.
Right.
कुछ नहीं.
We still don't have the inside picture, please.
Don't worry, you will not miss anything. I will not proceed till you
No,
say
no,
okay.
sir. We are actually, this is a signal for the audio visual.
I understand, ma'am. Don't worry.
They,
I'm just
they are
saying.
saying that we have to speak on
They are
with
working.
mic.
They
Then
are
only
working.
they will do it.
They are working on it.
So in the meantime, we are appreciating your cap.
Yeah?
In the meantime, we are appreciating your cap.
Okay.
And one more thing, sir. Any role of misoprostol, if the we are sure
Yes,
that
ma'am.
it's
Yes. So if you see, I mean, you don't have internal picture, but yes. So if you suspect that there is a receptoscopy required, you can put a misoprostol.
okay.
Preoperatively, it will ease out the dilatation. Any which ways, ma'am, intrauterine pathology like fibroid, large polyp will actually have a very soft internal os.
Okay.
Okay, because body is trying to remove it out. So generally, when you have intracavitary myoma, completely intracavitary, the os is very easy to pass on. But what you have to learn is only one thing called negotiation method. You definitely must be negotiating in shops. Now it's time to negotiate in uterine cavity. Okay? There was some spark, sister said. There was some spark, I think, and the cable is blown. There was some spark there. कुछ तो spark आया था वहाँ पे. हाँ, so इसके लिए वो केबल का इशू है. No, I'm not starting, don't worry.
ये डायरेक्ट कैमरे से मॉनिटर फोकस कर दीजिए.
Can we have the two cameras there so that we can see the screen and we can see the sir also?
Cutting 80 कर दो.
Please focus camera on monitor.
एक मिनट. हाँ कर दो अभी. हाँ, okay. Perfect.
I think what we can do is like one camera should be on the screen, that the monitor, and other one on the sir. So we can just, hello, anyone there?
आएगा, wait. That will be better. It's okay if they don't see me. They have anyway appreciated everything. Sir. नहीं नहीं ऐसी बात नहीं है.
Hello. Hello.
Hello?
Hello, Dr. Vaishali. We are now focusing actually
Light
there
on,
is
light
some
on.
technical problem.
Light नीचे light नीचे.
So we are focusing the
बड़ा, बड़ा.
external camera directly on the.
Okay.
Okay. So sir is saying you won't be able to see sir.
No.
Now we'll be
Okay.
seeing what you can do is in between you can show sir and then the
No problem.
monitor.
Don't worry. Yeah, sure. So can you see now?
Yes sir, but I think it should be, can you zoom it?
Can you come proper? अच्छे से दिखाओ यार. चलो बढ़िया दिखाओ.
So this is the loop sir you are inserting.
Yeah, we are using a loop.
Uh-huh.
And I have not yet. I'm
Yes,
just
it is
inserting the
better
anterior
now.
crypt. Okay.
Yes. So you're using the loop even for the polypoidal growth?
Yes, ma'am. I'm going to do everything with the loop only now. Okay. You see now?
Okay. Yes,
That's
sir.
the polypoidal what I showed you at the internal os.
Yes.
So I'm slowly just using the loop for that.
Yes.
Because otherwise the picture will have, if you keep on changing from operative to loop, from loop to operative, it's going to be very difficult. Okay.
Yes, sir.
So now I'm going to see, this is a polyp which was there.
Yes.
Okay.
Yes,
And
sir.
I'm going to now resect the polyp first. What is the basic idea of resection is that you should not be seeing your loop. Okay, the moment you see your loop and do it, that means you're not going to get the good, see the polyp is gone. And
Yes,
you can
sir.
see the glands which are now cut.
Yes, sir.
You can see beautifully the glands. So this was a mucosal polyp, okay?
Yes, sir.
So what you do is you see, you push the loop in.
Yes, sir.
Okay, completely. Then you hug the pathology.
Okay.
You first go on the opposite side. Suppose the pathology is on the left, go on the right. First the loop inside, then hug the pathology.
Okay.
And then slowly, when before touching you activate, and then you see it's gone. Can you see
Yes,
now?
sir. Yes, sir.
So activation time should be least.
Yes, sir.
You see now beautifully the glands are seen.
Yes,
now
sir.
those who say that the endometrium gets damaged, you still have some amount of glands.
Yes, sir.
And if you see in resection, generally the temperature at which resection works is much less because the fluid is continuously changing.
Okay.
Okay?
Yes,
So
sir.
you can see now all this polypoidal endometrium is coming out. I'm sure, but still the IVF people will not like it if you do this or not. So what I generally do, if there is a polypoidal endometrium like this, I will use MVA syringe.
Okay.
And remove all the polypoidal with manual vacuum aspiration because there is no energy in that.
Yes, sir.
And all the polypoidal will come out easily.
Okay.
But then if you have to do resection after MVA, it's not possible. Okay? So now I'm going to do here. You can see now. So I'm going to see the base. Please do not resect the base. There is a new concept now to take the base out and leave the pathology inside. Okay?
Okay.
But for that you need a biopsy at least. So you take out the biopsy like this. Okay? This is going to move. Okay? So what we are planning is, in this case, is something called a slicing technique. Let's see if it works out. What you should do is just make two half and allow this to go on the other side. Okay?
Yes.
So that is one out. So this is not fibroid. This is a polyp which is mucosal polyp because you can see the gland inside also.
Okay.
Sir, it's a bipolar resectoscopy.
And it's an adenomyotic polyp. Can you see the fluid coming out with hemosiderin?
Okay.
Yes.
Can you see?
Yes,
See that?
Yes.
So this is an adenomyotic polyp. I don't need a histopathology.
Okay.
You got it? Only and see the gland here. Can you see the cystic gland? Now see the size of the other glands vis-a-vis this gland. This is like a tall, a monster gland. Okay?
Yes.
So this is definitely going to have disordered endometrium is one of the sign of polyp. Okay?
Yes.
So So now I'm going to just go at the base, because to reduce the time of the surgery I will have to do that. Can you see I am still at the base only?
Yes.
Only at the base. This is the base.
Yes. And you're not touching the.
Yeah, not touching the myometrium or anything else. Just cutting the base now. And I'm going to take it out by using some other methods, because it's a very soft polyp. Okay?
Okay.
हो गया, case is over. Yeah?
Yes. Go on.
So this is like doing a polypectomy with resectoscope is like killing an ant with a tope. Okay? Actually I would have preferred to use only a bipolar needle and done 2 slices of it and come out. You see now this polyp will come out easily because it is soft and it's rotating. Can you see? It's free.
Yes.
Okay? That's the base of it. That is the base. What are these bubbles? Can anyone tell me?
So even if you don't take out the polyp, then also it will come out on its own?
Yes, it will come out on its own, but I will definitely take it out here.
Okay.
I will not keep it, but if you don't take out also it comes out on its own. There is no problem, okay?
And all these irregular surfaces here?
No ma'am, that is only the endometrium after the fluid has gone there, edema. Okay. This is endometrial edema, okay? Because of my hysteroscopic procedure. It was not there to begin with. Did you see the first time when you did a diagnostic?
Yes.
This is the os, the ostium, tubal ostium. Can you see?
Yes.
So initial picture for that reason only we took it. Now see, this is all edema. Okay?
Okay.
All this is edema of the endometrium because of hysteroscopy. So now all this is coming out. You can see the pieces are anyway coming out.
Yes.
So I will have to use either the ovum forceps. Oh, it's coming out already. You can see that?
Yes. The uterus is pushing it out.
Yes. Okay, so it is stuck now at the internal os. So I will go and pick it up. There are various ways to remove it. You can either take a tenaculum grasper, light off please. But straight way is to just speculum also. Speculum. किसमें?
Scope is out.
So all the polyp pieces are here. Whatever we have.
Can we have the outside picture?
Yes, you can have. Now the focus here, please. Light on, please. This light. चलेगा सिस्टर. It's okay. Don't worry. Don't worry. नहीं आएगा. So I'm just going to just keep it there. That's okay. No. Okay, so it's not going to come complete out easily. Let's see again. No worries, sister. Oops. लाइट कम करो ना.
Light off.
नहीं, it's okay, चलेगा. नहीं, वो ठीक है. It's not coming out easily. Okay. That's the polyp, right? Let's see now. Hold this.
Sir, how much is the cautery current?
Yeah, 80. So generally you start with 50. So I started with 50. Leave it. ये पकड़. Generally I start with lowest current. Okay. So I started with 50, and then I judge how it is cutting. Okay. Generally mucosal polyp will require 50 to 70 watt setting. But if myoma is there, then it may require 80 to 100. But rarely, sometimes if the myoma is degenerated, sometimes like that, the resistance of degenerated, fat degenerated myoma is quite high. So that requires higher current. Otherwise, only cutting. Coagulating I use only for blood vessels, which is seen at the end. So at the end of the myomectomy or polypectomy or anterior creep resection, whenever you are going to do, say, sorry, she has pain. हाँ ये पकड़ो, ये पकड़ लिया मैंने.
So since how long you are using bipolar resectoscopes?
Almost 8 years.
And what, other than these safety things, what other benefits?
So the benefit of safety in bipolar is that you don't have to change from fluid from saline to glycine. That's the biggest advantage, because most of the cases you need to do a diagnostic hysteroscopy, and under saline you use glycine for both, then it becomes too much. So first and foremost, you don't have to change the medium. You can continue hysteroscopy. Yeah, that's the polyp. Okay, it's out. So you can reduce the resectoscopy timing by conventional method also. It's not mandatory that you have to do, the complete resection of the polyp. You can do partial resection and remove partial of it, and then at the end you will see. Now I will just go and see. All okay? Now see, the uterine cavity is contracted and you see the endometrium. Can you see? Focus वहाँ पे ऊपर screen पे. Hello?
Yes sir, yes sir.
Can you see the polypoidal endometrium? How much edema is there now?
Yes, sir.
So this is all endometrium folds, okay, and nothing else. So you don't need to do anything for this. You can either do DNC also is fine, but otherwise she is doing well. See that? There's the cavity is completely empty. So I'll gently do the curettage for that endometrium to be shed completely. That's it. The case is over. Thank you so much. एक्यूरेट है ना? हाँ मैम, या लाइट मिलेगी? एक मिनट से यही देते हैं, ये छोड़.
Any questions from the audience?
हाँ, इसी बंद कर दो. She is shivering.
Sir, what are the post-op advice for this patient?
So this patient, ma'am, basically because she has polyp, I will wait for the report what polyp it is. Most likely this is adenomyotic polyp, so probably chances of recurrence is not much unless she has some other underlying cause. But because there is disorder endometrium, this patient can be given, if she is not fertility patient, then can be given 3 months of OC pills, and with that the rest of the polypoidal endometrium will get suppressed.
Sir, any
But
role of
whenever you send a
Foley's?
polyp, you must send adjacent polyp endometrium also for pathologists to understand. You got my point, ma'am?
Yeah. Sir, you have done an extensive resection,
Yeah.
and there is a loss of endometrium. So do you plan to put an inert IUCD or a
So ma'am, IUCD is actually detrimental for any cavity wherein you have put in a where you have done an operative. IUCD should not be put.
So sir, you will be putting a Foley's?
Foley's, no, I will not put for her because ma'am, endometrium base we have not resected anywhere.
Okay.
You got it?
Okay.
So basal endometrium is intact everywhere, all through. It looks that it's like you have erased only the multiple story of the building. The basement is still intact. Okay, so I have got the endometrium also. So we'll send polyp and endometrium for histopathology.
So sir, in such cases,
Yeah.
you are giving whether it is a submucous fibroid or a polyp or
Yes.
in every case you are giving an OCP, and then after the next month you can do hysteroscopy in any day of the cycle.
That's true, ma'am. Yes.
Okay.
So that is for preparation. But suppose now you are asking for the treatment.
Okay.
That this patient has a polypoidal endometrium.
Okay.
So I suspect that there is either anovulation or hyperestrogenic condition or something which is amiss. So patient has to be given antibiotic and has to be given OC pills now for this polypoidal endometrial treatment, not for the preparation. What you said is for preparation. I do that for all patients.
Okay. Thank you so much, sir.
Welcome.
Any questions?
Yeah. So this particular machine you can see here. So this machine is Allen's Combimax, and it works with most of the resectoscope. You have a separate plasma generation. I will show you what exactly is plasma. Most of you don't know what is plasma, and then people come to you and say, ma'am, our generator is plasma generator, and then you can buy this, it is better. So don't fall prey to such things. All machines which is designed to work under water are designed in such a way that they generate plasma. Okay. Now you see the efficiency of this machine is, it works at 80 watts. Okay. It works fantastically well. So you saw the resection, the quality of the strip coming out at a very low temperature. It does a fantastic phenomenal job because there are various modes by which you can get that. So there is a low cut, high cut. High cut has multiple levels, and the effects are also you can modify. So this way you can get good effect. If your machine, if you know well, energy, if you know well, your resection will be very, very easy. So before adopting any technology, please go through the machine. Don't buy because I tell you or somebody else tells you that you must buy this machine, that's it. First, before buying any machine, know the machine well and see to it that you take demonstration, understand the functionality, and then purchase. Thank you so much.
Operative relay. And now I would like to felicitate our chairpersons, Professor Anjana Agarwal ma'am and Dr. Ritu ma'am. please come over the dais, and I invite Dr. And Professor Deepa Kapoor ma'am to felicitate the chairpersons, please. Ma'am, please come over the dais. Many of us must be waiting for the lecture of Dr. Sumita Arora ma'am for fluid dynamics and energy sources must know facts. So for the next session, I would like to invite the chairpersons, Professor Dr. Sonia Luthra ma'am. She is professor and unit head in the Hind Medical College, Safedabad, Barabanki. Ma'am, please take the chair, please. And next I invite Dr. Mohita Bhushan ma'am. Ma'am is a renowned private practitioner in the Lucknow. Mohita ma'am, please take the chairs. I also invite Dr. Pragya Tripathi ma'am. Ma'am is a renowned private practitioner in Bahraich. Dr. Pragya Tripathi ma'am, please take the chair. Ma'am, it will be more better to coordinate. I request chairpersons to please introduce our speaker, Dr. Sumita Arora ma'am.
A very good afternoon, everyone. Our next speaker is eminent gynecologist of Lucknow, Dr. Sumita Arora. As we all know, she has been performing laparoscopic and hysteroscopic surgeries regularly in her center. She has done senior residency from King George's Medical College, and she has done her fellowship in basic and advanced gynae laparoscopy from Gangaram Hospital, New Delhi. She has been trained and a fellow in obstetric and gynec ultrasonography also. She has been awarded with Best Paper Award in Young Author Foxy in 2004 and Best Paper Award North Zone Yuva Foxy in 2017. So we all know that her area of interest is laparoscopy, hysteroscopy, infertility and high-risk pregnancy. Thank you so much, Dr. Sumita. It's a treat to hear you today. Welcome to the dais.
Thank you, Dr. Sonia, for your kind words. A very good evening to all the delegates present here. It's an honor to speak here. Thank you, Vaishali. Thank you, Sonu, for inviting me here. So since the morning, we have been seeing such good cases being done by Dr. Harish. What is the trick behind doing the surgery in such an elegant fashion without causing too much of bleeding, without causing too much of loss of vision, and at the same time keeping the patient safe? So that is basically fluid dynamics, and we should know about that and the energy sources which we are using. So I would be taking a very few basic things also, so that the beginners can just grasp the topic well, and that they can apply while starting off with their hysteroscopy clinic. So I would be speaking upon these fluid dynamics and energy sources. So, a long time back when I started my career, I just had a chance to see two complications, and they were mortalities in a workshop, two workshops at different places, and that caused a very slow growth in hysteroscopy as well as far as I am concerned. So I took this hysteroscopy very late. After I started a lot of laparoscopy work, hysteroscopy was at a backstage. Then I realized that in the Western countries, hysteroscopy is being done by healthcare workers. They are not even doctors. So when I studied, then I attended many workshops. I spoke to many people. So the main cause of those complications is actually mismanagement of the fluid. The surgeon skill, the anesthetist skill is there, but yes, mismanagement of fluid, causing a fluid overload, not using the right current with the right fluid is another cause. So to make our surgery safe, we need to know about this and what current we are using. The main complications are fluid overload. In general, with a large diameter resectoscopes, the incidence should be less than 5%. If it is more than 5%, even a mild fluid overload or a severe fluid overload, then your technique is wrong. And the other rare one is also air embolism. So only if we master this skill of fluid management, we will be able to avoid 90% of these complications. So it is very important to learn what irrigation fluid we are using, what is the way we are putting in fluid inside the uterine cavity, what pressure we should keep inside the cavity, so that the vision is very clear and we can complete the procedure in a faster way, in a lesser time. So significant role is to follow some safety measures. Good equipment we should have. We should have a proper irrigation pump. The inflow and outflow monitoring should be taken care of by a dedicated person, and that person should not be given any other responsibility in your OT. There should be a separate person for the anesthetist, there should be a separate assistant for the surgeon, and a person should be dedicated to only seeing the inflow which is going inside and the outflow which is coming out from different places, which I would be telling you. Then there should be a use of proper current, as we all know. The point to understand is which fluid is safe and which current should be used, which irrigation pump or method should be used. Should we hang the bottle, saline bottle or the ringer lactate bottle or the glycine bottle on a drip stand and then push inside with a pump, or we should have a better thing to do so that we do it in a better fashion and we take lesser time, and so we can avoid complications. What should be the pressure setting of the equipment, how to check fluid balance, when to stop, when to abandon the procedure. A fast surgeon can do a big myoma in a lesser time, and a new surgeon can take a lot of time even in dealing with a small polyp or a small myoma. Can any steps be taken pre-operatively to reduce that fluid absorption? So which fluid and which current and why? So many years back, gas was used for putting inside the intrauterine cavity, but it is not used now because it has chances of air embolism and there are many chances of acidosis and collapse. Then came the fluid irrigation media. It could be high molecular weight fluid like dextrans. This gives a very clear vision because the blood will not interfere in the vision, but then it has anaphylactic reactions and they can lead to pulmonary edema, so it was also abandoned. Then came the low molecular weight fluids like colloids and crystalloids. So we need to understand what a colloid is. Like colloid could be glycine or mannitol. Urologists also use this and gynecologists also use this. They use it for prostate resection, TURP they are doing, and we use for TCRE and myoma resection. So this glycine and sorbitol, these are actually electrolyte free medias. They are hypotonic and they can, if fluid overload occurs with these, then it is little difficult to manage. So if you are using this colloid, glycine and sorbitol or mannitol, we have to be very fast so that fluid overload does not occur, because if it occurs, it is difficult to manage. The safer thing is a crystalloid. It could be a ringer lactate or a normal saline. It is safer because it is with electrolytes, and even if it is absorbed, it will not cause any problem. It can be easily managed by the anesthetists. They can give diuretic, Lasix and all, and this will not cause much of the problem. So fluid overload is possible with any type of liquid. It could be isotonic or a hypotonic, but the overload would be easily managed if we use isotonic media, Rimger lactate or normal saline. To prevent fluid overload substantially, we use isotonic media, and for this we need to use a bipolar current. Why a bipolar current and why not a monopolar current? Because if we use a monopolar current, the monopolar current has to travel inside the fluid to the electrode which is kept below the patient, and if we are using a Ringer lactate or a normal saline media, it will not be transferred to that return electrode, and so the current effect will not be there. So it is very important to use a bipolar current. If we are using a bipolar current, then we have to use Ringer lactate or a normal saline as a fluid irrigation media. So we can see in this case, it is a case of Asherman syndrome which I was doing a long time back. So in this also, if we are taking more time, then we have to use Ringer lactate or normal saline, because Asherman syndrome is a lengthy procedure. The distension media used should be hypotonic with monopolar current, that is electrolyte-free, glycine and sorbitol. We have already spoke about that. Electrolyte rich media cannot be used in monopolar as current will dissipate freely and it will reduce the power density and the effect. If we use a bipolar current, then the media could be Ringer lactate and NS, and so less complications will occur and less chances of fluid overload, and if at all it occurs, it can be managed well by a diuretic. Thus, we prefer a bipolar current and a normal saline or a Ringer lactate as a distension media. Use of bipolar technology, it prevents fluid overload, which it occurs in only 6% of the cases. It could be fatal if the surgeon is taking a lot of time. So that doesn't mean that if we use that bipolar and a good distension media, the complications will not occur. We have to be fast. After that, bipolar is itself better than monopolar. Why? Because the temperature of the surrounding tissue will remain between 40 to 70, while in monopolar the temperature rises to 400 degrees. If we are dealing with infertility patients, then we always speak about endometrial damage. So bipolar current is a very important thing which has to be used in nowadays when our patients, we are dealing with infertile patients. Bipolar will not cause burns, monopolar can cause iatrogenic burns. Bipolar will not interfere with the ECG and pacemaker because the return electrode and the dissipating electrode is in the same equipment, in the same hand instrument which is going inside. So it does not travel much through the fluid and through the body of the patient. So there is no interference with ECG and pacemakers, while in monopolar there is an interference. There is no electrical stimulation of nerves in bipolar, whereas there is in monopolar there is. Cleaner and sharper cuts we get if we are using bipolar resectoscope. We see that the sharper cuts are there. In monopolar there are less sharper cuts. More efficacious coagulation, bleeding will be lesser in bipolar, while in monopolar it will be less. So if we are going to start a new hysteroscopy system, our clinic, in our hospital, we should spend a little more money and we should go for good company equipment and a bipolar, instead of first buying monopolar and then dealing with complications, losing your confidence, and then shifting to, if you get the courage to reinitiate your choice of doing hysteroscopy. So we need to invest in good. Maybe we can wait for a few years, but if we buy from a standard company, good company, and bipolar system, and use good media for that. So which irrigation system should be used? Now we have discussed about the fluid, we have discussed also about the current, how we should put inside the fluid. These are the different things which are available in the market. There could be simple devices like gravity fall system is there. We hang at a certain height, the pressure which we get is something, we increase the height, we get more pressure, we decrease the height, then some person has to be there to pump always. So this becomes a very difficult thing, and believe me, when I was using the system, I could not see anything. Experts can see, but in the beginning of your career you will not see anything, and then you will stop doing hysteroscopy because that is a useless procedure and you can do with your curette and all. Then when we shift to this electronic suction and irrigation pump, this becomes a pleasure. It's just like driving a Mercedes. So the process becomes so simple, you see everything, you take lesser time, you waste less fluid, and like in the morning we saw that 3 cases Dr. Haresh did so fast using only 500 ml of saline, maybe 1 or 2 liters. If you are using this pressure, the person will be just changing the bottles, and while changing the units, some air will go inside, it will cause difficulty in vision, and there can be chances of air embolism also. So better not to use this. You should buy a good electronic suction irrigation pump. These are the simple devices. Does not maintain a constant intrauterine pressure. It is not ideal for operative long surgeries. It's okay for diagnostic hysteroscopy and if you cannot afford it in the beginning, but then if you want to go on for an operative work or little advanced work, you need to go for better things. These are the pressure sensitive pump. What they will do, there are 2 types of things, endomat and a hystromat. Little difference, but endomat is better. This we can use also in our laparoscopic surgery procedures. Hystromat will only be for a hysteroscopy procedures. So we better buy an endomat. Like this is a Hemao endomat. They monitor and maintain the preset intrauterine pressure. We can fix that pressure. We will be discussing how much pressure should we keep, but it maintains it to a preset pressure. It reduces the flow rate when the preset level is reached. It will not go on pushing inside. Thus reduces the total fluid used for distension. Like if the pressure is good enough inside and it is not leaking, that is the pressure is maintained, it will not pump in more fluid. So there will not be more extravasation from the tubes into the peritoneal cavity, and then the patient will have problem, bloating and all later on because of the fluid which goes inside. It will reduce the chance of fluid overload. It gives a gradual distension at the lowest possible flow rate, as high pressure can cause uterine contraction initially. So it will slowly increase the pressure so that the patient is comfortable. If you are doing office hysteroscopy, the patient will not feel the pain by somebody pushing it like this. The patient will have pain. So it will gradually increase the pressure, and we can complete the procedure even without anesthesia. Simple procedures we can do. What should be the pressure settings now? We need to understand that the thick muscles of the uterine wall needs a minimum pressure of 40 millimeters mercury to distend. So the pressure has to be more than 40 millimeters. The fluid pressure should ideally be between 80 to 100 millimeters mercury. Gradually the pressure should build up. It should not be like, it should not be giving any pain to the patient if the patient is under office hysteroscopy procedure. We should limit the pressure below 120. Why? Because it is the mean arterial pressure. After that, if we increase the pressure more than 120, more intravasation will occur inside the circulation of the patient, so the fluid overload can increase. So try to keep the pressure less than 100 from 80 to 100. Only we should exceed on 125 when we open the suction. If we have blood inside, we are doing some work which is causing some bleeding and we want to clear, we open the suction, we open the outflow tract, and then we need to pump in little more fluid because we want that fluid should come out from the suction and the pressure should be maintained. Only under those circumstances the pressure should be more than 100, otherwise it should be between 80 to 100. Some amount of fluid will go into the venous circulation, as subendometrial venous pressure is only 4 millimeters. This we cannot avoid, but if we keep the pressure below the mean arterial pressure of 120, we can avoid some amount of unwanted fluid overload. Now how are we going to achieve this good distension at a gradually increasing pressure? The answer is only one. We use pressure sensitive pump devices for irrigation, and there should be some person who is dedicated to seeing that what pressure is going on now in this case. Maintaining a slowly risen and steady distension below the arterial pressure of 120 without blood in the operative field is a must for long operative, and for this we need to buy a pressure sensitive pump. Now how to check this fluid balance? How much is going in, how much is coming out? Now we see that it is the most important part of the surgery. We see that inflow is the fluid which is going through the bags which are hung on the above the hystromat or the endomat. Now we have to have two bags by which the Euro bag is connected, both the sides. Euro line is connected from both the sides. If the fluid in one bag is over, the person who is standing there should just close that bag and open the other fluid, 3 liters or 1 liter, whatever we are using. The outflow can be from 3 places. We need to understand this, that the outflow is through the outflow channel of the assembly which has gone inside. Maybe it is our hysteroscope or it is our resectoscope. That outflow channel is going in, that outflow channel is going to the suction jar. So some amount of fluid is going in the suction jar. Some amount of fluid is coming out from the cervix besides this hysteroscope. So some amount of leakage is occurring through the perineum. It is going inside the drapes and it is coming down. And some amount of fluid is spilling also. So all these 3 have to be counted, and the person should take account of all these 3 things. The inflow, if it is going, if the 1 liter unit bag is attached above the endomat, after completion of that bag, before changing, he should see that what is there in the suction jar, how much spill it is, and so that he can inform when the fluid overload is going above the threshold levels, which we will be telling you. So this is also a very important part, because if we are using linen drapes to cover the patient made of cloth, then the spill you cannot count. So it is important that for hysteroscopic procedures we use these plastic drapes, and there are some drapes which have this collection reservoir present in them. We can go for them, and so that no spill occurs on the floor, very less spill occurs on the floor, because that is difficult to count. There are systems which are available, closed systems, but they are again expensive. So we can do away with them by using these drapes, plastic drapes. Mechanisms should be in place to, these are the guidelines which I have jotted out from the RCOG things. So mechanism should be in place to monitor fluid deficit during operative hysteroscopic procedure. Closed system should be used as they allow more accurate measurement of the fluid output. Drapes that contain a fluid reservoir gives a better estimation. Measurement of the fluid deficit should be done at a minimum of 10 minutes interval. Like the person, if he is standing there, every 10 minutes he should see himself. And if the fluid overload is going above the threshold, he should speak loudly and inform the anesthetist as well as the surgeon, so that they know that what they are doing and what they are heading to. One dedicated person should be there. He should speak loudly enough to make his voice heard. So this is the closed system. We can see that this is the fluid bag which is hung on the top. Below is the hysteroscope which is going inside. One is coming from the irrigation outflow channel. It is going into the jar. These jars are below, and some is collecting in the reservoir bag, and some is being spilled. This H is being spilled, and suction is used for that. Their systems are available which can also suck the fluid which is on the floor, and they can capture that fluid and suck that fluid and put it into, so that there is a proper estimation of the fluid going inside and coming out. So this is called a closed system. Obviously this will come at a good price, but then if you are going into advanced procedures, it is better to have them if you are doing a lot of procedure work. How to prevent spill or leak? We can use small diameter. Like in the morning, Dr. Haresh was using Bitoki 5 mm, 2.9 mm scope and 5 mm. For this 5 mm scope, we need not dilate the cervical canal. So even I am not using mesoprost or anything. If I am using office hysteroscopy procedure, or even if I am doing under anesthesia, I always use a Bitoki, and I need not dilate it. Only if it is fibrous, then I need to cut the fibrosis to enter inside the cervical canal. So if we are not dilating, then there is no leak occurring from the cervix. So that spill you can avoid. We should limit the use of resectoscope which needs cervical dilatation. Small procedures like polyp and all, we can do with this Bitoki system only. For a bigger myoma or for a TCRE procedure, we need to use resectoscope, because for that we would need dilatation, and if the dilatation is a little more, then the spill will be too much, so that there will be difficult estimation. If we are using a resectoscope, we need not go in and come out very frequently. We should try and finish the whole procedure in just one going of the resectoscope. We should try to do that. Leak occurs only on change of instrument. If we are using the instrument channel for putting the instrument in, coming out, then again scissor in, then again, that through that instrument channel also some fluid will leak. So we should avoid using that. This comes only with as many cases as you do, you get more experienced in that. We can also use shaver or mechanical morcellator instead of resectoscope. This will be a boon in coming time once the prices of these things reduce. So small diameter hysteroscope, like conventionally the scope was 4 mm, but now the Bitoki, the upper one, telescope 2.9, diagnostic sheath is 4.3, the operative sheet becomes 5 mm, and in this we can use 5 French flexible instruments, our hand instruments, scissors, graspers and forceps. So this becomes a system which is very good for office hysteroscopy. Now when to stop? This should be a very important thing in our mind, that when should we stop the procedure. The fluid deficit, if it is more than 1000 ml, when we are using hypotonic solutions like glycine, if we are using monopolar, we have to use glycine. If we are using that system, then you have to stop in a normal patient if you are using at 1000 ml of fluid deficit. Inflow is going more, outflow is coming less, 1000 ml is the threshold, we have to abandon the procedure. But if we are using isotonic solutions like normal saline, we can go up to fluid deficit of 2500 ml in a healthy woman of reproductive age. But in an elderly patient or a patient who is suffering from some cardiovascular or some renal problem or some other comorbidities, then the fluid deficit is much lesser. It is lesser if we use a hypotonic solution 750, and if we use ringer lactate or normal saline, then it is 1500 ml. So we have to know this threshold, that at this threshold we are going to stop the procedure, come what may be. We will abandon and we will do it in the next setting, like myomectomy we can do. We should counsel the patient that for your welfare we might need a second sitting for the procedure. Now what preoperative measures can be taken for reducing the fluid absorption at the time of surgery? If we know that we are dealing with a big myoma, what we can do, we can give this, these are from the guidelines, we can give pre-op administration of GnRH agonist. It should be considered in premenopausal women before hysteroscopic resection of fibroids. And also intracervically at the time of procedure, if we give dilute vasopressin, it can be given for before dilatation of the cervix for reducing the fluid overload at the time of surgery, myomectomy or some advanced procedures. Now what are the steps to prevent air embolism? The hysteroscope and the inflow tubing should be primed with fluid. Once we put our assembly inside, our resectoscope inside or our hysteroscope inside with the inflow and outflow channel, we should see that there is no air inside even our scope, even in our operative sheath or even in our inflow channel, and there should be no fluid bubbles, gas bubbles in the tubing which is coming from the bottle hanging at the top. So if we are entering inside, we should see that there is, this is the video of retained products of conception. All the products are lying on the anterior wall of the uterus. So we should see that there is no air inside the tubing. We should remove the air and only then we should negotiate inside the intracervical canal. CO2 insufflation should be not used. We have already stopped using that for many years. Still some amount of gas may be produced by electrosurgery when we see bubbles inside while we are operating, but that cannot be prevented. We will have them. CO2 and carbon monoxide is produced, but the good thing is that they are easily soluble, so they will not cause any type of air embolism. So the complications will not be there with those things. But yes, it should be avoided. We should suspect air embolism. If there is sudden oxygen desaturation, the anesthetist should be having a close watch while we are doing hysteroscopy, because if the anesthetist is sitting in the side room or is having some talk on his phone, then the patient can be under trouble. So there can be sudden oxygen desaturation or cardiovascular collapse during the procedure, and that will be showing that the patient has had an air embolism. So this was my talk, and if you want to read more about this and you want to just start, this is a very good guidelines which will clear all concepts on this. This is 2016 paper, and you can have a read of this. Thank you so much. Last slide. Okay. Last slide लगा दो भाई. ये वाली लगा दो. फिर से.
Starting से.
नहीं नहीं ये वाली बस. हाँ इसके बाद.
हाँ बिल्कुल बोल
रुक जाओ. ये this.
आपके लिए पिक्चर आ गई. थैंक यू सो मच डॉक्टर सुमिता. आपने बहुत ही महत्वपूर्ण बातें बताई हैं बिगनर्स के लिए. मैं बताना चाहूँगी, मैं फ़र्स्ट टाइम कोई हिस्ट्रोस्कोपी की आपकी वर्कशॉप इस तरह की मैं अटेंड कर रही हूँ. और आपने जिस तरह से बताया, जो हादसा आपने बताया वो हादसा मुझे भी पता था, और उसके बाद से मैंने सोचा ही नहीं, मैंने देखने की नहीं सोची उसकी तरफ. मगर जिस तरह से आपने छोटी छोटी चीज़ों को बताया है, दो आस्पेक्ट्स विच यू हैव कवर्ड, you have done it very very nicely. You've done justice to your talk. We all are benefited by it, I think, and जो भी हमारे जैसे beginners हैं वो ज़रूर शुरू करेंगे. बहुत बहुत धन्यवाद. डॉक्टर सोनू सिंह का अगला टॉक है इनका.
कुछ नहीं.
ये मेरे को देंगे.
बोलिए ना फिर कमेंट से.
Our next talk is by Dr. Sonu Singh, consultant gynecologist, Vivekanand Hospital, and she is also the organizer of this workshop. She has done her fellowship in advanced gynae laparoscopy from Ahmedabad, advanced diploma in reproductive medicine from Kiel, Germany, and she is also trained in gynecological oncology from Tata Memorial Hospital, Mumbai.
A very good afternoon to all the senior dignitaries, and we are so glad that today we have got such good number of delegates. That shows that Lucknow and surrounding area, all the gynecologists are so keen to update themselves with the newer modalities. My topic is avoiding. Obviously everybody wants to see the positive aspects, the advantages, all these things, and nobody should or want to talk about the negative things, but this is important topic and lot of things has already been covered by Sumita ma'am. So I will be little faster because lot of cases are still pending and we are more interested in live surgeries. So hysteroscopic complications, if we talk about the incidence, the complication rate from the diagnostic hysteroscopy are not much, and they are more common in the operative procedures, and most of the complications are mainly related during the entry, or it is related to the surgeon's experience and the kind of procedure they are performing. So this classification you must have seen till now, which shows the different levels of surgeries which we perform, and as we go and do the higher end surgeries, the chances of complications are too high. Complications can be primary complications and secondary, and in all these complications we know very well that the consent and the counseling related to them is very important in the pre-operative phase. Patient position. This is very important after you have worked up your patient and you have done a proper pre-anesthesia checkup and pre-op investigations. The patient lands in OT, and goes on the table. So most important thing is the position. A lot of injuries may happen because you may think that it is just a 2-minute procedure, but sometimes it may even extend to half an hour. So that may lead to different kinds of injuries. Brachial plexus injury, then different pressure injuries on the peroneal nerve, then there may be overstretching of the sacroiliac joint. So the first picture is a no, because it is too uncomfortable position for the patient, and the patient should be like what is shown in the second picture, a comfortable position for the patient with semi-abducted and semi-flexed legs and properly covered patient. Now, okay. So most common complication, or you may say the thing which we all have faced, is the complication or the problem which we face when we enter the cervix. Most of the time, that's why we had this habit of putting misoprostol, because we thought that it may cause all these problems. But false passage is something which is so this thing, because once we have created a false passage, again and again we tend to go in that false passage only, and it becomes more difficult to find the right path of the cervical canal. So, and it occurs mainly because we have this practice of putting tenaculum or valsalum over the cervix, and we do forceful dilatation with our dilators. In one of the cases also, we have seen that today how differently this angulated the cervix was. So pre-medication not usually required, as Dr. Sumita also said, and but may be required in few cases where we have already examined the patient and we feel that it is tightly stenosed. Misoprostol 200 or 400, either 2 or 1 hour before procedure we put. And the latest thing is we do vaginoscopy. We have seen sir since morning he is doing only no touch technique, which is having less pain, more comfortable for the patient, no need of touching the even cervix, and it even doesn't hamper the cervical glandular morphology, which is also very important for infertility patients. So this thing you have seen a lot many times, and it all is possible because we are using now a lesser diameter of instruments. That is the key. Use lesser diameter, and then you will be able to do the same thing very easily in your OTs also. Then distension media, very nicely, very elaborately told by Sumita ma'am. So I will not go deep into that. Systemic fluid absorption, till now, very nicely explained by ma'am, what are the different ways, then how to monitor. Since morning, sir is also, and these guidelines are actually the take-home guidelines. Everybody should go, and in their leisure time, they should go through these guidelines. And the fluid deficit, we have monitored in the last case in the OT, the fluid deficit, because initially we took 2 bottles of normal saline. In the end, around 400 ml of fluid has gone in, and in the empty bucket we could see how much fluid has gone out, came out. So basically, this kind of monitoring is very important. So this slide is also about the same, and always we should think about prevention, because many complications are very difficult to be managed. So it is better to always think about how to prevent them. They are not many, but we can manage them. Like we can prevent them. This is not that difficult to be managed. We have to be more cautious only. Now the same thing was shown by ma'am. It is the ideal thing, the ideal way of monitoring the fluid deficit. But obviously all this machinery is costly, we know that. But in our OT we don't have this. We are able to monitor the input and the output the way we have done in the last case. Simply don't allow your fluid to just go on the ground, on the floor. In that way you will not be able to monitor the deficit. Now these are the signs, very important for us also, for the anesthesia people also, that the BP may go up, pulmonary pressure will be high. Then serum electrolytes is one of the very important aspect. There will be hyponatremia, the first thing. Parotid swelling, you can have subconjunctival edema if the patient will have fluid overload. Then coming to the perforation. Now this perforation can be by mechanical thing or it can be while using some electrocautery, and it may occur when you are inserting your hysteroscope. It has happened with me also. In one of the cases of postmenopausal uterus, it was so soft, the uterus was so soft and so small that I thought I have just gone above the internal os, but actually it was the fundus. So it is common, but then from that day I have always been very cautious with postmenopausal women. Now uterine perforation with all the complications, the most important aspect is we should be able to recognize that we have committed something wrong. There is something wrong on the table itself. So when we should suspect that the perforation has occurred, when your field becomes dirty with blood, that means there is excessive bleeding, or you are in a false passage which you are not able to identify as uterine cavity. There is sudden loss of distension and vision. There is rapid increase in the fluid deficit. You can visualize something yellowish, areolar tissue, and definitely you can confirm if you are totally confirmed when you see like intestines or bowel, something like that. So this video I just wanted to show, but it's not running. Okay. So this is the video of one of my patient of Asherman syndrome, in which I was going through scissors only. Is it running? Oh. Okay. And I was cutting very confidently, thinking that these are the adhesions. ये forward कैसे होगा? थोड़ा सा वीडियो फॉरवर्ड करना है, थोड़ा सा आगे करिए. आ नहीं रहा वो मार्क, नहीं आ रहा. So actually it was a, ठीक है, हो रहा है. So actually it was a fundal, okay, that's okay. It was a perforation in the end. I suddenly lost the vision and I put a scope immediately. I could see a, last थोड़ा end का दिखाओ, और आगे, yes. And on putting the scope, यही रही है. On putting the scope, I could find this fluid, which may be because of the hysteroscopy, and also रहने दो, कोई बात नहीं.
वो उधर इसलिए तो वही यहाँ से
and then because that perforation was bleeding, I just took a stitch. And the best thing is you should also examine the bowel, which on laparoscopy will be much easier definitely than just opening up and examining and taking out all the intestine. So it is the same thing that you have to abandon your procedure, put such patients on broad spectrum antibiotic, do a cautious discharge, just look for the symptoms post-operatively for 2 or 3 days, and rest of the things are the same as described in the video. Now if you have gone through electrocautery, you are suspecting electrocautery injury, then the most important thing are the precautions. Your foot switch should not be placed in a location which may result in accidental activation by somebody else around you. And of course bipolar resectoscope is the trend these days. We know the advantages very nicely, and the patient plate should be properly fixed when you are using monopolar resectoscope, because for bipolar we don't need this patient plate. And sir also told that start with the lowest possible volt. So he started with 50, and because it was not feasible, it was not cutting nicely, he raised it, and finally 80 he put it on 80. So that is the way. Start with the lowest current. Don't just ask the faculty, sir, what are your current settings? Because they have put on that level only after first testing. So this is a much better idea. And another thing is, don't apply current when you are at the fundus. Rather, when you have started your movement from above downwards, then only put your foot on the plate. So these are the post-operative adhesions. We all know that adhesions prevention is important, and it may occur after using electrocautery and doing myomectomies and septal resection and all that. And the different ways of adhesion prevention, we know that we can put IUCD, and we are putting and all these, but these are all not evidence based. These are our personal experiences. And second look hysteroscopy is the best option. It is actually the recommendation that after all septal resections, after all myoma resections, one should, and Asherman's, one should always do after 6 weeks a second look hysteroscopy. Then the latest thing is the hysteroscopic morcellation, and definitely it is the newest thing which will be there, and which will be taken up. If the rates or the cost come down, then all of us are ready to just buy it, because it has so many advantages. We know that it is causing least damage to the endometrium, the most important thing for the fertility. Then hemorrhage management. Hemorrhage means bleeding. So definitely pre-op preparation of the patient is very important. You can put GnRH analog and COC before you attempt any of the major procedures like myoma and multiple polyps and very thick endometrium. Then you can just pinpoint during the surgery, you can just pinpoint the site of bleeding, and you can coagulate it with a needle. Needle is there which is not being shown in any of the cases, but yes, it is available. And bimanual uterine compression we are doing in and out in our OTs. Tamponade with balloon, we have done in two cases today only. So if the bleeding continues, then we have to be more cautious and investigate more. Then air embolism, very nicely explained by Sumita ma'am, so I will not go in detail into that. Infection prevention, yes, we all are doing it very nicely. The incidence is just 0.01 to 1.42%, and the signs are pain, vaginal discharge, fever, tenderness. IV and oral both are the ways. If you are suspecting a moderate to severe infection, go for intravenous management, IV drugs. These are the combinations most of us are giving. Oral treatment for 14 days, doxy and metro a better option. Then hematometra. Why does hematometra occur? Because after the procedure, if the cervical stenosis occurs, then whatever bleeding is happening after the procedure, it will be there inside the uterine cavity, and your patient will land up into hematometra. So another important thing is ultrasound guided hysteroscopy. This is, I think, the next ideal thing before just putting your laparoscope, because many patients of infertility, and those patients who are going for IVF, they don't give consent for laparoscopy whatsoever may be the case. They say, नहीं बस आप हमारा जो uterus है उसे ठीक करिए, बच्चा दीजिए and जाना है. So in those cases, because we are very well versed with ultrasound, and how much to cut, how much deep we are going in the myometrium, we can judge with the ultrasound. So some other basic safety tips. I have explained appropriate pre-op preparation, then synchronous use of ultrasound, very important. Then your surgical team should be trained just like you. And so my take-home message for the budding gynecologist or the budding gynecologist who want to start and go into hysteroscopy and laparoscopy is, just train them properly. Because so many courses are available with us, we can go there and learn. Histro trainers are there, even we have arranged 2 histro trainers outside. So those who are interested, because histro trainers also gives you very good idea. Matlab they are not just waste of time. I think we also learned on histro trainers initially. So, and it is also important, always take help from someone whom you think is better to deal with those complications and those cases which you are not able to do. And hysteroscopic complication, hysteroscopy overall is a safe procedure and it has very low rate of complications if certain these small precautions are followed in the OT. Be vigilant in OT and just recognize your complications and manage them. Thank you.
इसमें वो चेंज हो जाएगा क्या? नहीं मैम, इसमें क्या है, सेक्शन तो यहीं से शुरू हो जाएगा.
डॉक्टर सोनू आपने जो भी कॉम्प्लिकेशंस के पूरा बताया, बहुत अच्छे से बताया. बिकॉज स्किल लर्निंग तो सीखना ही है, बट कॉम्प्लिकेशंस को भी मैनेज करना वो भी एक वर्क के साथ आपने बहुत अच्छे से बताया. और बडिंग नहीं है, जो हम लोग थोड़े से जो बूढ़े हो रहे हैं वो भी सीख रहे हैं. सो for me,
I think hysteroscopy is much easier to learn than laparoscopy, and it is very underutilized procedure because it may diagnose a lot of things which I perform myself ultrasound in 2 or 3 cases, and today in which I diagnosed only a fibroid, there was a polyp also. So there always don't rely on your just imaging. Sometimes we need all these procedures for diagnosis, and we may save lot of uterus actually from hysterectomies.
नहीं बहुत अच्छा. और दूसरा आपकी ये सरलता है और आपका साहस भी है अपने ही कॉम्प्लिकेशंस को दिखाना. अपने यूजुअली आप लोग एक आध मित्रों को बताते हैं, बट आपने पूरी टीम को बताया, इतने सारे लोगों को. ये बहुत अच्छी बात है, ये सीखने को मिलता है इससे. बहुत अच्छा है. नहीं इट इज सो गुड टू शो दैट वीडियो. नो दैट्स आई रियली अप्रिशिएट इट. यू हैव शोन दैट वीडियो. सो ये से हिम्मत खुलती है सबकी. Yes, we can also do. होगा तो manage करेंगे.
And one more message I want to give, that I have this habit of recording all my cases. Literally, very rarely it may have happened कि suddenly वो wire हट गया वहाँ से, plug से निकल गया. I have recorded, I have many hard disks. I have recorded all my cases. It really helps me. Really helps me, and also you are able to, like ma'am said, present your cases.
Very well आपने presentation किया. Thank you so much. Very well.
Thank you ma'am for this wonderful talk. Now I request our chairpersons to kindly felicitate our speakers. Ma'am please.
ये है ना, ये पीछे पकड़ना है ऐसे. फिर ये जाएगा नहीं. हो गया फिक्स. इसको ऐसे क्योंकि इसको अगर
Sumita ma'am, please come.
क्या हुआ? Don't worry at all. पेडल देना है नीचे, ये पेडल दे. भैया ये हटा लो, साइड से हटा लो. अभी वो टीम रख दो, उधर रख दो. यस. इसको शुरू करो ना, ये शुरू करो, ये शुरू करो. और उसका केबल लगाया पीछे, ये कनेक्ट किया IBS. ये नहीं ये करो. और पीछे कनेक्ट किया केबल, सक्शन IBS. हाँ पीछे लगाना पड़ेगा वापस. हाँ 1 मिनट, नहीं हो रहा है. सक्शन ऑन होना चाहिए. पीछे केबल लगाएंगे तो ही होगा. इसको जो केबल इसमें लगी है वो इससे सक्शन में लगाओ. यहाँ पे पीछे पेडल का साइन है वहाँ पे. हाँ पेडल के साइन पे, पेडल के साइन पे. मतलब समझा ना? नहीं तो होगा नहीं वो. क्या नहीं हो रहा है? दिखाता हूँ, एक मिनट देखता हूँ। ये पकड़ ले। एक मिनट मैं बताता हूँ मैम, एक मिनट। नहीं वो नीचे है, ऊपर वाले में। हाँ वही गड़बड़ ऊपर। यस, थैंक यू वेरी मच। एक मिनट। यस, ये हुई ना बात, समझा अभी? तो ये क्या होता है, देख आधे पेडल में ना
Thank you,
suction
ma'am.
शुरू होगा, तो
Now I
पॉलिप जो है वो चिपक
request
जाएगी।
Dr. Renu Makkar ma'am to kindly
Oscillator देखा
felicitate
तुमने?
our
Laparoscopy
chairpersons.
में?
Ma'am, please come.
टिनाकिलम
Renu
है ना?
ma'am.
ये टिनाकिलम का काम कर रहे हैं। अभी इसमें टिनाकिलम नहीं है, टिनाकिलम फाइब्रोइड को मॉर्सोलेटर पे पकड़ेगा, ठीक है, या क्लॉग्रास पर। अगर वो पकड़ेगा नहीं तो मॉर्सोलेटर उसके चलेगा नहीं, ठीक है। तो ये मॉर्सोलेटर का काम हो रहा है। उसके बाद अभी देखा, पूरा दबाऊंगा, ये हाफ पेडल ये शुरू हो गया, ये टिनाकिलम इधर लेके आया है इसको, सक्शन से पॉलिप यहाँ आ गया इसके अंदर। अभी ये आ गया तो ये उसको, तो चिप्स यहाँ से आएंगी, वो बकेट में जाएगी। ये हो गया। इरिगेशन तो ऑन है, इरिगेशन ऑन करिए, करे शुरू। दिख रहा है क्या वहाँ पे? कैन वी स्टार्ट मैम? ओ माइक तो ऑन है यहाँ पे। कैन आई just announce them, no, that we are starting something very interesting. If everybody can assemble, it's very good. हाँ आप चलिए, आप शुरू कीजिए। Don't worry.
Hello. On. Hello. On.
Yes.
Hello.
Hello.
As we are already
Yes, we can
running
hear
late,
you.
so I'll not take
Okay,
much
okay.
time.
Hello.
Yes.
Hello.
Now I will
Can you hear?
take directly to the live
Isha
relay
Bhaiya?
of the surgeries from the OT. For this session, I
Hello, Isha
request
Bhaiya?
our chairpersons,
Yes.
Dr. Smriti Agrawal ma'am,
नीचे Wi-Fi आ रही
HOD
है?
Department of Obstetrics and Gynecology, RML Hospital, Lucknow. I also request Dr. Radhika, Fertility Specialist, Birla IVF Center, Lucknow.
Check.
इसका फायदा क्या पता है?
Dr. Pushpa Jaiswal ma'am, Director Ajanta
बंद करना,
Hospital and
हाँ।
IVF Center, Lucknow.
ये बंद करना है। ओके, अभी देखो इसका फायदा क्या पता है आपको? बोलिए इसको।
And at last, I request Dr. Sarika Purwar ma'am,
आप
Consultant,
अगर समझो-
Department of Obstetrics and Gynecology, OP Chaudhary Hospital and Research Center, Lucknow.
मान लीजिए पॉली को,
Director Sri Ram Hospital, not Ajanta. Some not made the corrections.
इसको
I'm
खींच के
sorry,
लेके आ
Dr. Pushpa Jaiswal ma'am,
समझे आप?
Director Sri Ram Hospital, Lucknow.
इसको डायलेट करना है तो भी अच्छा है। 3 mm इंस्ट्रूमेंट जा सकते हैं।
Hello.
Check.
Hello. Hello, we are audible?
Yes. Audible.
Okay.
Yeah, can you see the video?
So we
Yes.
are starting with a new case, which is an interesting case. She is a patient, 46-year patient of primary infertility, and her ultrasound shows a fibroid of 20 into 17 millimeter in anterior wall of uterus, and we'll be showing IBS procedure in this. We'll be using IBS basically to remove this fibroid. Over to sir.
Hello. Okay, so everybody who is very young and enthusiastic, this is your technology for future. The future of hysteroscopy is going to change by this particular technology. If you see what I'm using right now, यहाँ दिखा ना यहाँ पे. Do you have the picture
Everybody
there?
please focus here. This is a very important upcoming
Over here.
thing,
Okay.
and most of us may be using it in future.
Yes, 100%. I'm telling you, this is going to change because this does not require the amount of skill requirement is very, very minuscule. The technology will take away the skill of the hysteroscopic surgeon, and everybody will be able to do. Now you see, this is the camera, that's the light, and this is a laprocator type of scope. Okay, like those who are the senior people who would be doing TL, they would realize that this is quite similar to that. Okay, so the cable is at 6 o'clock and I started fluid. See, right now I am not showing the motor is here and the shaver is in this, the blade. But here what I am using is a Maryland 3 millimeter, and that is the biggest advantage of it. The hysteroscopy, now वहाँ पे ले लो अभी. Now what I am showing you is 3 millimeter instrument. You see how beautifully there is a cryptal polyp here. Generally you have 5 French instrument which is just 1 millimeter. Okay, this is 3 millimeter. You can see how big is the instrument, how sturdy instrument it is. Suppose there is stenosis, I can do the dilatation with Maryland only. Okay, so I will first show you the polyp here. The polyp is here and I am just grabbing it. Can you see? Are you able to see properly?
Yes, yes.
Yes. Thank you very much. So this is the polyp. I am just showing. Okay, this actually does not require anything, but I can show you that how beautifully you see that. So the polyp can be removed. Likewise, you can get 3 millimeter if you are doing tuboplasty or some microsurgery. If your hospital also has a pediatric surgery, then you have 3 millimeter, lots of instrument, tinaculum, lot many 3 millimeter instrument. You can see now how beautifully. I will now do the dissection of the cryptal fibrosis. Can you see?
Yes.
See that? The cryptal fibrosis is being done. Now I will show you how I do the dilatation of the os with Maryland. You can see that. Now I'll just go and open the grasper inside like we always do for all the cases. The dissection we do by opening the instrument. Okay. So this is the os. And that's the negotiation. Okay, and you can see beautiful multiple polyps there. Can you all see that?
Yes.
Now let me tell you this, what this endometrium is disordered endometrium again. You can see micropolyps so beautifully. The sign of inflammatory is micropolyps. But when you have polyp on a polyp, it is a sign that you have infection. Now come here, okay, I will show you. Can you see a small polyp on the lateral wall which has a micropolyp on the top of it?
Yes, yes.
Are you really seeing it? See, I'm pointing it. Wait, I'll point. Not that, not that. Not that, ma'am. I'll show you. 1 minute. My instrument, let it come. Let my instrument come in. I will show you. Exactly see here my point. What I'm pointing is this polyp. This here. 1 minute. This polyp here. This polyp. Okay, what I'm touching right now. You see that? Can you see? A micropolyp and a small polyp on top. Again on top also is like that. See? A micropolyp and there is a small polyp on top. I'll come close to it. Can you see now?
Yes.
These polyps also have micropolyps on top of it. All of them. Can you see? They are wearing caps. See that? See this one. I have focused now. This polyp here. Okay. So this is definitely infection. Okay. So what you can do, advantage of shaver is, ma'am, see this. Huh? So you can hold the polyp with a grasper, avulse it. You see how beautifully it has come out. Did you see that? So this is one advantage of this. एक मिनट पानी बंद करना है. हाँ, अभी पानी शुरू करना है. आ गया? Now I'll show you the shaver. So now 3 mm instrument comes out, and the part which the shaver, which is having a blade, goes in. The benefit, those of you who have morcellator are soon going to have no blades, no accessories for the morcellator coming from stores, because stores has discontinued laparoscopic morcellator. But the same unidrive machine here is being used for the shaver. Okay, so now I'm going to use the shaver. Okay, so same way I go inside the cavity, and then I will just, can you increase 80 to 100 please? This one 100 plus. Oh, your spectacles, ma'am, be careful. Huh? Yeah, thank you so much. And can we open one of the, it's open, the fluid is not punctured. Ma'am, close this, no? Close this one. Close it and start that one. Please. Yeah, that's enough. And give pressure in that. Little, not much. Ah, enough, enough. Thank you so much. Now see what have you, all of you who have done, bus, enough, enough, enough. All of you who have done the, hello? Am I audible?
Yes, go ahead, ma'am.
Those who have done laparoscopic morcellator, this is the blade which works. You see, can you see the blade here? Okay.
Yes, yes.
अरे ये ठीक से घूम नहीं रहा है वो. No, it's not. Wait a minute. ये पकड़ना कैमरा. Yeah. Okay. Okay. Fine. Fine. No problem, ma'am. Nothing. Nothing. See. Now, can you see that? Can you see the movement?
Yes.
Yeah. So basically, what this will do is this will hold the polyp with the suction first and then eat it up. Okay. So you see that it's gone. Can you see?
Yes.
Now see that?
Yes.
Now see all these micropolyps, this particular instrument is going to eat it up. Okay, just see these micropolyps. You go there, just press it, it goes, eat it up. It will eat it up. You see, huh? See that? It's gone. See that? It's gone. So basically you can do DNC, without doing curettage. It just takes it up only the superficial layer without damaging the basal layer at all, completely. So see this, okay? So this is one of the most breakthrough thing that you've seen. Anyways, this is being done in ortho, being used in ortho a lot. It's not that it is a new technology, but in gynecology it is being used for this is the first decade. And this is the future technology, believe me. See, now in resectoscopy, you have to think about current, you have to think about fluid. Here there is no problem at all because the pressure is same. You can actually reduce the pressure. Ma'am, reduce the pressure to 80 again. Now look at this cavity, okay? You see the bump here. Can you see the micropolyps here? Just go close and just do this. It will all come up, you see? And you are not losing the histopathology specimen, okay? You don't have to use grasper, nothing at all. This all specimen comes in the bucket or a glass jar where there is a small filter like a small mesh which has in this there is no mesh, ma'am. Right now I have not put it. But it comes when you buy a new set, no, it comes. Because these people keep on going here and there, ma'am. The company doesn't give them. So now you can see here, you see the cavity, huh? You see the cavity, how beautifully it is gone. Everything is clear. Can you see the cavity now? So this
Hello,
is the technology. Sir? Yes, ma'am.
Harish, sir.
Yes, ma'am.
And I think the best part about this is very least amount of hand maneuvers are required.
Yeah, that is what I'm saying, ma'am. Basically, no, that's what the first thing I said.
Both the hands.
No, first thing I said is that there is no skill required in this. Okay, so basically what you're saying is right. Same thing, what I said. There is no skill requirement. You just go close to the pathology and press it. That's it. That is what skill is required here. So practically speaking, this is a very lame procedure. Okay, if you give it to a smart and hysteroscopic surgeon, they don't like it because there is nothing to be done. It's like automatic car.
Hello,
Yes,
Dr.
ma'am.
Harish.
Yes.
A small question from me, sir. Sir, I have used this Smith and Nephew, but the problem which I faced was that if we are opening our suction, because we have to suck the micropolyps, lot of fluid also comes with that, so the vision becomes poor for that time. So, how are you managing that outflow suction channel?
Ma'am, this one, no, basically the program is in the machine. Can you focus on the machine, Bau? Brother.
We are not seeing the outside picture.
1 minute, ma'am, 1 minute. No, there is only one picture outside.
And Dr. Harish, we also want to know how you're retrieving the specimen
Yeah,
and
I will
how
show
you're
you.
manipulating this
Yeah, I will show you, ma'am.
instrument.
So, yeah, you can show here. यहाँ पे दिखाइए. Ma'am, you can see this pressure inside here. Can you see my hand?
Yes.
Okay, now this is the inflow.
That leg of the patient is coming.
Okay, 1 minute, ma'am. Just hold on. I will show you now. Okay. थोड़ा ट्रॉली पीछे ले लो. Anyways, the procedure is over, ma'am. I have come out of the patient's this thing. Ma'am, the advantage of this IBS is much higher than Smith and Nephew. Because you know what, ma'am, see, you remove this. Can you see the system here?
Yes.
So you remove the motor.
So the camera can be a little away. Zoom.
थोड़ा
out.
सा पीछे
Yeah,
ले लो.
थोड़ा.
हाँ. You can remove the shaver and can put in a Maryland or a bowel grasper 3 mm. Can you see?
Yeah.
So this one will allow you to operate very easily and take a biopsy, polyp out easily. Okay. Suppose there is there are band of adhesions which is there, or if you want to enucleate myoma. So this one, ये screen दिखाना screen. दिख रहा है? Can you see, ma'am, Maryland here?
Yes.
Suppose there is a deep myoma, slightly deep. Now the shaving will not happen, right? So you go on the side, you dissect the fibroid will pop in the cavity, then rest of the myoma can be removed easily. While in Smith and Nephew, I don't know whether it is possible to do this way. Another point here is, ma'am, this particular system works integrated. That's why it is called IBS. It is integrated Bugatti shaver. So this one here is a flow suction. So when I press the pedal half, you see the suction has started?
Yeah.
Okay.
Okay.
After that, when I press it full, then the motor starts.
Okay.
So it is in combination with, so both of them work by talking to each other. This machine is actually not two, they are one, talking to each other. That now the full pedal is on, so both of them are on. So the fluid, the tissue that you get is in this bucket. Okay, and I will show you the tissue. Huh? I will show you the tissue. ये ले लो. हाँ नहीं है अपने है क्या इनके पास छलनी? नहीं तो I can show you the very nice easy way, ma'am. There is no problem. हाँ हो गया. The case is over. I'll just show you the tissue. How much tissue we get. Ideally, ma'am, generally the new machine system that they buy, no, they get a glass jar with a mesh inside. So all the tissue comes into that. Yeah, perfect. Perfect, perfect. So ma'am, if you see, no, I wanted to show them the amount of water also. नहीं एक खाली कोई beaker या कुछ है. So they will know how much fluid is used. यहाँ पे दिखाओ.
Some चाय की छन्नी can be used.
Yeah, ma'am. See, yes, true, ma'am, true. अभी चाय याद आ रही है सबको. Can you see how much fluid is used here? It's only 1 liter of the saline that is used. Okay, for this procedure. Of course, this procedure was small, but only 1 liter is used, and all the 1 liter is here. It's outside here. I will just measure it. So there is no need of any special instrument, okay, or this thing. Just hold it. नहीं ये पकड़ेंगे ना, ये पकड़िए. यहाँ पे focus करिए आप, so that they know how much water is there and how much fluid is there, and all the tissue. You can see here the tissue in this. I don't know whether you can see.
Yes, it is visible. It is visible to some extent. Yeah, yeah.
So there is lot of tissue there, and a whole 1 liter of fluid has come out here. So it's not too much of the tissue, too much of waste of water or saline, and all the tissue is here. Okay. इसमें से लेना पड़ेगा. Okay. Thank you so much. Thank you very much. We have the next case, which is either type 3 or type 2 fibroid.
Dr. Harish, can you show us the IBS?
Yes.
And how you were moving it with your hand?
Yes, I can show you. Sorry. यहाँ पे स्क्रू यहाँ पे दिखाई ट्रॉली पे. We can start taking out patient. ये सिस्टम भी वहाँ शिफ्ट कर दीजिए अभी. So basically you see this is the scope. इसके ऊपर लाइए आप. आ गया? Can you see, ma'am?
Yes, yes.
Yeah. So basically I wanted to show you two things. Okay, I will show you assembly and disassembling of both of them. Now see, this is the 3 mm, 3 mm instrument channel. Okay, so here the instrument goes in.
Yes.
Okay, so there is a washer for 3 mm instrument, just like how you have 3 millimeter trocar. Same washer. Okay, now this is the scope. Here the camera comes. Here there is a light cable, and this is inlet. Okay, so this is basically becomes a diagnostic sheath. Now when you attach, this blade goes inside, and there is a motor which attaches here. So you have to just hold the camera in one hand, the other hand is, and both of them are quite at a distance, you see.
So the hands don't hit each other.
So hands are working like this. There is no problem at all. And in this way, entire uterus is actually covered. And the motor is such that you can also rotate the motor in 360 degrees. So all the pathologies can be easy this way. It can be rotated this way also and this way also. So everything gets covered. There is nothing that is left. In addition, suppose you need to do dilatation, dissection, then you have multiple grasper. There are 3 graspers which comes, one bowel type grasper fenestrated, one Maryland and one Caesar. And this is quite sturdier than your 5 millimeter, that 5 French Caesar. This will probably last for 15 years. So this is the system. Okay. Now let's understand disassembling and assembling of this one. This video is there on my channel on YouTube also. If you see, this Batocchi sheath is designed in such a way that you have 2 sheaths and a scope. So if you see, in and out are opposite words, right? So this is the inlet and outlet. You don't have to see anywhere anything like 0 or this thing. Just place it like this. Opposite, in and out are opposite to each other. So don't see for line 0. That is what you generally do, right? So keep it opposite each other and just slide in. And then righty-tighty. Remember this, righty-tighty, lefty-loosey. Left loose, right tight. So this you have to just rotate on the right side. So this becomes tight. Okay. Now again same thing. Now you see, this sheath is not balanced. If I keep it, there are 2 on one side, my left side, only 1 on the right side. So this is not balanced. I will have to balance it. So I keep a scope to the left and see it is fixed. Again righty-tighty. So this is how you just assemble. You don't have to see anything. You just keep everything here on table and assemble. There is no harm, nothing will happen to the scope. But if you try to see where the 0 mark, then the scope will touch something. Don't do like that. So just place it here and balance the, okay, that becomes, and disassembling also very easy. Lefty-loosey, take it out. Lefty-loosey, take it out. That's it.
Right, great. And can you also show us the motor which you said it has to be attached onto the IBS?
The motor?
Yeah.
Yeah, okay, 1 minute. Can they get the handpiece? Karl Strauss. Handpiece, motor. IBS motor. दूसरे केस के साथ रेडी है हाँ सॉरी बेटा आई एम सो सॉरी So generally when you have instruments like this from Karl Strauss or any other company, what happens is most people don't know. Meanwhile they bring the motor I am talking to you so that we utilize time. Generally if you have Karl Strauss instrument like this, then what you should do is remove these caps, take a syringe, okay, at the end of the day, take spirit and take it in this and then just pass me lana, zoom in. You see what happens here, huh? Just see what happens to the, okay, now you see here, did you see how much fluid came out? This is saline, and saline causes something called as corrosive damage to the metal. So that's why when you go inside you will see that rust. It's not rust basically. So after you've done with the spirit, now there is spirit inside. Saline is replaced by spirit. Then you remove extra spirit also by just putting air. Do it 2-3 times and then just hang it on the IV stand like this. Okay, when you hang it on the IV stand, what happens is, whatever remaining spirit is there, no, it will come out. And the spirit is, it is self-evaporating, so everything will go out. So this is how you will take care of your instruments. Okay? And whenever you are immersing or autoclaving or doing whatever, like suppose you have a case today and you want to sterilize it, before sterilizing, just open the instrument, take a toothbrush, soap and hydrogen peroxide and just rub it here. Wash it before putting inside X. So whatever saline is there which is crystallized comes out, does not go in the patient. Okay, most of the time we go there and then, oh, now it has come out. So that should not happen. Okay?
So,
yeah. This is the motor. Can you see, ma'am?
Yes, yes, sir.
So how do you assemble is, you retract this part. Okay, you retract this down, put the motor inside and then leave it.
Okay.
So this is how it just assembles. And this is nothing but a same rotocut motor is there inside this, but in a small size. What morcellator motor is there, same motor. But it is not circulating, it is just oscillating.
Sir, the blade on top of this also comes in sizes, like the channel for a bigger myoma is broader.
Yes, ma'am, I can show you.
How many
There
sizes?
are 3 sizes, ma'am. 3 sizes and 1 and 2 different configuration, corrugated and plain. So you can see here, there are 2 different sizes. Can you see?
Yeah.
You can't appreciate very well there because the size difference is only in millimeter. This one is 3 millimeter, this one is 6 millimeter.
Okay. So for a larger myoma, if you
This
want
one
to
you
take
have to
deeper
use.
cuts, we have to use the 6 mm.
Yes, ma'am. Yes, ma'am. Yeah? Done. We are taking the other case now.
So now moving to the next case, the patient is 40-year female. She is para 2 and with previous 2 LACS. Her
Ready?
ultrasound showed an enlarged heterogeneous submucous fibroid. It can be a type 2 or type 3, which we will be confirming by doing the office hysteroscopy, and further treatment will be decided upon this. Usually when we have such kind of findings, we either do a MRI or we do 3D ultrasound to confirm our findings. But in this case, we'll be doing the office hysteroscopy and then we'll be confirming the finding and then we'll be doing the see and treat condition.
Thank you. So you got the history of this case now?
We are audible? Hello? Hello?
Yes.
Okay.
Yeah,
The
yeah.
camera is just actually there.
How is the crowd? Is it lost or it is there?
It is very much there.
Oh, perfect. Very good. Are they enjoying?
Perfectly, yes.
Actually, the thing is,
So the lectures of today are shifted tomorrow morning. How many of will you come?
Sir is asking who is willing to come tomorrow morning for his lecture on tips and tricks of resectoscopy.
What time, ma'am?
Wow, that's nice. That itself is enough to say. So time will be told at 5 o'clock in the evening.
Okay.
Actually, there is some technical glitch. We have this camera thing is lost, and now we have only one camera which will be showing the outside and the inside, both of the things. Sorry for
But
this
the vision is all right. It is very good.
Okay. So the any question for sir? Sir, do you do routinely the MRI or 3D USG to confirm whether it is a type?
This mic is not working properly, Dr. Vaishali.
My mic?
Yes, the volume is, sometimes it becomes too low.
आवाज नहीं आ रही. Hello. Hello.
Now it is okay.
Okay. Sir, what you usually do?
Yeah, so I generally do 3D ultrasound to know anything about Mullerian duct anomalies. Most of the time I will show you one of the reports that we get. He's an amazing guy, and if you go on my channel, Dr. Harish Vagasya YouTube channel, you have entire collection of Mullerian duct anomalies, and there is one Dr. Anirudh Badade who has taken a lecture on how to diagnose them on sonography. Okay, MRI generally is not required except if the patient has vaginal agenesis where TVS cannot be done. शुरू कीजिए इसको. So basically we do only 3D. We do not do MRI for all the cases. I think it is too much of a waste of money for the patient. By the time you send that all, in that much money we do hysteroscopy. So our hysteroscopy charges are quite economical, and we do huge number of hysteroscopy because of that. And that's why we have come to a conclusion. You can see now. Focus there. Can you see? Lights कम कर दो.
Yes,
तो
yes.
और भी अच्छा दिखेगा उनको. थोड़ा ऐसा करेंगे. नहीं, it's okay. So this is the external os. You can see the cervix very well. Okay, you can see entire cervix. I am not holding the lips of the vulva. Now people worry that you can see that. You can see entire cervix. You can study the fornices for any fungal infection, any lesion, anything, and you can go inside the cervix now, and that's inside the cervix. Okay, and you can see, wow, this is a wonderful thing. Can you see that? Ma'am, any procedure history? Now see this is because of that missed abortion. Okay, she has cervical adhesions. Can you see? So typically if you go close, it will be like a, okay, this is a fibrotic band adhesion, Caesar. Don't worry, sister, just give it like this. Yes, good girl. No worries, no worries. वापस वहाँ जाना पड़ेगा इसको. हाँ, leave it. So Caesar is coming in now, and you can see the band of adhesion there. Now generally what most of the people do is just divide it, okay, and that's not a good idea. Okay, ideally what you should be doing is just okay, go and cut there, not in the center. When you cut in the center, it will get divided, and you can see that on the Caesar there are black dots. That's what happens with the saline remaining inside. You will never see my Caesar having that one. Okay, so that is where you cut. You cut. ये बंद नहीं हो रहा सीजर, क्या हुआ इसको? हाँ, हो गया. It's broken. इसको दूसरा लेना पड़ेगा, ये बंद नहीं हो रहा है, टूट गया सीजर. Now see, this scissor is broken. Okay, it's gone. So I will show them. I will go inside and I will do it with the grasper also. It's okay. So what is general good idea to do if the patient is having a fibroid? SGA classification is now out. Okay. So generally we do something called as Lasmar scoring. Okay. And next webinar of mine will be on that, how to do Lasmar scoring and hysteroscopic resection of fibroid. And I will send you guys the link. You can share it with all the delegates who have come today. And so this is how you remove with the grasper. Suppose you don't have scissor. So, okay, so good. Sometimes something doesn't work, you come to know next thing what is to be done. Now scissor was not there, so we removed with the grasper. But what we are doing, you see, these fibrotic strings, can you see the threads? You remove them by holding with the grasper. But if you don't have this grasper, then you will not work very well. Believe me, there is only one thing I would recommend to buy from Karl stores, and that is this grasper. Crocodile grasper, they are very sturdy, long lasting. And believe me, you will. So now I'm dilating. Can you see? I've dilated. So those of you who said that under vision or under laparoscopy, there is no need. You go inside and you dilate, automatically it fills up with the saline, and then what you need is negotiation, what we generally do in market. Okay, and there you go to see.
Sir, this negotiation thing happens at the level of internal os by rotating
Yes,
the,
yes, right,
so
perfect.
that the oblique diameter of the telescope comes in the transverse diameter of the
Yes,
internal os.
true, right. Can you just give pressure in this? In this, yeah. So now can you see now this is what happens if your endometrium is not very nicely prepared as we want. That's the debris, okay, which I have removed, and now can you see the fibroid? This is the नहीं क्या हुआ रहने दो. That's the micropolyp. That's the ostium on the right side, okay, and that's the ostium on the left side, this one, okay, not the upper one. This one is not the ostium, okay. The ostium is here. Can you see the polyp there? This one is the ostium, okay, and this is whole myoma. It's the fundal myoma.
Sir, it is not appearing like myoma from what we
Yeah,
can see
right.
here.
Right, you are absolutely right. Why it is not appearing like fibroid? Can you tell me why it is not appearing? Can you see the blood vessel here on the top? Did you see?
Yes,
Yeah,
yes.
so this is fibroid, okay? Now I will show you that where is the fibroid, okay, alright? All of you are not convinced that this is fibroid. Let me see whether it is fibroid or not, okay? Bas enough. Can we have the AC on?
Dr. Harish, you just said that the endometrium is not prepared. What did you mean by that? Do we need to prepare the endometrium before we do
Yes,
it?
before any fibroid, you must prepare the endometrium, and that's what I've been talking from morning.
Okay.
Any operative hysteroscopy, you need to prepare endometrium like how you prepare patient for anesthesia, for any other surgery, like that, okay? So
for
I'm
the-
removing this endometrium which is not well prepared. At least thank God that she is in the post-menstrual phase. That's why the endometrium is thin. नहीं चाहिए sister.
Sir, what
ये खोल दो ना.
preparation they
और
want to
उसमें
know,
pressure
sir?
दे दो. नहीं आपने उल्टा कर दिया भाई. एक मिनट ना, जस्ट होल्ड, बस ओपन ही रखो उसको, पूरा ओपन. भाई सुनो ना, ये उसमें लगाया और वो बंद है. नहीं आप लगाओ मत, हाँ लगाओ मत. वो वाला खोलो, हाँ उसमें प्रेशर दो. सेक्शन ऑन है, सेक्शन ऑन करेंगे. नहीं सेक्शन आपको लगाना पड़ेगा. ये नहीं उसमें नहीं लगेगा, उसमें नहीं होगा बेटा, वो IBS ये कनेक्टेड नहीं है. राजा ओ भाई यहाँ डोंट वरी आएगा, लेके आएगा. So endometrium preparation is with the use of OC pills, okay? Somebody was talking about OC pills. Sorry for the
Yes.
interruption in between.
And sir, what about GnRH for fibroids?
So yeah, if you have a fibroid which is quite large, then you have to use, then you have to give GnRH. If you give GnRH, both the things happen simultaneously, but how will you give is the question, right? So you give GnRH, this is, so I would generally say there are 4 tips in doing myomas, okay? This looks like adhesion band. This is not fibroid. What you are saying was right, okay? It is not fibroid, it is a adhesion band. It's not type 2 or type 3 fibroid, it's a adhesion band. But let's discuss the adhesion first. I will come to the fibroid as soon as I finish this. Is that alright?
Yes, sir, yes.
Okay. So I am removing this endometrium manually. See, this is surgical preparation of endometrium to see what exactly lies there. Now you can see, this is the band of adhesion. Can you see now?
Yes, sir, yes.
It looks like arcuate uterus, okay?
Yes.
But now you see one very nice important thing, okay? As soon as I reduce the pressure, you see it is started popping in. Just keep your eyes there, huh? Just see it's popping in. You see it is popping in. And now when I push it, see it's going in, out.
Yeah.
Okay? So I really don't know if there is, but whenever you see yellow tissue like this in the cavity, means patient has RPOC. Okay? There is no other tissue which appears like this. If you see dirty, sloughed out tissue like this is mostly RPOC. Okay? But I would not still conclude. I will just go on doing the work first, then only I will come to the conclusion. So this is the band of adhesion, you can see very well, which is epithelialized by endometrium. So I was talking in the morning that very rarely, sometime you will see adhesion band completely surrounded by endometrium. Okay. So this is the nice endometrium on the adhesion, which is very thick. So basically there is a caving. Can you see caving? Okay, whenever there is a caving, no, this is the sign of adhesion. See this caving here?
Yes, yes.
So wherever you go, you see caving here. You see?
Yes, sir, yes. Sir.
Do you see multiple caving in here? Here it was appearing like two ostia.
Yeah.
Okay, sometimes you are doing hysterolab, and if you do like this, no, this endometrium goes and sticks in the ostium there, okay? So that also you have to take care about. Then you will not get the patency test. So now I am going to take Caesar. Caesar aa gaya, sister? Very good. Chalo. Nice. I was waiting for the Caesar and doing little time pass. Yeah, give me Caesar, sister. Give. Give. So this exchange of instrument, stopping the fluid, starting the stop purpose, bas, enough. Okay, now how will you do the adhesiolysis? Anyone? Can anyone suggest? Generally what people do, or what will you do is, you go in the center and cut the adhesion, right?
Yes, sir. So,
So
we look for the most
so
fibrous
what you
part
do is,
and the white
so
area, and then
now see, the adhesion is from here
yes.
to here. Okay?
Okay.
So what you do is go make the cable at 12 o'clock or 1 o'clock. Can you see now?
Okay.
So my scissor has come down. So I can cut like this. Okay, and can you see the hemosiderin again? You will see some hemosiderin, some yellow tissue, some slough. Can you see that? 1 minute, huh? I will show you. See this. Can you see? No, you're not appreciating.
Yes, sir. Yes, sir. We are seeing, sir.
This one. Can you see this? This.
So first you are separating it from the posterior wall.
Yes. Why? Because posterior wall is difficult.
Yes, sir.
So I'm just doing it. Anterior wall is very easy to operate in hysteroscopy. Okay.
Okay, sir.
So I'm just doing this, and this patient has RPOC for sure.
Okay, sir.
Okay, I don't need histopath. And I have done RPOCs almost 8 months after the first previous history of abortion. Okay, so RPOCs can remain there, calcify slowly over a period of time. So then the patient comes with osseous metaplasia or something like that. You can see the orange color tissue there. Can you see?
Yes, sir. Yes, sir.
So this is nothing but RPOC. Plus here, if you see here, this area. Okay, this is RPOC here. So most of the time what happens is, we are too much in a hurry to finish the case off, and we miss all microscopic findings which is there. Okay, now see the adhesion. Can you see adhesion is going up? I don't know whether you appreciate it. 1 minute, ma'am. I'll show you again. So ostia should always be kept in the vision, in between also, like not always but in between, so that you can have orientation. That is your landmark. See this? The adhesion band has gone up. And now I'm going to go and take the cable at 6 o'clock. So this has become fundus part, and you can see that. So this was a good case actually for adhesion demonstration. Okay. Now this is done from the posterior wall. Now I will go and do it from the anterior wall.
Okay, sir.
So, sir, you are planning to excise these
Yes,
eggs,
you are
not
absolutely
only
right.
just incising,
Just
but you
incision
want.
is of no use, okay? Another advantage is I will have entire tissue sent for pathology, they will do grossing, they will do microscopic finding on it and tell me whether is there any chorionic villi. Not live, dead also is fine, okay? But then the diagnosis of retained product is confirmed. And once you have that diagnosis, what is your take on the further patient management is, if patient conceives again, look for a adherent placenta, okay?
Yeah, yes.
So that's the take. What I'm saying is applied gynecology. Think of future, and that's the fibroid. Okay, 1 in 2 cases, you see now. This is adhesion band. I will show it differently. And that's the fibroid. You see, can you see the fibroid now? 1 minute, I will show you. Pressure come, pressure badana.
So, we are not able to visualize.
You will. 1 second. You will be able to visualize. बस, वहीं पे रहना प्लीज, वहीं पे रहना 2 मिनट, 2 मिनट, 2 मिनट, बस 1 मिनट, अभी नहीं, अभी कुछ नहीं देना. आपको भी देखना है. देखिए, ये फाइब्रॉइड है.
So, sir, do you suggest that we should look for, like if we are suspecting fibroid or something, we should reduce the pressure and then...
Yes, of course. See, when you reduce the pressure, it pops in. Can you see fibroid? Here we can appreciate very well. I don't know the vision there maybe.
Yes, sir, it looks like a fibroid, but it is still attached to the posterior wall.
No, it is attached to the fundus there.
Okay.
Posterior wall I have separated from. I will go in between that pseudocapsule and then you will see very well. Okay, now that's the pseudocapsule. This is something called as opium. All my ticks and trips are coming true here. Okay, so this is something called as preparation. Can you see the fibroid now? See, this is the entire fibroid.
Yes, sir.
This round thing.
Yes, sir.
Okay, so next time when she comes for, suppose if she is not coming out completely, mostly I will finish it now only, but if suppose it doesn't come out, then I will do it in the next sitting. It will be much inside. Okay, you leave her like this by giving deep cut. Patient is awake, so we can leave her. See that? Can you see the difference now? Now you can see very well that myoma differentiation. Can you see? And look at that. It's coming. Are you able to understand? See?
Yes, sir, yes.
Look at the fibroid now.
Yes, sir.
Well, type 3. It was just touching the endometrium. This was the actually band of adhesion, and the fibroid was behind it. Actually, it's a very interesting case. So rarely you get to see two pathologies combined, and then one pathology generally, does not allow you to. So that is what we call it diagnostic dilemma. Now see this, it's coming out. I'm enucleating the fibroid just with the use of one instrument, okay? Yeah, we can do IBS now.
Sir, how can we
You want to see?
decide that we will be able to remove it hysteroscopically?
I will be so basically how will you decide that?
Here,
Okay.
intraoperatively. sir.
Intraoperatively. Now see, I am going in the pseudocapsule and showing you. Now that's the end of the fibroid. Can you see? Can you see?
Yes,
the
sir, yes.
nice pink endometrium, myometrium there?
Myometrium we can see.
Yeah, and a supple. You see, it's soft, very nice. I can feel it. You guys can't.
No,
I'm at the
we are
base.
able to
So when I see the base coming inside, I can easily dissect it. Okay, can you see now?
Yes.
Now you see how fibroid is inside. So I have made the fibroid in the cavity. Now I will go with the resectoscope. This is a resectoscope ले लेंगे. And I will resect it out. Suction on, please, suction. Sorry. For this case. Okay.
Dr. Harish, can we
Yeah.
use IBS in this case with this?
You want to use IBS and see? IBS is ready? I can show IBS also, ma'am. Whatever audience wants to see. Take a poll. I myself will prefer resectoscope. I will tell you that is why I prefer resectoscope. Okay? ठीक है ना, ले लेंगे IBS चाहिए. What do you want?
Yes,
You want
IBS.
IBS or what?
IBS.
Okay,
Okay, IBS.
They are fascinated by this instrument now.
So दोनों connect करना पड़ेगा. Okay, so I will have to change everything now. Light off, please. Now, okay, so basically what is the take on endometrium damage? What you are saying, right? Is that's the question here. Now see, ma'am, suppose I get cataract in my eye. Okay? You have to operate on my fingers or eyes? Eyes, right? Patient has a pathology. Now this is like, you eat samosas and what not, what all things you eat, and then the patient comes and say, ma'am, ये tablet की कोई side effect तो नहीं है. It's like that. Now the damage on endometrium is not much compared to the pathology causing her harm. This pathology has led her abortion. It is causing her artificial arcuate uterus, and implantation on the fibroid led to all that adhesion, abnormal endometrium, all that. God forbid if she would have had Asherman now and complete fibrotic endometrium, she would have lost all chances of becoming. So the pathology is more harming than your surgery. Now we are going to operate only in the fundus part, not rest of the endometrium. So the damage is not more than 15% of endometrium, which is really acceptable. So, and secondly, you are doing a clean surgery. You are removing the pathology, doing a clean surgery. It's not a procedure wherein you have pregnancy left inside or some bits of placenta or some bits of fetal part will remain. So there is no chance of infection. So she will have fantastic result. You got the answer, ma'am? कैसे हो? ठीक हो ना आप? Fibroid, light, light, stand by करना भाई. Okay, what is it? No, DNC, no? Because of fibroid, ma'am. So the bleeding, see now how it is. Bleeding, of course, because there is going to be bleeding because she has fibroid there. Fibroid is going to have a lot of vascularity. So these are the complications which can happen and give problem. Are you seeing the assembly of this? Light दिखाओ. ये light ऊपर की light करो, दिखाओ assembly. ये दिखाओ ना. Are you seeing the assembly of the shaver? Shaver लगेगा. है आ गया? No, बड़ा वाला लेंगे ना, ये छोटा है. हाँ, yes, okay. So now, washer होगा इसका सिस्टम. क्रीम कलर, आइवरी कलर का washer होगा. है ना? है ना washer? तो उसमें होगा, देखो ना. आपको तकलीफ नहीं है ना कुछ? ऐसे कुछ नहीं करके बहुत कुछ कर लेते सर हम.
This patient is awake. Patient is not under anesthesia.
No. This is our office. You want to see her face?
We have used local anesthesia.
No, ma'am, nothing at all.
Nothing only at all. Vocal. Only vocal.
Only talk to her nicely. नहीं 10 mm नहीं लगेगा इसको, 3 mm लगेगा. 3 mm कहाँ गया पर? वो कहाँ गया? बहुत लीक कर जाएगा सिस्टर. ये चल जाएगा, चलो. एंड फुली लग गया. कहाँ गया वो? हाँ, लैप्रोस्कोपी का ही है, सेम. जानबूझ के बनाया.
नहीं दिया ना.
ओके, चलो लेट्स स्टार्ट द.
if you are doing office hysteroscopy, you do
Yeah.
not even call the anesthetist, or you keep him
Ma'am,
standby?
I do it at Nova, ART, Indira, IVF, all these places they keep 10 patients, and even if there is SOS, we do not call anesthetist, we call only if we fail.
Only?
If we fail.
If we fail. But then the anesthetist will take a lot of time to come.
No, ma'am, I run away. They call whenever they call. Later on, the patient comes. We tell the patient that see this procedure is free of charge, and you need anesthesia. Everything is told to the patient beforehand, ma'am. That if this is a possibility. You get my point, ma'am?
So what are the what is the pre-medication used in that case, sir?
Which case?
Sir, for office hysteroscopy and especially operative.
Pre-medication?
Yes.
Nothing, zero. Only bromoxine and sometimes we put in misoprost if the patient has a big pathology like large polyp or something like that. Okay, so now you can see 1 minute. Hands दिखाना कैसे काम करते हो.
So not even any Buscopan or something?
No. Post-operatively, if we put this one, what do you call? Post-operatively, if we put a balloon, then yes. Then I definitely put in. Okay, you got it? Then I definitely give protein or Buscopan.
So we need to see the camera.
Yeah, okay. Can you show here, camera? Now the problem is that if you see camera, you will not see the internal view. But you see camera for a while. You see how am I operating?
Right.
You can show me completely, like I'm comfortable, right?
Yeah.
So you see how I was operating here with my fingers. Now when you bring it to the hands, the skill level is reduced, right? Suppose for example you write with your finger, you will write very small handwriting, but write with the hand, it will be big, no?
Crude.
So the skill required in writing with finger is much higher. So this one is a lame procedure. It is for those who are beginners and don't want to learn conventional hysteroscopy. Okay?
The scope in this is 0 degree in the shaver.
Sorry, ma'am. No, ma'am.
30 degrees.
Yeah. ये 80, 100 कर. Now see there is a clot here. एक मिनट ये ना अभी इसको वहाँ चला जाएगा टिश्यू सब. उसको एक बकेट रख दो ना.
No, sir, can we see the inside view now?
Yeah, inside view now. Now see there is lot of debris, lot of clot, and I am just sucking the clots. Can you see? Now, निकाल लिया? कहाँ रख दिया? हाँ पक्का ना उसमें हमको टिश्यू चाहिए. When? Generally doesn't know, dear. It's under vision, right? You will see, ma'am. Hello.
Yes, we can follow you.
Now
sir.
you will see the fibroid so well. Can you see?
Yes.
So this is I call opium. Okay, it is not my study. It is Batocki's study. Opium is office preparation of partially intramural myomas. So you do office hysteroscopy and bring out the fibroid like this, okay, which was type 1 and type 2 or type 3, and now see, it's a very easy simple procedure. Now it will eat it up. This monster will eat up this laddu so easily. Can you see now? Partly
Yes.
is gone. Okay, so you go inside, bring it out.
Have you encountered any bleeding which happens during
So ma'am, it's very easy. This set also comes with a bipolar 3 millimeter.
Okay.
So things are so good, no ma'am. Believe me, if you have money, this Ferrari must be bought. And the advantage is, if somebody has morsolator set and somebody has an orthopedic friend, then this instrument becomes so cheap because they will use this shaver, same shaver for arthroscopy. आप ठीक है ना? No, not enjoying, but well, I would not say enjoy, but yeah, this is degenerated fibroid. Can you see? And it's quite deep, okay? Quite deep. Look at that. That's the end of the myoma. वो बाइपोलर इसका डालना अंदर भाई. ओ भैया, बाइपोलर इसके साथ में है, इसके साथ में है. नहीं सिस्टर को बोल, नहीं आपके इसमें, आपके बैग में एक बाइपोलर है इसका, वो डालो ना. So I can show them, you know. This one, no, we'll just change. Faster, much faster. That's why I said I don't prefer this, because for me it's like I would have finished the section now. इससे वो दूसरा प्लेट दे दो, ये रहने दो, because this is going in both the direction. No, 6 mm I was using, which is not very effective in this case. Yes, उसका केबल भी है ना, केबल तो बाहर ही रखो. पर यस मैम, पानी खत्म हो रहा है, देखो ध्यान दो थोड़ा उधर. नहीं है, अभी है. See, right now, till now, in the entire enucleation and till now, we have used only about 2.5 liter. Okay? So efficiency is very important. Yeah, we did adhesive lysis, we did RPOCs, we did lot of things. Partially myoma is gone. You see now? You see beautifully.
Visible. You can see the bed.
The only problem with this is that the blades are quite expensive. So before buying in, you must because see, if they start rusting, then they don't work very well. So always maintenance is very important part of any equipment that you buy, any major big equipment or things that you buy. You must realize that. It's working, it's working. Okay, it's gone. See that? This is how it removes all the tissue. You see, all the tissues are going inside. Okay, there is some user here. Okay, so see these bleeders. Can you see the bleeders? I will show you how to control it. Okay. Is she alright? The water is over. Water is getting over. Change किया? किया? Oh, thank you so much. बस इसके बाद हम कैलकुलेट करेंगे, हाँ, और नहीं लगाएंगे नया वाला, because it's quite big. quite a big. Okay, see this. Now the rest of the part, you want to see how to remove it. You can take a instrument and remove it also. Sorry. So the machine said I have lost my this thing because I got kinked. So these machines are quite smart that way. See that? In about 2-3 minutes we will be done. Huh? This myoma is gone completely. Alright, it's over. Can you see now? Beautiful. Look at that myometrium. That's the last bit. Yes. It's for us, the hello. Yes. Now you can't see anything because of the bleeding. Okay. So I will show you now how to see, how to go. Bipolar ले लो, sister. ले लिया? Yes. Okay, it's over. Only a small bit is remaining here. This one. Suppose now if patient starts bleeding and you have no bipolar, what will you do?
Tamponade?
Very good. How will you do that? Just like how you do in obstetrics.
Okay.
Right?
Just Foley catheter or you put condom also on it?
No, you can just put a Foley's catheter, ma'am. But then you use not use small one. Don't use pediatric. Use a 12 or 14.
Okay. And 30 to 40 cc. How much of balloon should be inflated?
Yeah, so then what happens is you don't knot the catheter. हाँ बंद करो, ये खोलो, ये खोलो. हाँ और वहाँ पे प्रेशर दो अभी. चलो. इसमें. Give. So then you put in a 12 French catheter, okay? 12 size Foley's. Oh.
And how much saline?
And ये छोटा वाला ये leak होगा. And then you use about 12 millimeter. Sorry, about pressure दो. खोलो ना, खोलो खोलो. हाँ. वो पूरा निकालो ना उसको. There is no water coming in. खोलो ना, वो निकालो. वहाँ से हाँ वहाँ से खुलेगा. हाँ हाँ 1 मिनट. हाँ बस सॉरी मैम. हाँ मैम करा सकते हैं फिल्टर. बस अभी नहीं देना. इसलिए गॉस पीस चाहिए, खत्म हो जाएगा पानी तुरंत. ये आपका वॉशर का ध्यान रखो. हाँ ऐसे मत करो. Okay, now can you see the cavity?
Yeah, sir.
Yeah, so my bipolar is coming in and I will see for the bleeders. Okay, that's where the bleeder is. ये भाई bipolar लाओ, आपका लगाओ bipolar. ये है क्या? हाँ वही.
How much pressure are you using right now, sir?
So right now I am using 120 pressure to see the and then to see the blood vessel. थोड़ा बढ़ाओ ना, बाइपोलर चल नहीं रहा है. हाँ बढ़ाओ ना. So to see the bleeders, then I would just this is just for the demonstration. She doesn't have bleeding. हाँ बढ़ाओ 100 करो. Yeah, okay, perfect. Okay. There is some issue, it's not working. But generally, this is how you stop the bleeding. There is not much bleeding now. Okay, so you can see that the pressure now is 100. And I will show you with the speculum that there is not much bleeding. Okay, just see the vision here. But generally, it works very well. Okay.
So when you put in a balloon tamponade, sir, how much of saline do you instill in that fully?
Yeah, so generally what you do is about 5 to 7 milliliter, because there is a big cave of fibroid which will take lot of space. Okay, so you do not put 3 cc, you put 5 to 7 cc depending upon the size of the fibroid. If the fibroid is less than 3 centimeter, put 5 cc. If the fibroid is more than 3 centimeter, up to 5 centimeter, you will try, right? So 5-6 centimeter fibroid, then you put 7 ml and keep the catheter open.
So that you can see the bleeding if it is
Yes,
happening.
mostly there will be nothing. And after 4 hours, first do not remove the catheter. Hold the catheter at the cervix, push it inside little, and then remove the fluid slowly. So you will come to know that there is bleeding or no. Most of the time, all the cases that I have done are virgin women, girls, and they have no problem. Most of the time they stop bleeding after 2-3 hours. Now see the speculum. I will show you. Speculum है? हाँ दिखाइए इधर. हाँ ये छोड़ दीजिए. There is no bleeding. Can you see?
Yes, sir. No bleeding.
There is no bleeding at all. Okay. All right. So there is no bleeding. So we'll leave her alone. Thank you so much.
It was a very fantastic.
Yeah, this was a nice case. Yes, you saw renucleation, you saw excision of adhesion, you saw everything in this case. The only problem is that it comes out as a keema. So for Lucknow people who are eating galotis, it is quite okay, but for Mumbai people, it's quite not good. So this is another disadvantage. I don't like it. It's like absolute, like you can show them. You see how it is. दिखाओ सिस्टम. कैमरा यहीं पे है. शिफ्ट किया गया. ठीक है. It's okay. Open this.
नहीं रुकेंगे. Vishali, can you hear me? Is anyone in the OT?
Hello.
There is no one in the hall, Vishali. Where is Sonu? What is next over here?
Hello.
Yes, Vishali.
Yeah, we are ready with the next case. Sir is coming in a moment. And
What is
so
the
this
next
patient
case?
is a 33-year female. She had a history of 2 spontaneous abortion and had a DNC 4 years and 2 years back. And her HSG showed a space occupying lesion, and even her ultrasound was like showing query partial septum. So she is being planned for hysteroscopy. We are suspecting partial septum in this patient. So we have 2 more cases to show. One is like infertility in which we can show you the PRP, and another one is a polyp. So sir is here and he's ready.
Hello.
Yes.
Hello, sir.
Yeah, hello.
Yeah.
Sir, delegates over here want to meet you, and sir, how many more cases are left? Dr. Vaishali, how many cases
2
are
cases more, but they are very small. One is infertility. We will say ask sir to be fast. He is usually fast, but he is talking.
Exactly.
He's like describing all the things, so we'll be asking him to be.
So if there is any repetition, then Dr. Vaishali can take over the case, and we can have discussion with sir in the hall here after this case, or maybe another one. So this is the case we were waiting, the septum case. Haresh sir? Haresh sir, can you hear us? Oh, why?
Hello?
Hello, sir is there?
Sir is there?
No, but we can't hear sir.
Okay, please see the mic. You are able to hear me?
Yeah, very clear and loud.
Sir.
Yeah.
Hello. Now see, is it subseptum? What do you see?
Sir, it appears maybe some
So
adhesion
there is
band.
a, yes, so this patient has abortions because of incompetent os. Okay, can you see the os here?
Yes, sir. Yes.
So big, can you see? Not a single case so far you have seen so big os. You see?
Sir, again your voice has gone.
Again.
We can't hear you,
Ah.
sir.
So you see the os is quite
Yes.
big, okay?
Yes, sir. Yes.
Now the problem is, sorry Vaishali ma'am, she has to hold with the mic. Now the cavity if you see is not very nicely distended because of the, can you hear me now?
Yes, sir. Yes, sir.
The cavity is also not very nicely distended. You see? Can you see? It is not distended well.
Yes, yes.
That's because of internal os being
It is
very
more like, yeah.
patulous. So she will definitely require circlage. So please write her down that this patient will definitely require circlage when she gets pregnant. That is first thing. And we'll also remove this. Now this particular band of adhesion is just like so ma'am, this is a chronic adhesion and no, it is fibrous, I'll tell you. This is type 3 adhesion and it's got epithelialized also. You will see now. Okay, so you will see inside ma'am. Okay, you will easily see. Now see when I cut. Can you see now, ma'am? ऊपर epithelium आ गया है. Something like that. Like previous case, I did endometrium removal, and then you will see the fibrotic part here. And it is type 3 fibrotic adhesion. Type 3 is with vascularity. Can you see the vascularity here? See this?
So how do you differentiate whether this is septum or this is a adhesion
Oh,
band?
well, that's what I'm saying. Can you see there is a space here connecting the fundus? A septum can never be in the center. Are you getting my point? You see
Now we
here,
got it.
there is
Now
a
we got it.
space.
It will come from the
Wait a
fundus.
minute, just a
Ah.
minute, I will show you. Once we cut this now, you will see fundus intact. Means you will see endometrium there also. Are you understanding?
Got it, got it.
Yeah, very good. Thank you so much. Now see ma'am, how much fibrosis is there? Can you see? This is also fibrosis, but there is vascularity, so it's fine. So you go and flush to the endometrium posteriorly first. Take whole chunk of adhesion band because it is physically present. It is not adhesion of two walls, just wall to wall. There is a band of adhesion and which you need to physically remove it out. And you will see ma'am the fundus now. Right now I am cutting from posterior wall and then I will go on the anterior wall. So central part will come out. You will see I am going slowly because I want you guys to see and notice how on the first look I found that this is adhesion band and not the, see, there is endometrium behind. Can you see now?
Yes, yes.
See. Wait, huh? See. Okay? See that. Now adhesion band you can see very clearly in the center and the endometrium here behind is quite nice, you see. So now you see the bump on the top wall and bump here, both of them will come out. This is endometrial bump. Just checking if there is any abnormality. There is nothing, okay? This is all normal. Only I have to remove is this bump. Yes, and you will see So this patient I will require a balloon. Why? Because there are exactly mirror image of two adhesion, two raw area
Yes,
with loss of basal layer, right?
Yeah, sir.
So now see. Look at that. Okay, see, it's coming out. It's okay, ma'am, don't worry. We don't need it. Nothing will come. No, no. We don't make pathologists rich. We diagnose pathology here. Don't send too much of material for. See now? Do you see? This is the endometrium intact. So there is no, she doesn't have subseptum. However, you want to check, you can still check by giving some cuts there. There is no harm in that. Okay? There is nothing there, ma'am, in the fundus. Fundus is absolutely okay. Okay? No fibrosis, normal endometrium. Can you see the pink material? Can you see?
Yes,
and it's bleeding also. Okay, so there is nothing in the fundus. Only this was there.
So it was just.
She will conceive, ma'am.
adhesion.
Very nicely, no problem. Just do her. Fantastic. Okay,
Thank
you so
sir.
much.
Thank you, sir.
I will see you there.
It was really wonderful to watch you since morning.
Thank you so much.
So
you guys are
many
really patient.
cases
Yeah,
wonderfully
okay. We'll see,
demonstrated.
No, one more patient is there. What is that? Okay. Yeah. Okay, oh, PRP. So there is one PRP, okay? For poor endometrium. So we'll have a good... पुलिस डालेंगे ये वहाँ ले लेंगे फिर ऐसे ही ले लो बाद में ऐसे ही दे देना वहाँ से ये भी उसमें मत डालो इधर ही रखो आपका फ़ोन है
Hello.
Hello.
Yeah, this is the final patient. She has been waiting since morning. So,
Swamiji is here and he watched the last surgery of sir also. Haresh sir. Okay, I think he is not around.
Hello.
Hello. Dr. Vishali.
Hello.
Hello, sir.
Yeah.
Sir, your last case was witnessed by Swami sir also.
Oh, wow.
Swami
That is
sir
great.
was here. He was
Such an
watching
honor. Oh,
your
okay.
surgery.
Great, great.
Yeah.
Thank you so much.
Hello.
So she is para 0+2.
Hello.
Secondary infertility with fibroid uterus.
Dr. Vishali.
हाँ.
Swamiji wants to say something.
अच्छा, okay. We are listening. Yes, sir.
Hello.
जी, sir.
It was a very wonderful presentation.
Yeah.
Very wonderfully seen here. And all credit goes to you and the doctor for very nicely demonstrating and explaining. The video presentation was also very good. My hearty the congratulations to
Thank
the
you,
entire
thank you
team.
so much, sir. Thank you very much.
Very good, very well done. Thank you.
Swamiji. Thank you.
Congratulations.
Thanks.
Hello. I request Dr. Akansha, IV specialist from, to felicitate our chairpersons. Ma'am, please come on the dais. Dr. Smriti ma'am, Radhika ma'am, Sarika ma'am, and Pushpa Jaiswal ma'am.
Dr. Akanksha is gynec endoscopic surgeon in Hind Medical College, and I request her to felicitate Dr. Smriti Agarwal. Ma'am is HOD in the Department of Ops in Gynae at RML Hospital, Lucknow. RML Institute of Medical Sciences is different. Yeah. I request Dr. Sarika Purwar ma'am to felicitate our next chairperson, Dr. Pushpa. Ma'am is very senior and renowned gynecologist in Lucknow and director of Sri Ram Hospital. And now I request Sumita ma'am to felicitate Dr. Radhika, who is a fertility consultant in Birla IVF. And Sumita ma'am, everybody knows Sumita ma'am is a renowned and very good endoscopic surgeon. We all get so much inspired by ma'am.
Sorry.
And I request Dr. Sarika Purwar. She is also chairperson in this session. Just now she told me. No, she ma'am is there. Actually, she doesn't recognize, I think. No, you should recognize your seniors.
देख नहीं रहे ना.
And I will be felicitating ma'am.
देख ध्यान रखो उधर. देखना नहीं चाहिए उसने. वो देख नहीं रहा ना उसे. ये ले लो, ये शीट ले लो बाहर.
थोड़ी सा बंद कर देंगे.
बस ठीक है. रख दो. कभी भी ना स्कोप आप देंगे ना, तो ये नहीं दिया ना तो स्कोप डैमेज हो जाएगा, आपका डेमो बंद हो जाएगा. हाँ, पर तो क्या करना है, एक जन को ग्लव्स डाल देना, क्योंकि ये क्या सीधा डेमो बंद हो जाएगा अपना. हाँ पूरा ना. यस नहीं अभी करेंगे ना, पहले ही, बिफोर दैट. चालू करने शुरू करने के पहले ही बोल देता हूँ. दे दे निकाल. बराबर है. परफेक्ट. सारी बंद कर देना. ये मेरा है, ये स्टोर्स का है. ये स्टोर्स, ये स्टोर्स नहीं स्टोर्स का है, ये सब स्टोर्स का है. ओके. स्कोप 2 लूप, उसका ऑपरेटर ये और शीट, और ये सिर्फ मेरा है. 4 चीज़ मैं बाद में लेता हूँ. चलो. No, don't worry. Don't. वो नहीं चलेगा सेक्शन नीचे वाला कर रहे. ये ऊपर ले लेंगे प्लीज. थैंक यू वेरी मच.
Everybody is appreciating Neelam ma'am standing over there. Neelam ma'am, she is the senior most among us here. Neelam ma'am, everybody is, yeah ma'am, saying hello to you.
वो नीचे. Yeah, we'll decide, yeah. So if she doesn't want to, then it's good for patient. But if she has to, then it's not good. It's good for audience. Yeah. Hello? Am I audible?
If you are able to hear us, hello?
Yes, sir. Audible.
Hello?
Yes, ma'am. Camera.
Hello?
Hello?
Yes, sir. Audible.
Okay.
But can they hear me?
If you are able to hear, sir?
Hello? Hello?
Yes,
No.
sir. Yes. Hello.
They are? Okay.
Yes, audible, sir.
Alright, okay, great. Thank you so much. Bas. Thank you, sister. So nice. So we are so much grateful to Carlstros for giving their Rubina, one of the latest system here, and the vision was phenomenally great. But some technical glitch which was there, of course, but any technical glitch like that can happen. Only thing the problem was because of the incompatibility of the cables, okay? So we have 4K, no, this is not 4K, yeah, 4K. Rubina is 4K, 3D, but we are only using the 2D right now, and of course because we don't have hysteroscope right now, as of now, in 3D. So that one I was using with the Carlstros LED light, and you can see that you saw already multiple times you saw Endomet Select, with which we did all the cases very efficiently, especially the shaving, right? And to support this we have a bipolar generator of Combimax from none other than Alan, which is having all compatible things, and one of the best generator. I do almost all cases with Alan. Water. Start. Please. Is it open? Yeah, that's fine. Screen. Are you having an internal picture? Okay, this is very good. You can see the vaginal lesion of candidiasis. I want to show them how candidiasis
We are
looks.
seeing half above and nothing clearly. It is in between.
Now is it there? No?
Nothing is properly focused.
Focus करिए उसको अच्छे से.
Yeah, yeah. Now we can see.
Camera zoom.
Yeah, yeah. Yes, yes, yes.
थोड़े lights off कर दीजिए please. Can you see this lesion as a candidiasis?
Yes, sir. Yes.
See these lesions here on the cervix.
Yes.
Okay, this is candidiasis. All these lesions, can you see this? And you see red lesions also. A typical candidiasis, can you see that? So she definitely requires a treatment, please. So please write it down in the paper. Give her oral also. Okay, now you can see the adhesion there, and this is the false passage. Yeah, you can see that. There's the false passage here, and this is the actual passage. Caesar. है यहाँ पे आएगी ना ग्रास पर देना सीजर लेनी पड़ेगी सीजर ले लीजिए हाँ ले
So we are watching everything, false passage and.
Yeah, that's what. Generally, most of the time, what happens, ma'am, when so many people assemble, God also takes care of them. Yeah, we do half of the things and rest of the things He does. Not even half actually, we do only 10%. So sometimes when I tell the people, they say, okay, so we organize, we are not getting enough cases. I say, you just organize. Because so many people are there, God takes care.
Yeah, even we were not expecting.
And God also wants the patient to get benefited, okay? So He will send true patients, perfect patients. So many times in workshop I have done cases which are so rare, and I surprised. Then I got an answer after. Swamiji will understand much better if Swamiji is there.
No, he has gone.
Okay, okay. So you see, this is how you nullify the false passage by removing the angle. Okay. So you remove that, and it's become a part of cervix now. Till you keep a niche, it is going to remain a. Okay, see? Gone. So what you have to do is blunting of the angle between the false passage and the real passage. Inside also you see the adhesions. Can you see cat eye? Yes. Cat's eye sign. Okay, you can see two eyes of the cat. So this is because of the adhesions, and this patient after this particular correction will surely develop good endometrium. But let's see, if we find that there is sclerosis of endometrium, then yes, PRP might give some benefit to her. Again, doing one PRP randomly has no meaning. So there are micropolyps here. So with the grasper also equally good adhesiolysis can be done. So I am just holding the band, can you see? You see that's the band in between. I hold it and I twist it. So it breaks and it brings in my grasper, you see.
Sir, why you are not using scissor here?
Ma'am, scissor is just coming. We actually broke one scissor and there is only one scissor. So it takes some time for sterilization. Otherwise, yes, scissor is ideal. Is there? Scissor आगे चले लाइए. बंद करके हाँ यस बस ठीक है. There is a lot of fibrosis here. You can see white tissues, lot of underlying fibrosis.
Check.
Okay, so this is what atretic amenorrhea. Did she came with amenorrhea? No? Oligo? But she is menstruating very well because she has almost cribriform plate there. Can you see that? There is only a sort of a mesh there, almost block internal os completely with lot of fibrosis there. Now you can see some part open. First, what she has, that's the area, and this is fibrosis. You can see this white tissue is all fibrosis. Okay, this is at the internal os. There generally, whenever there is a lot of adhesion, the internal os is slightly long. It's not like one point. So you will see elongation and you can see now that's the area. I will see the probing now. What I started with the first case, you can see that's the probing. So that will give you an idea. So it's like this, ma'am. If you see the direction, it is acutely anteverted and towards her right. Yep. सक्शन ऑन है. ओह सक्शन चाहिए फिर. ठीक है, ओके, हो जाएगा क्लियर. बट सक्शन ऑन नहीं, वहाँ नहीं होगा. वहाँ पे नहीं होगा सक्शन ऑन. वो कनेक्ट करना पड़ेगा. सक्शन ऑन करेंगे, कनेक्ट करेंगे. सो इनसाइड इज सुपर्ब. हाँ, this is the fibrotic band which was seen in between. Can you see, ma'am? Nicely it is coming out, huh? All the fibrosis in the scissor. Yeah, endometrium is good. Is the suction on? On है? नहीं, on लगता नहीं है, but ठीक है. Endometrium is nice. Beautiful glands. वो ये लगा देना लेयर लॉक बस thank you. Yeah, see the endometrium, ma'am. Look at the cavity, there is not a single band of adhesion. It's a fantastic endometrium. Only because of cervix there is the issue. Most of these patients have a problem because of cervix. These fibrosis has come from cervix. During the, you can see the thread nicely. So most of the time whenever you see that the endometrium is not developing, the problem is mostly at the cervix, mostly. That's what is my observation. And there are micro polyps here. You can see that. So we'll try and see the endometrium now. And see, it's quite nice, supple, soft endometrium. And we'll see the gland regularity. It's nice. Only micro polyps, you see, right now exactly at the center here. So she will be good with antibiotic. Look at this. Graspa de do. You want a biopsy, ma'am? Yeah, okay. So generally what we do is we go like this, open the grasper and just push it inside, and the endometrium comes like that, you see, with micro polyps. Can you see in my grasper? The hole is closed, or is there? People are there? There? Gone for tea. Everybody's gone for tea? Maybe, looks like that. It's okay. That's all okay now. All these cases we have seen. These threads. Okay, so once we remove that, our job is done. We'll put in a catheter for her again. Foley's, yeah. So cavity is good. Whenever you write a note, you must mention that the cavity is conjuncta U0 in the case which we done metroplasty and polyp. Second case, you must write conjuncta U1C because it was Y-shaped cavity. Then the case previous to this we did here a myoma 1, just acquired conjuncta UC1 because of subseptum, looking like subseptum, but it was not subseptum. So it was conjuncta U0, there is normal cavity but with band adhesion. She'll do well, ma'am. Doxycycline will give her with स्पेक्युलम वल्सरम लगेगा बेटा. No. Which one? Second case polypectomy with this one, no? U1, U1C. You don't know this classification? No, don't say recent. 18 is not recent. और एक केस है ना वहाँ पे. आपके सिस्टम की तरह यहाँ की सिस्टम का. तो सीजर जो टूट गया वो किसकी थी? आपकी. ये हमारा सेट है क्या? हाँ, केयरफुल, आराम से. स्पेक्युलम वल्सरम सीजर नहीं, स्पेक्युलम वल्सरम सीजर. दे मुझे दे वो. तू लेके आ. स्पेक्युलम वल्सरम सीजर. बस हो गया. She is for IVF. Huh? So ask madam that when she removes this, after few days try a mock. Okay? Yeah. Once this will stay for 12 days to 15 days, whatever, how much she tolerates. Okay? I'm not going to inflate too much, so she will tolerate well. But if she delivers, it's good, because then the cervix will open up. In case if she doesn't deliver and you remove after 12 days, after 5-7 days of that, do a mock. So you will have a good idea. So you will have an idea that, and then you can plan next cycle. Of course, looking at her ET. Till then she can take doxy. 15 days till she is. Yes. She has to take. Okay? Silicone catheter. Silicone is rather better than that rubber. Latex से भी अच्छा है. Latex तो still has. Only thing is I have never put silicone because knotting property is not great. थोड़ा सा rubberize. इसको फाइबर इसको. The endometrium is nice, ma'am. Don't worry about anybody. Just transfer, she'll conceive. I'm pretty sure. Okay, buddy. Bye, Tadin. Thank you. राजा माइक ले लेगा. चल ठीक, तू ले. हाँ जी.
Very nicely performed surgery, sir. It was a great day for all of us sitting here to learn from you.
Thank you so much. Thank you.
Such difficult adhesions dealt with so nicely.
Hello.